Good morning. I'm Dr. Martin Kulldorff, the chair of the Advisory Committee on Immunization Practices. Today is June 25, 2025, and I'm pleased to call today's ACIP meeting to order. I wish you all welcome, and I thank you for being here. I want to thank both the voting and ex officio members and liaisons of the committee, who will shortly introduce themselves. I would also like to take this opportunity to thank the former committee members. Serving on this committee is a time-intensive and not always appreciated task. I also want to thank the devoted CDC researchers and staff who've done a great job of investigating these matters, assembling the experts, and putting together the agenda and presentation content. ACIP recommendations have an impact on the health and lives of Americans from infancy to old age. Nothing is more precious to those of us on this panel than our children and grandchildren. And likewise, we know they are nothing more important to parents than the health of their children. Our recommendations cover the lives of over 70 million mostly healthy children. Secretary Kennedy has given this committee a clear mandate to use evidence-based medicine when making vaccine recommendations, and that is what we will do. Vaccines are not all good or bad. If you think that all vaccines are safe and effective and want them all, or if you think that all vaccines are dangerous and don't want any of them, then you don't have much use for us. You already know what you want. But if you wish to know which vaccines are suitable for you and your children, and at what ages, then we will provide you with evidence-based recommendations. I'm very glad that there's so much interest in the work of this committee. And I want to especially welcome members of the public with us today remotely. It is wonderful that you take an interest in vaccines, medicine, and science. If you have questions or concerns about the safety or efficacy of vaccines, we want to hear them. That is the scientific method, and it is natural to ask questions. That is what the CDC subject matter experts do. It's what the public does, and it is what we will do. No questions should be off limits. Some media outlets have been very harsh on the new members of this committee, issuing false accusations and making concerted efforts to put scientists in either a pro or anti-vaccine box. Such labels undermine critical scientific inquiry, and it further feeds the flames of vaccine hesitancy. As Secretary Kennedy has eloquently stated, opposing mercury in fish does not make you anti-fish, and opposing mercury in vaccines does not make you anti-vaccine. In fact, to thoroughly scrutinize and ensure the safety and efficacy of vaccines is a pro-vaccine position, just like the promotion of aviation safety is a pro-airline position. Millions of Americans board an airplane each day. While airlines fiercely compete when it comes to schedules, ticket pricing, and service, there is one thing they collaborate very closely on, and that is safety. If one airline ignores safety concerns or has a plane crash, that affects the public trust in and willingness to travel with all other airlines. The same is true for vaccines. When there are unexpected adverse reactions, or when concern are concerning the safety of one vaccine, that affects all other vaccines, reducing vaccine uptake and coverage. Rebuilding public trust through sound science is very important. For example, the inflated promises about the COVID vaccines preventing transmission and disease and COVID vaccine mandates have decreased overall public trust in vaccines. Messages stemming from evidence-based science on the safety and efficacy of vaccines is in the best interest of the public, industry, and public health institutions. Lastly, I wish to address my fellow scientists in the audience. It is no secret to anyone in this room that confidence in public health institutions, including CDC, FDA, NIH, and university leadership, fell during the pandemic, and that it is at an all-time low. Most scientists are honestly seeking the truth in their research, and that includes scientists here at CDC. We must work to rebuild integrity and trust, and we do that by honestly recognizing past mistakes, adhering to evidence-based medicine, and encouraging open scientific discourse, as uncomfortable as that may be. I hope you will join me in this quest. I will now turn it over to the ACIP Executive Secretary. Please, Mina.
Thank you, Dr. Kuldorf. Good morning, everyone. I'm Dr. Mina Zadeh, and I'm serving as the designated federal officer for the Advisory Committee on Immunization Practices. Welcome to the June 25th to 26th, 2025 ACIP meeting. Before introducing our new ACIP members and conducting roll call, I'd like to review a few procedural items. Presentation slides are or will soon be available on the ACIP website. For those participating remotely, please remain muted unless called upon. Use the raise hand feature to request recognition during discussion. Questions will be taken from voting members and ex officios, followed by liaison representatives as time permits. Please keep your video off. Profile images are acceptable. Next slide, please. The Advisory Committee on Immunization Practices is a public advisory body, and engagement with the public and transparency in our processes are central to the committee's work. For this meeting, we will be holding 2 oral public comment periods. The first will be held today at 4:15 p.m. Eastern Time. The second will be held tomorrow, June 26th, at approximately 11:30 a.m. Eastern Time. To create a fairer and more efficient process for requesting to make an oral comment, we ask those interested to submit a request online in advance of the meeting. We give priority to advance requests, and if there are more requests than can be accommodated in the allotted time, we select speakers through a blinded lottery. The 30 speakers selected by lottery for this meeting have already been notified. We thank all those who requested an opportunity to make a public comment. Members of the public also had the opportunity to submit written public comments on issues via regulations.gov. The docket number for today's meeting is ID CDC 2025-0024. More information on the public comment process can be found on the ACIP meeting website. Next slide, please. As outlined on the ACIP Policies and Procedures Manual, members agree to refrain from certain vaccine-related activities while serving on the committee. CDC may grant limited conflict of interest waivers for activities that support a member's expertise. Members who conduct vaccine clinical trials or serve on data safety monitoring boards may present on those topics, but are prohibited from voting on related issues. If a member has an association with a company's vaccine, they may participate in discussion, but must abstain from all votes concerning that company's vaccines. At the start of each meeting, members are asked to declare any relevant conflicts of interest. Next, I'd like to welcome our new ACIP members. Please introduce yourselves briefly and describe your background and disclose any conflicts relevant to this meeting. And if you don't have any conflicts, please state that you don't have any conflicts. I'll start with our chair, Dr. Martin Kuldorf.
Thank you so much, Dr. Zadeh. So I'm Martin Kuldorf. I have worked on vaccine safety for over 20 years. I have been very closely involved with the CDC's Vaccine City Data Link and the FDA Sentinel initiative, helping developing their vaccine safety surveillance and monitoring program. I used to be a professor of medicine at Harvard University and at Harvard's Brigham and Women's Hospitals until I was fired. I did not take the COVID vaccine because I already had immunity, superior immunity from having had COVID. And I was astonished that universities threw away 2,500 years of knowledge about infection-acquired immunity when they very unscientifically and unethically fired people for not having taken the COVID vaccine. I used to serve on 2 work groups under ACIP in the past. One was for the COVID-19 vaccine safety, but I was removed from that committee because I objected to the pause of the J&J vaccines. There were reports of blood clots in young women, so it made sense not to give them the vaccine, but I objected to the pause of older Americans because there was a shortage of vaccines and people were dying. So I think that pause of the J&J vaccine was inappropriate, and actually I think some Americans died because of it. So in that case, I was, I guess, the most pro-vaccine person among vaccine scientists in this country. So it's kind of a little bit ridiculous that then the media says that I am anti-vaccine. So, but that is as it is. So please, next person. Oh yeah, during my work with vaccines, I've never accepted any money from pharmaceutical companies manufacturing vaccines. And I don't have any conflict of interest with any of the topics of today's meeting.
Thank you. We'll do it in alphabetical order. Dr. Hiblin.
I'm Joseph Hiblin, and I was a commissioned officer in the United States Public Health Service for 30 years and have dedicated myself both as a physician and an intramural scientist to the best quality of science, and I am absolutely honored to participate in this tremendous public health endeavor of protecting our infants, our mothers, ourselves, and the world from deadly viruses that we don't always understand. I am honored by the intellect and the capacity of my fellow committee members. I am currently a distinguished visiting professor at the University of Bristol, and I have approached this committee and these issues with a neutral scientific mind, completely evaluating the data presented to us to make the best decisions for public health, and I have no conflicts of interest. Thank you.
Thank you, Dr. Levy.
So, hi, good morning, everybody. I'm Retzef Levy. I'm serving on the faculty of MIT since 2006. I have a PhD in operations research from Cornell University, and my research is focused on the use of data, advanced analytics, and modeling to inform and optimize risk-benefit decisions and system design and operations. And much of my research over the years have been focused on human health. Specifically, I have over 19 years of working in healthcare systems, very closely with clinicians. I've done work on safety and quality in manufacturing of biologics, developed epidemiological models, post-marketing drug and safety surveillance models. I also have work on issues related to water and food and agriculture systems that also have a major impact on human health. And I also have been involved in work on the COVID-19 vaccines. I'm delighted, honored, and humbled to be here today. And I look forward to working with my colleagues on the committee and with the CDC staff members and others on the very, very important issues that are in front of us, and hopefully together learn what the data and the evidence and the science are telling us about the best recommendations for the public in the US and beyond, and looking forward for hard work. I don't have any conflict of interest with respect to the issues that will be discussed in the coming meeting.
Thank you. Dr. Malone?
My name is Robert Malone. I'm a Maryland licensed physician and scientist. I have been secret cleared by the U.S. Department of Defense, extensively vetted. I've now been through 3 months of vetting and training regarding COI with HHS. I have no conflicts of interest. Any potential conflicts of interest have been analyzed and vetted and declared lacking, both internally by HHS and specifically by CDC. My relevant background is that I've been working in virology, immunology, molecular biology, pathology since 1983, beginning in a laboratory focused on retroviruses and intimately involved in initial findings relating to what we now call HIV. I've worked in academia to associate professor, most recently at the Uniformed Services University of Health Sciences in DC. I've worked for the government at length, particularly with Defense Threat Reduction Agency and in the biodefense space, including the prime systems contractor, Dynport Vaccine Company, that had responsibility for virtually all DoD-related vaccines and threat mitigations for biowarfare agents. I've worked for ARIS Global TB Vaccine Foundation in tuberculosis vaccine development, which is a Bill and Melinda Gates funded non-governmental organization. I've worked in industry, in regulatory affairs. I'm an expert in clinical research, regulatory affairs, project management, and contracting with extensive government experience, particularly with Defense Threat Reduction Agency. Regarding specifically vaccines, my experiences included influenza, seasonal and pandemic vaccine development, including a senior management position at Solvay Vaccines, managing a $300+ million contract for cell-based influenza. I've been an invited speaker at the World Health Organization to lecture on novel influenza vaccine manufacturing technology. I have experience in HIV, anthrax, plague, tuberculosis, and virtually all of the classical biodefense-related vaccine products that are currently in the pipeline. My core competence, again, is in virology, immunology, pathology. I taught pathology for many years in academia, molecular biology, and in particular, polynucleotide delivery. Thank you.
Thank you. We'll go to Dr. Pagano, and then afterwards we'll go to our online members.
Good morning. I'm James Pagano, a retired emergency physician with over 40 years of experience in patient care and department management. I chose that specialty, which was brand new at the time, because it offered me the chance to provide expert care to the entire spectrum of the patient population, from infants to the elderly, regardless of their background, regardless of their ability to pay, when they needed that care most, in an emergency, and often under difficult circumstances. This is the perspective and mindset I bring to this committee. I'm honored to be here. I have no conflicts.
Thank you. Dr. Meisner, I think we have to unmute for him to be able to speak. think we have to unmute
Yes,
him to be able to speak.
yes, thank you, Mina. And I hope that everyone can hear me.
Yes, we can hear you.
Thank you. I welcome everybody, those online and who are listening to this meeting. And
I think we have to unmute
yes,
him to be able to speak.
yes, thank you, Mina. And I hope that everyone can hear me.
Yes, we can hear you.
Thank you. I welcome everybody, those online and who are listening to this meeting. And yes,
To be able to speak.
okay. Yes, thank you, Mina. I'm not sure,
I hope that
Mina,
everyone
if
can hear me.
what's happening. There's an echo here.
Yes, we can hear you.
Thank you.
We're looking into it.
Welcome everybody, those online and who are listening to this meeting. And
I think there's a problem.
okay, yes, thank you. Mina.
I'm not sure,
I hope that
Mina, if
We
what's
can hear
happening.
you.
There's an echo here.
yes, we can hear you.
He can't.
Thank you.
We're looking into it.
Welcome everybody.
Okay, why don't you come back to me when
Okay.
it gets straightened out?
Maybe if we can go to our next member, Dr. Pepsworth. She also needs to be unmuted, please. Dr. Pepsworth, I think you can unmute. Maybe we'll be able to hear you. Dr. Pepsworth, can you hear us? If you can unmute.
Hi, can you hear me now?
Yes, we can hear you. Thank you.
Okay, sorry about that. My name is Vicki Pebsworth, and I've worked in the healthcare field now for about 45 years. I have doctoral degrees in nursing and in public health from the University of Michigan. My public health background is in health services, organization, and policy. I previously served on the FDA's VRBPAC committee for quite a few years. I also served on 2 committees at the National Vaccine Advisory Committee. I currently am a volunteer as the Director of Research at the nonprofit National Vaccine Information Center. I'm also the Pacific Region Director of the National Association of Catholic Nurses. As it relates to conflicts of interest, I have been asked to read the following statement. As required under the ACIP policies and procedures, I am also disclosing that I own stock in a healthcare sector fund that includes holdings relevant to the ACIP, including vaccine manufacturers. However, the amount of that stock holding is under the Office of Government Ethics Regulatory de minimis amount. I understand that I therefore can fully participate in the ACIP meeting. Thank you very much. I look forward to being of service and working hard to improve policymaking decisions for vaccines. Thank you.
Thank you, Dr. Meissner.
I apologize for the technical difficulty on my end. My name is Cody Meissner. I am currently a contractor supporting the Biomedical Advanced Research and Development Authority, that is BARDA. And I'm also a professor at Geisel School of Medicine at Dartmouth. I've had a long-standing interest in vaccines and public health. I have previously served on ACIP, on VRPAC. I was chair of the National Vaccine Injury Compensation Program, and I have worked in the past extensively with the American Academy of Pediatrics. I am delighted to be able to present my perspective to the committee. Thank you.
Thank you. And now I'll go through our ex officio members. If you would please let us know who's present from your agency, and I'll try to go through this as fast as possible. Centers for Medicare and Medicaid Services.
Good morning. Andrew Johnson, Senior Advisor, Centers for Medicare and Medicaid Services.
Thank you. Food and Drug Administration.
Present, Tracy Beth Hogue, physician scientist. I'm Senior Advisor for Clinical Sciences in the Office of the Commissioner and the Center for Biologics Evaluation and Research. Thanks.
Thank you. Health Resources and Services Administration. Anyone online? Does she want, is she introducing? Okay. Indian Health Services. I have Matt Clark. And the National Institute of Health. Okay. Now I'm going to go through our liaison representatives. American Academy of Family Physicians. Sorry, I think we're having technical difficulty. We're gonna go to the next section, which is the work group updates, and then come back to roll call since we're having difficulty. Thank you. I'll turn it over to Dr. Koldorf.
So hopefully we can have them introduced a little bit later on. Work groups play a very important role in the work of the ACIP. Selected from around the country, work group members are experts on the vaccines, diseases, and safety issues under consideration. They investigate issues in detail and forward recommendations to the ACIP. Work groups must be chaired by an ACIP member, so new chairs are currently being appointed to the existing work groups. Other work group members have been retained. It's important that we build on the progress that has already been made, and we are very grateful for the work that has been done to date by these work groups. There are currently 11 important work groups looking at vaccines for chikungunya, COVID-19, cytomegalovirus, human papillomavirus, influenza, meningococcal disease, mpox, pneumococcal disease, and RSV, respiratory syncytial virus. We are looking forward to receiving reports from these work groups at future ACIP meetings. When there are different views among working groups members, we want to hear both the majority and minority views. Some new work groups will also be established. The number of vaccines that our children and adolescents receive today exceed what children in most other developed nations receive, and what most of us in this room received when we were children. In addition to studying and evaluating individual vaccines, it is important to evaluate the cumulative effect of the recommended vaccine schedule. This includes interaction effects between different vaccines, the total number of vaccines, cumulative amounts of vaccine ingredients, and the relative timing of different vaccines. The Institute of Medicine, which is now the National Academy of Medicine, wrote an important report on these issues some years ago, arguing for more research on this topic. And it's now time to evaluate that new research. Towards that end, we will be establishing a work group that will look at the cumulative childhood vaccine schedule, as well as the adolescent schedule. We will also be convening a new work group to look at vaccines that have not been subject to review in more than 7 years. This was supposed to be a regular practice of the ACIP, but it has not been done in a thorough and systematic way. We will change that. We are learning more about vaccines over time, and to stay true to evidence-based medicine, we have a duty and responsibility to keep up to date with scientific research to make sure that ACIP recommendations are optimal for both individuals and public health. Among other topics, this new vaccine group may look at the universally recommended hepatitis B vaccine at the day of birth. Is it wise to administer a birth dose of hepatitis B vaccine to every newborn before leaving the hospital? That's the question. Unless the mother is hepatitis B positive, an argument could be made to delay the vaccine for this infection, which is primarily spread by sexual activity and intravenous drug use. Vaccines are important for combating measles. For the first dose at age 12 to 15 months, a previous ACIP meeting recommended 2 alternative options equally, with either separate MMR and varicella vaccines in 2 different needles, or the combined MMRV vaccine in 1 needle, even though the latter caused an excess number of febrile seizures. Aware of this, most pediatricians administer separate MMR and varicella vaccines, and CDC has also expressed a preference for that. To minimize vaccine adverse reactions, the ACIP may follow the lead of pediatricians and reevaluate its earlier recommendation concerning MMRV for 1-year-old children. This working group may also look at new research concerning the optimal timing of the MMR vaccine to resolve religious objections that some parents have concerning the MMR vaccine being used here in the United States. It could also look at other MMR vaccines, such as the one used in Japan. While we may bring different perspectives on some issues, we look very much forward to working collaboratively with the current members of the existing work groups, as well as with scientists here at CDC. We share the same goal, the improvement of public health. That can only be achieved through close collaboration, open discussions, and most importantly, with evidence-based medicine. Thank you.
Thank you for that update. Now we can start our presentations. Our first topic is COVID-19 vaccines. I'm going to turn it over to Dr. McNeil.
Morning. This is projecting? Correct. Great. Good morning. My name is Adam McNeil. I serve as Acting Director for the CDC's Coronavirus and Other Respiratory Viruses Division. The COVID session today will include information on the epidemiology of COVID-19, as well as COVID-19 vaccine effectiveness, safety, and implementation. These presentations include data from 2 evidence to recommendation domains that the COVID-19 work group has reviewed, which are the public health problem and benefits and harms. I want to upfront acknowledge and thank all the CDC employees and collaborators who contributed to the data and content of these presentations. Outlined on this slide is the agenda for the session. After a brief introduction, I will present on COVID-19 epidemiology and updates on COVID-19 vaccine effectiveness. Dr. Sarah Meyer will then give an update on vaccine safety. Dr. Georgina Peacock will present on COVID-19 vaccine coverage and implementation, and I'll wrap up the session by presenting a summary of the first 2 domains of the evidence to recommendations. Please note that PDF versions of these slides have all been posted on the ACIP website, which is available to the public. To recap events of the past year, last June, ACIP recommended 24-25 COVID-19 vaccination for all people aged 6 months and older. In August, FDA authorized Moderna, Pfizer, and Novavax COVID-19 vaccines, and in September, ACIP's recommendations and CDC vaccination guidance was published in MMWR. At the October 2024 ACIP meeting, the committee recommended additional doses for adults aged 65 and older and people 6 months and older with moderate or severe immunocompromise, which was then published in MMWR in December 2024. As has been customary after every recommendation change, CDC updated the interim clinical considerations with these changes following vaccine availability in August, September, and October of 2024. Last month, in May 2024, per HHS directive, CDC updated the COVID-19 vaccine recommendations to shared clinical decision-making for healthy children aged 6 months to 17 years and no guidance not applicable for pregnant women. Also, last month, FDA approved Novavax's COVID-19 vaccine and Moderna's M-Spike for people ages 12 to 64 years at high risk for severe COVID-19 and for people ages 65 and older. On May 22nd, 2025, FDA's VRBPAC met to discuss strain selection for the 25-26 COVID-19 vaccines. FDA then advised manufacturers that the 25-26 formula should be monovalent JN1 lineage-based antigen composition, preferentially using the LP8.1 strain. Here is an overview of the current routine COVID-19 vaccine schedule by age group. Children aged 6 months to 4 years who are unvaccinated may receive a multi-dose initial series with a 24-25 COVID-19 mRNA vaccine using shared clinical decision-making. Those who have previously completed an initial series may receive 1 dose of a 24-25 mRNA vaccine from the same manufacturer as the initial series using shared clinical decision-making. People aged 5 to 17 years may receive 1 age-appropriate dose of the 24-25 COVID-19 vaccine using shared clinical decision-making. Adults aged 18 to 64 years should receive 1 dose of any 24-25 COVID-19 vaccine, and those aged 65 and older should receive 2 doses of any 24-25 COVID-19 vaccine spaced 6 months apart. The current recommendations for people with moderate or severe immunocompromise are shown on this slide. People who are moderately or severely immunocompromised and unvaccinated should receive a multi-dose vaccination series with an age-appropriate 24-25 vaccine and receive one 24-25 vaccine dose 6 months after completing the initial series. Those who have previously completed an initial series should receive 2 doses of an age-appropriate 24-25 COVID-19 vaccines spaced 6 months apart. And they may receive additional age-appropriate 24-25 COVID-19 vaccine doses under shared clinical decision-making. Very important to note, COVID-19 vaccines have had interim recommendations since 2020. These ACIP recommendations were made based on the best available information at the time, with the understanding that these recommendations would be regularly revisited and potentially evolve over time. For the past several years, the work group has been considering non-universal recommendations for COVID-19 vaccination, meaning that only certain age or risk groups would be recommended. At the ACIP meetings in September 2023 and June 2024, the work group interpretations summary outlined discussions that the work group had around universal and non-universal policy options for the 2023-24 and the 2024-25 vaccines, respectively. Ultimately, based on the totality of the evidence, including the epidemiology of COVID-19 and implementation considerations, the work group felt that a universal recommendation was the best option. Beginning in November 2024, the work group has discussed 25-26 COVID-19 vaccine recommendations, and at the April 25 ACIP meeting, ACIP members discussed considerations for the 2025-2026 recommendations, potentially moving to a non-universal recommendation. Between November 2024 and June 2025, the COVID-19 work group reviewed epidemiology and burden of COVID-19 disease, vaccine effectiveness, vaccine safety, and implementation. At the most recent work group meeting on June 5th, and in polling after the meeting, the work group agreed to the following groups and recommendation types. Age-appropriate 2025-2026 COVID-19 vaccines for all infants and children aged 6 to 23 months. Age-appropriate 2025-2026 COVID-19 vaccine for persons aged 2 to 64 years for the following groups. Persons at high risk for severe COVID-19, including pregnant women, persons at high risk of exposure, shared clinical decision-making for persons desiring additional protection from COVID-19, and 2 doses of 2025-26 COVID-19 vaccines for adults aged 65 years and people 6 months and people less than or greater than 6 months with moderate or severe immunocompromise. Next, we will move to COVID-19 epidemiology. This presentation starts with some overall epidemiology related to COVID-19 associated hospitalizations, and then we'll focus first on children, including infants, followed by adults and pregnant women. Finally, I'll give an update on current genomics of SARS-CoV-2. COVID-19 continues to impact Americans' health. Using COVIDNet data and other sources, CDC estimates that since October 1st, 2024, there have been between 9.8 and 16.1 million COVID-19 associated illnesses, between 2.4 and 3.8 million COVID-19 associated outpatient visits, between 270,000 and 440,000 COVID-19 associated hospitalizations, and between 32,000 and 51,000 COVID-19 associated deaths. Long COVID, also known as post-COVID condition, is a significant public health threat that occurs following COVID-19. National surveys in 2023 estimated approximately 9.2 million and 9.2 million adults and 3.3 million children in the US had long COVID. Among adults, 3.6% reported long COVID symptoms and 8.4% reported ever having long COVID. Among children, 0.4% reported long COVID symptoms, and 1.4% reported ever having long COVID. More than 3 in 5 adults and almost 4 in 5 children with long COVID reported activity limitations. Much of the epidemiologic data presented today will be data from the COVID-19 Associated Hospitalization Surveillance Network, or COVIDNet. COVIDNet is one of 3 RESTnet platforms, in addition to RSVNet and FluServeNet, that collect data using similar methods and catchment area on laboratory-confirmed COVID-19, RSV, and influenza-associated hospitalizations, respectively. COVIDNet is a population-based surveillance system that collects and reports data from more than 300 acute care hospitals in 185 counties across 13 states. The COVIDNet catchment area includes about 10% of the US population. Hospitalizations reported to COVIDNet include all those where a positive COVID-19 test result was reported within 14 days prior to hospitalization. Testing for SARS-CoV-2 is driven by clinical judgment and facility policies. Basic demographic data are collected on all patients, while detailed clinical data are collected by trained surveillance officers from an age and site stratified random sample. For this presentation, the period of population-based rates of COVID-19 associated hospitalizations is July through June. This period allows us to present data for periods that are inclusive of both the typical respiratory virus season of October through April, as well as the increase in rates which we have experienced over the preceding summer for COVID-19. Clinical data are presented for the most recent 12-month period of April 2024 through March 2025. The next 2 slides will show weekly hospitalization rates for COVID-19 in red, influenza in blue, and RSV in green. The inset, which shows rates since the beginning of the pandemic, is shown for context, and weekly rates for July 2023 through May 2025 are shown in the main graph. COVID-19 associated hospitalization rates peak both in the winter as well as the summer, as you can see with the large summer peak in the 2024 wave. This differs from RSV and influenza, which generally have a similar peak. You can see the impact that this year-round circulation of SARS-CoV-2 has in this figure, which shows cumulative rates of COVID-19, influenza, and RSV-associated hospitalizations for the same period as the previous slide. Cumulative rates are the sum of consecutive weekly rates. For cumulative hospitalization slips that are positive or increasing, that indicates ongoing new hospitalizations. For slopes that are flat, that indicates hospitalizations are minimal or slowed to 0. Cumulative rates of COVID-19 associated hospitalizations for the ongoing period of July 2024 through June 2025, shown in the solid red line, were higher during June to November, lower during November through June compared to those observed in the prior season from July 2023 to June 2024, shown with the dashed red line. While cumulative rates of influenza-associated hospitalizations for the ongoing 24-25 season, shown in the solid blue line, are higher than rates for COVID-19 associated hospitalizations for the current season, they remain lower than last year's COVID-19 hospitalization rates. Note that surveillance for influenza-associated hospitalizations is limited to October through April, as that is a typical period of influenza circulation. While the remainder of this presentation will focus mainly on COVID-19 hospitalizations, note that different respiratory viruses affect age groups differently, with the biggest collective impact at the extremes. This figure shows cumulative rates of laboratory-confirmed hospitalizations for COVID-19 and influenza for July 2024 through April 2025. More infants aged less than 1 year and adults aged 75 years and older had hospitalizations associated with COVID-19 than influenza during a high severity influenza season. On this slide, the larger figure shows cumulative rates of COVID-19 hospitalization by age group, with a focus on those less than 75. The rates of hospitalizations among infants less than 6 months are nearly identical to those aged 65 to 74, with cumulative rates of 268 and 266 per 100,000 respectively. Similarly, rates among children aged 6 to 23 months are nearly equal to those among adults aged 50 to 64 months. The inset figure in the red box includes these same rates in addition to adults aged 75 and older, indicated in the orange line. The next several slides will focus on the epidemiology of COVID-19 associated mortality. The next 3 slides use data from the National Vital Statistics System that shows the number of death certificates coded with a specific code indicating COVID-19 as a cause of death. Overall, COVID-19 associated deaths were currently decreasing and remain lower this winter than they were in the summer and fall of 2024. This slide shows the number of deaths with COVID-19 listed as the underlying cause of death from July 2024 to June 2025 by age group. While COVID-19 causes deaths in all age groups, you can see that more than 70% of deaths occur in adults ages 65 and older. It is important to realize that the preceding 2 slides may substantially undercount the number of deaths due to COVID-19. Looking at data in COVIDnet, this figure shows the percentage of in-hospital deaths in patients hospitalized with laboratory-confirmed SARS-CoV-2 with COVID-19 as a cause of death listed on the death certificate. The proportion of death certificates with COVID-19 as a cause of death has declined over time. The likelihood of having COVID-19 listed as a cause of death has decreased over time, even among patients with COVID-19 associated hospitalization. Using provisional death certificate data, NCHS estimates that more than 20,000 COVID-19 related deaths occurred between October 2024 and May 2025. And as discussed in the last slide, this is likely an underestimate. Using additional data and modeling techniques, CDC estimates that since October 1, 2024, between 32,000 and 51,000 people have died in the US from COVID-19. Next, we'll turn to the epidemiology of COVID-19 associated hospitalizations. This slide shows data from the new Vaccine Surveillance Network, which is a multi-pathogen enhanced surveillance network to assess pediatric viral, respiratory, and gastrointestinal infections and vaccine impact in children. These data compare hospitalization rates due to COVID-19 in red and influenza in blue from July 2024 through March 2025. Hospitalization rates for both viruses are highest for those younger than 6 months old and generally decrease with an increasing age through age 17. For age groups younger than 2, influenza and COVID-19 associated hospitalizations are similar. In those aged 2 to 11 years, hospitalization rates were higher for influenza, and COVID-19 hospitalization rates for those ages 12 to 17 had too few detections and are not shown. This figure from COVIDnet shows the percent of COVID-19 associated hospitalizations by age group by week from July 2024 through May 2025. For this period, hospitalizations among children younger than 2 years of age, shown in green, comprise 57% of all COVID-19 associated hospitalizations among children and adolescents, including infants younger than 6 months old, who make up 27% of pediatric COVID-19 associated hospitalizations. COVID-19 causes severe disease in infants younger than 6 months. Infants have the highest rates of COVID-19 associated hospitalization among all pediatric age groups, with rates comparable to adults 65 to 74 years. During July 2024 to May 2025, the cumulative COVID-19 associated hospitalization rate among infants was 268 per 100,000, and the cumulative rate among adults aged 65 to 74 was 266. Note, as indicated earlier in the presentation, rates are higher among those greater than 75. Among infants less than 6 months hospitalized recently for COVID-19, 22% were admitted to the ICU, 71% had no underlying medical conditions, and only 3.5% had any record of maternal COVID-19 vaccination during pregnancy. No COVID-19 vaccine products are approved for infant ages younger than 6 months old. Any protection must come from maternal antibodies to the infant, either from vaccination during pregnancy or prior infection. Transitioning to vaccine-eligible infants and older children, this figure shows the percent of weekly COVID-19 associated hospitalizations by age group from July 2024 through May 2025, limited to those children older than 6 months. Among them, children ages 6 to 23 months, shown in green, comprise 41% of all hospitalizations during July 2024 through May 2025. This figure shows cumulative rates among pediatric age groups from July 2024 through May 2025 and is similar to the one shown earlier. For reference, the younger than 4 age group is shown here as a dashed gray line. If you examine that rate line relative to the highlighted age subgroups, you'll see that rates of those age subgroups vary widely. While cumulative rates of the overall younger than 4 age group are 68 per 100,000. Rates among infants younger than 6 months are 268, 6 to 23 months are 100, and 2 to 4 years are 22 per 100,000 population. This is the same figure as the previous one, but adding back in 2 adult age groups. As previously mentioned, the rates of hospitalization among infants aged younger than 6 months are nearly identical to those aged 65 to 74. Similarly, rates among children aged 6 to 23 months are nearly identical to those among nearly equal to adults aged 50 to 64 years. Additionally, there are differences among thresholds for admitting children and adults for hospitalization, which should be noted. As shown in the box, 94% of adults aged 50 to 64 years hospitalized for COVID-19 had one or more underlying condition, compared to only 46% of children aged 6 to 23 months hospitalized for COVID-19. In other words, while most adults 50 to 64 years admitted for COVID-19 had underlying medical conditions, more than half of children 6 to 23 months were otherwise healthy before their COVID-19 hospitalization. Not only do hospitalization rates vary by pediatric age group, but the clinical characteristics, including underlying medical conditions of infants, children, and adolescents being hospitalized for COVID-19 also differed by age group during recent seasons. This slide shows the proportion of children hospitalized for COVID-19 who did not have any underlying medical conditions. 54%, or more than half of children aged 6 to 23 months hospitalized for COVID-19 had no underlying medical conditions. Among those with an underlying condition, the most common condition was prematurity. Among the 3 older pediatric age groups, those aged 2 to 17 years, more than 70% of children and adolescents had at least one underlying condition, with asthma and reactive airway disease and neurologic disorders being the most common conditions. The proportion of hospitalized children with no underlying medical conditions decreases with age. Among children who are hospitalized for COVID-19, many continue to experience severe outcomes. From April 2024 to March 2025, overall, 24% of children younger than 18 years were admitted to the intensive care unit. This is consistent across all age groups. As indicated in the red bracket, 23% under 2 years were admitted to the ICU during hospitalization for COVID-19. Among them, 53% had no underlying medical conditions, although this varied by age group. This slide shows that the majority of children hospitalized for COVID-19 during October 2024 to March 2025 did not receive the most recently recommended COVID-19 vaccine. Roughly 10% of children across all vaccine-eligible pediatric age groups have received the recommended COVID-19 24-25 dose. Next, we will turn to pediatric mortality. Slide 28, right? Okay, we're good. This graph shows the number of documented COVID-19 and influenza deaths among people ages 0 to 17 years from July 2024 to June 2025. For children younger than 2, the number of deaths associated with COVID-19 in red was similar to the number of deaths associated with flu, shown in blue. However, for children ages 2 to 17 years, there are more deaths associated with influenza than COVID-19. It is important to note that COVID-19 deaths here are likely an underestimate because pediatric deaths associated with influenza are nationally notifiable, but pediatric deaths associated with COVID-19 were not during this time period. Since March 2020, 128 deaths among children and adolescents occurred among residents of the COVID-net catchment area, either during COVID-19 associated hospitalization or within 30 days after discharge. Of the 25 who died in the catchment area since July 2023, 10 occurred during the past 12-month period of April 2024 through March 2025. Please note that these are raw counts and that COVID-net catchment area represents about 10% of the US population. Among those 25 pediatric deaths since July 2025, 52% were younger than age 2 years, 72% had at least one underlying condition. Of the 16 who were age eligible for COVID-19 vaccination, 14 had no record of COVID-19 vaccination, and none were up to date. Reporting for death certificate data to ResNet are delayed. Data from 2022-2023, the most recent available data for the complete death certificate. Among those, the 25 most recent deaths for which we have complete mortality data, 28% had COVID-19 as a specific cause of death on their death certificate. An additional 9 had causes of death attributed to other respiratory circulatory causes. As previously mentioned, death certificate data alone might underestimate COVID-19 associated pediatric deaths. In summary, most pediatric hospitalizations occur in children younger than 2 years. Most of these hospitalized children have no underlying medical conditions, including 71% of infants ages less than 6 months old and half of children aged 6 to 23 months. Rates of COVID-19 associated hospitalizations are the highest among infants aged younger than 6 months, followed by those 6 to 23 months. Rates of COVID-19 associated hospitalizations among infants younger than 6 months are comparable to rates among older adults aged 65 to 74 years. Notably, no COVID-19 vaccine products are approved for the youngest infants under 6 months. Any protection for them must come from transfer of maternal antibodies, either through vaccination during pregnancy or prior infection. Outcomes among hospitalized children can be severe, with 1 in 4 admitted to the intensive care unit. COVID-19 deaths continue to occur among infants and children. The majority of COVID-19 vaccine-eligible children and adolescents who were hospitalized had no recent record of receiving the most recently recommended vaccine. On to COVID-19 associated hospitalizations in adults. As noted previously, adults comprise the vast majority of COVID-19 associated hospitalizations, with older adults being the most impacted, and rates are highest among adults aged 75 years and older. This figure shows the weekly percent of COVID-19 associated hospitalizations by adult age group from March 2024 through May 2025. For this period, July 2024 through May 2025, highlighted in the red box, adults ages 65 and older comprise 72% of all adult COVID-19 associated hospitalizations captured in COVIDNet. Adults 75 years and older comprised half of all COVID-19 hospitalizations among adults, despite making up less than 10% of the population. This figure shows the number of underlying medical conditions reported among adults hospitalized for COVID-19. Most adults hospitalized with COVID-19 had at least one underlying medical condition. A majority had two or more underlying medical conditions. Even among the youngest adults, those ages 18 through 49 years, shown in light green, the prevalence of one or more underlying medical conditions is 86%, with 61% having two or more underlying medical conditions. A significant proportion of adults hospitalized for COVID-19 experienced severe outcomes, with the proportion experiencing ICU admission shown in tan, invasive mechanical ventilation in blue, and in-hospital death in red. Overall, 15% of adults hospitalized for COVID-19 were admitted to the ICU. In-hospital death is more common among adults 50 years of age and older. As noted in the yellow box, during this period, 85% of all adults hospitalized for COVID-19 who died in hospital were ages 65 years and older. Note that these are only in-hospital deaths. This slide shows the proportion of adults hospitalized for COVID-19 by vaccination status among adult age groups for October 2024 through March 2025. Among adults 65 years and older, highlighted in the box on the far right, 65% of adults hospitalized for COVID-19 received neither the 2023-24 or 24-25 formula COVID-19 vaccine. 1/3 of adults aged 65 years and older hospitalized for COVID-19 received the recommended at least one dose of the 24-25 vaccine prior to admission. 17% received 2 doses. On to COVID-19 associated hospitalizations among pregnant women. In COVIDNet, pregnancy status was collected from SARS-CoV-2 positive hospitalized women ages 15 to 49 years. 28.5% of women aged 15 to 49 years hospitalized with laboratory confirmed SARS-CoV-2 infection were pregnant. 50% of those had COVID-19 related signs or symptoms. Among 131 hospitalized pregnant women with a laboratory-confirmed SARS-CoV-2 positive test result and underlying COVID-19 related signs or symptoms, 50% had no underlying conditions. 68% were no longer pregnant at discharge, among whom 83% had a healthy newborn, 11% had a preterm infant, 1% had a male infant, and 5% had pregnancy loss. 92% had no record of COVID-19 vaccinations since July 1st, 2023. 5.8% received recommended 24-25 COVID-19 vaccine dose. To summarize the adult data, Rates of COVID-19 associated hospitalization are highest among oldest adult age groups. Adults aged greater than 65 comprise 72% of adult COVID-19 associated hospitalizations, and those 75 years and older comprise 50% of adult hospitalizations. COVID-19 associated hospitalizations have decreased over time, but cumulative rates among adults aged greater than 75 years remain high. The risk of COVID-19 associated hospitalization continues year-round, peaking in winter and summer months. 65% of adults aged 65 years or older hospitalized with COVID-19 had no record of receiving greater than one dose of the recommended 24-25 COVID-19 vaccine prior to hospitalization. Most adults hospitalized for COVID-19 have at least one underlying medical condition, and most have two. Among SARS-CoV-2 positive pregnant women admitted during April 24 to March 2025 with COVID-19 related symptoms on admission, 50% had no underlying medical conditions, and most, 92%, had no record of COVID-19 vaccination since July 1st, 2023. Next, we'll transition to SARS-CoV-2 genomics. Since SARS-CoV-2 emerged in late 2019, we observed evolution of the viruses with accumulating substitutions in the spike protein, which binds the ACE2 cellular receptor and is target for neutralizing antibodies. Looking at this timeline along the x-axis and number of spike protein amino acid differences on the y-axis, you can observe periods of both drift in accumulations of changes and shift when new lineage is emerged and had numerous changes. So really important stuff here. The first time we observed a shift was in late 2021 to 2022, and you can see by the jump from purple to orange dots. That was a shift from Delta to Omicron. We have also observed shifts from BA.45 viruses to XBB viruses, and then from XBB to JN.1 viruses. These shifts necessitated changing the formulation of the COVID-19 vaccine dose. The 23-24 formulation of the COVID-19 vaccine that was released in fall of 2023 was XBB 1.5. During the winter, we observed circulation of XBB 1.5 sublineages like EG5, FL1.5.1, and HV1, which were very similar to XBB 1.5. December 2023 to January 2024, we observed a strain replacement of XBB 1.5 to JN1 viruses, which evolved independently of XBB 1.5 viruses. Since the emergence of JN1, SARS-CoV lineages have continued to evolve from JN1, and we've not observed a strain replacement. All the lineages that have predominated since the JN1 emergence are descendants currently of JN1. Viruses that have predominated since January 2025, as noted, are all JN1 descendants. I've circled the JN1 lineage in this dendrogram in each sublineage that has predominated in the last 1.5 years. We continue to see JN1 lineage viruses predominating. This was the weighted and nowcast estimates posted on COVID Data Tracker on June 10th, 2025. LP.8.1 was the predominant lineage through the spring, though now NB.1.8.1 appears to be increasing in proportion, as well as XFG and XFC. All of these are still JN1 lineage viruses. As mentioned, LP8.1, XFC, and NB1.8.1 are JN1 lineage viruses. This is an amino acid alignment of substitutions in the spike protein in comparison to the 24-25 COVID-19 vaccine formulation. There are only 2 to 4 changes in the receptor binding domain in comparison to last year's vaccine. As a reminder, last summer, circulating viruses had 13 or more spike changes in spike receptor binding domain in comparison to the vaccine formulation. So for time, I'm going to skip over the slide that has SERA. This was presented recently at the VRPAC meeting, as well as the antigen cartography. The big picture is that current circulating lineages appear relatively similar structurally wise to those in vaccine formulations. To summarize the COVID-19 genomics, current viruses are JN1 descendants with 2 to 3 substitutions in spike receptor binding in the spike receptor binding domain in comparison to KP2 spike. Current viruses are neutralized with sera from participants who received the 24-25 COVID-19 vaccine. Antigenic cartography indicates JN1 viruses are similar. FDA's VRPAC reviewed genomic and phenotypic data in May 2025 and unanimously voted to recommend a monovalent JN1 lineage vaccine as its composition. FDA has advised manufacturers to use JN1-based COVID-19 preferentially using the LP 8.1 strain for the 25-26 COVID-19 vaccines. I'll now move on to discussing COVID-19 vaccine effectiveness. This is the next set of slides, please.
Thank you. I think we're going to continue with the presentations, and the next presentation is on COVID-19 vaccine effectiveness. Dr. McNeil.
Sorry. Go ahead. Okay. I will now move on to presenting COVID-19 vaccine effectiveness. I'll start today with methods and context for how we measure and interpret vaccine effectiveness, or VE, and then present estimates of COVID-19 VE in children and adults, and overall conclusions. I'll start by summarizing VE methods and providing some context for interpretation of results. For respiratory viruses, CDC generally uses a case control design, often the test negative design, or TND, to measure vaccine effectiveness. In the TND, people who seek care for respiratory illness are included. Cases are those that test positive for SARS-CoV-2, and controls are those that test negative. Controls in these studies are meant to represent the population from which the cases arose, and here give us an understanding of COVID-19 vaccine coverage among people seeking care for respiratory illness. We then compare vaccination status in cases and controls to determine vaccine effectiveness, or VE. If coverage is higher among controls than among cases, that indicates the vaccines are associated with protection against disease. Because both cases and controls are people seeking care for respiratory illness, we can reduce the impact of factors that can distort or confound the relationship between vaccination status and illness. Reducing the impact or adjusting for factors like age and geography helps to make the true relationship between vaccination status and illness clear. Today I'll be sharing VE results from 3 CDC platforms for children and adults. The first VE platform is the Vision Network, a multi-site network of over 200 electronic health records, a multi-site network of electronic health records at over 300 emergency departments and urgent care clinics and over 200 hospitals that include both children and adults. Vision uses a test negative design and includes eligible people of all ages with COVID-19-like illness and a clinical test within 10 days before or 72 hours after their encounter. Cases are those with a positive NAT or antigen test for SARS-CoV-2 and no positive RSV or influenza test result. Controls are those with a negative NAT test for SARS-CoV-2 and no positive NAT test result for influenza or RSV, depending on age. Vaccination is documented by electronic health records and state or city registries. The second VE platform enrolls only children with enrollment at 26 pediatric hospitals in 20 states. The analysis I'll present today for this platform is designed to assess the effectiveness of COVID-19 vaccination in pregnant women for prevention of COVID-19 related hospitalizations in infants less than 6 months of age. The third platform included today is the IV Network, a multi-site VE platform in 26 hospitals in 20 states that, like Vision, uses a test-negative design. Unlike Vision, IV uses an active enrollment design with patient interviews and nasal swabbing of enrollees. Participants included in analyses presented today were adults ages 18 and greater years hospitalized with COVID-19-like illness. Cases have a SARS-CoV-2 positive nucleic antigen test or nucleic acid test or antigen test, and controls were negative for SARS-CoV-2, influenza, and RSV by RT-PCR. Vaccination history is ascertained through electronic medical records, state and local vaccine registries, and plausible self-report, and specimens are collected for central testing and sequencing. Here we've measured COVID-19 VE. Here's how COVID-19 VE measurements have been changed in terms of approaches by season. When COVID-19 vaccines were first released, we measured absolute VE, which compares the frequency of health outcomes in vaccinated versus unvaccinated people. During the bivalent era, however, we also measured relative VE, which compares the frequency of health outcomes in people who received one type of vaccine to people who received a different vaccine. For example, people who received a bivalent vaccine versus those who received only the original monovalent COVID-19 vaccine. Generally, for 2023-24 and 24-25 COVID-19 vaccines, we've combined absolute and relative VE and measured protection as the frequency in disease in those who received the current vaccine to those who did not, regardless of their past vaccination or infection history. In other words, the comparison group for the 23-24 VE analysis includes people who are unvaccinated, as well as those who received original monovalent and bivalent COVID-19 doses. The same is true for the 24-25 estimates, where the comparison group is people who are unvaccinated or received original monovalent, bivalent, or 23-24 COVID-19 vaccines. Of note, this is similar to how influenza vaccine effectiveness is measured each year. This represents the added benefit of a seasonal vaccination for the respective season, regardless of previous vaccination or infection history. This graph shows the COVID-19 vaccination coverage from CDC's National Immunization Survey during the 23-24 and 24-25 seasons among children aged 6 months to 4 years in blue, and among children and adolescents aged 5 to 17 years in green. 23-24 uptake is shown in dotted lines, and 24-25 uptake is shown in solid lines. You can see that that coverage was similar in both years. It remained quite low. The lowest coverage in youngest children occurred during the 24-25 season. Here we see data on uptake of COVID-19 vaccines among adults aged 18 years and up, with the 23-24 shown in blue and 24-25 shown in gray. Note that the 24-25 vaccines were recommended a few weeks earlier than the 23-24 vaccines, so coverage started to increase a bit earlier, but ended up similar at just under 25% during each spring year. Moving on to older adults, this slide uses data from Medicare fee-for-service beneficiaries aged 65 years and older to understand coverage for the 24-25 COVID-19 season by underlying medical condition status. The x-axis is calendar week in 2-week periods, and the y-axis is coverage. You can see in red, the overall coverage was 28% for this group by January 2025. Coverage was highest among those with immunocompromising conditions at 32%, and lowest among those with no underlying medical conditions at 24%. I'll now share estimates for COVID-19 VE in children. This graph from CDC's COVIDNet surveillance platform shows cumulative rates of COVID-19 hospitalizations for 23-24 and 24-25. As with coverage graphs, younger kids are again in blue and older kids are in green, with 23-24 rates in the dotted lines and 24-25 rates in the solid lines. You can see that rates are higher in the younger children, and that rates in the 24-25 season were lower in both age groups than in 23-24. As you'll see, this resulted in less statistical power for 24-25 analyses. It means that we are only able to share data for finer stratifications for 23-24. This slide shows the 23-24 COVID-19 vaccine effectiveness against emergency department and urgent care encounters, including data through August 24, which is when the 24-25 vaccines were released. Note that the reference group includes all individuals who did not receive a 23-24 COVID-19 vaccine. For those aged greater than 5 years, this includes unvaccinated persons and persons who were vaccinated with greater than one original monovalent or bivalent COVID-19 doses. For those aged less than 5 years, both those in the reference group and those in the vaccinated group were required to have completed an initial series. The 23-24 dose could have been part of the initial series or in addition to the initial series. In the top block, you see counts of encounters, cases, and time since dose for people who did not receive a 23-24 COVID-19 by age group, 9 months to 4 years, 5 to 17 years, and adults 18 and up. The middle block shows VE among those who received a 23-24 dose 7 to 59 days earlier, and the bottom is VE among those who received 23-24 dose 62 to 299 days earlier. Note that there was not enough children vaccinated from days 60 to 299 with positive SARS-CoV-2 tests to split the 60 to 299 day block in children with more granularity. You can see that VE is estimated to be as good or better among children as it is among adults. This aligns with previous seasons showing generally comparable VE across age groups. This slide is similar to the previous one, though now showing VE during the 24-25 season. As mentioned, lower numbers of COVID-19 cases in 24-25 resulted in less statistical power during the season, so we were not able to estimate VE by time since dose for 24-25. Instead, we've shown overall VE for the 7 to 179 days since receipt of a 24-25 COVID-19 vaccine dose. You can see that, as with 2023-24, VE is the same or higher in children and adults. Now we'll move on to estimates of effectiveness of maternal COVID-19 vaccine receipt for protection of COVID-19 associated hospitalization among infants from the Overcoming COVID-19 Network during 2022-2023. Maternal VE is particularly important because infants under 6 months of age are not eligible for COVID-19 vaccination and have higher rates of severe COVID-19 disease than older children and most adult age groups. Vaccination of pregnant women is the only way to protect their infants from severe disease. This analysis included mothers who received their last dose of COVID-19 mRNA vaccine between the first day of pregnancy and 14 days before delivery. The comparison group was mothers who did not receive any COVID-19 vaccination, either before or during pregnancy. As you can see, VE was highest in the youngest children at 54% during the first 2 months of life and 35% during the first 0 to 5 months of life. This mirrors patterns in older children and adults where VE drops with more time since dose. I'll now share results for COVID-19 VE in adults. This slide shows absolute VE of original monovalent and bivalent doses received prior to or during pregnancy against COVID-19 associated emergency department or urgent care visits in pregnant women aged 18 to 45 years. Note that although these are older vaccines, the data were collected during 2023 and during 2022 and 2023 when Omicron was the dominant variant. As you can see, a dose during pregnancy in this population administered a median of 91 days before the encounter provided 52% protection, while a dose administered less than 6 months before pregnancy, a median of 267 days from the encounter yielded 28% protection, and a dose 6 months or more was not statistically different than 0. This follows the pattern we see in non-pregnant adults and children, where a more recent dose gives the highest protection. This slide shows similar data now for 23-24 monovalent COVID-19 vaccines. Although there was not statistical power here to look at the time since dose, we can see that protection in pregnant women, a median 77 days after COVID-19 vaccination, shown on the top, was similar to protection in non-pregnant women of the same age group, a median of 83 days after COVID-19 vaccination. This slide shows the characteristics of the patient populations included in the next analysis I'll present. First, above the top, you see each of the 3 analyses: vision emergency department urgent care encounters in adults aged 18 years and up, vision hospitalizations in adults aged 65 and up, which include estimates against critical illness, and IV hospitalizations in adults aged 65 years and up. First, you can see that median age for the emergency department urgent care encounters was low, in the low to mid-50s, compared to hospitalization analyses in both platforms, which had median ages in the mid to high 70s. Keep in mind that the only analysis we'll share today that included adults aged 18 to 64 was the vision ED urgent care analysis. Younger adults were excluded from hospitalization analyses for both vision and IV because of lack of statistical power, due both to lower baseline hospitalization rates and lower COVID-19 vaccine uptake in younger adults. However, we've seen in previous seasons that VE is similar among those aged 18 to 64 and those aged 65 and up. Finally, both platforms include VE for adults with immunocompromising conditions. This slide shows VE of the 24-25 COVID-19 vaccines against COVID-19 associated emergency department and urgent care encounters by age group. The top block shows VE for all adults aged 18 and up during the 7 to 179 days after the dose, and split by time since dose. 7 to 59 days, 60 to 119, and 120 to 179 days. The middle block shows the same information for adults aged 18 to 64 years and adults aged 65 years and up. The first column shows COVID-19 cases. The second column shows COVID-19 controls. The third column shows median time since the last dose among vaccinated. And then finally, the last column, a forest plot, shows vaccine effectiveness. Note that among the reference group, those who did not receive the 24-25 COVID-19 vaccine, it's been a median of around 1,000 days, or almost 3 years, since receipt of the last COVID-19 vaccine dose for all adults. VE among all adults against COVID-19 associated emergency department urgent care encounters was 34% for the 7 to 179 days since receipt of a dose, 36% for the 7 to 59 days, 35% for the 60 to 119 days, and 28% for the 120 to 179 days since a 24-25 COVID-19 vaccine dose. VE among younger and older adults was similar. This slide shows VE against COVID-19 associated hospitalization among adults aged 65 years and up without documented immunocompromising conditions in the vision and IV networks. This slide is laid out the same as the previous slide, except instead of age groups, it shows vision adults in the top block and IV results in the bottom block for adults aged 65 years and up. VE was almost identical across the two networks, providing reassurance of the results. During the 7 to 179 days since a dose, the point estimate was 44% in vision and 46% in IV. VE started at 46% in vision and 42% in IV, declining to 32% in vision and 40% in IV during the 120 days after vaccination. Although note that the confidence intervals for this time period are wider due to smaller numbers of both cases and controls vaccinated 4 to 6 months before their encounter. This slide shows VE against COVID-19 associated critical illness in vision and IV. Vision on the top defines critical illness as admission to intensive care or in-hospital death, and estimates are shown by time since dose among those 65 years and up. You can see that point estimates do not change much over time, even in the longest time since dose strata, 120 to 179 days since the dose, indicating relatively durable protection. This mirrors what we've seen in previous years. VE against the most severe outcomes remains the most durable over time, with little evidence of waning in the longest time since dose period. In IV, shown on the bottom, we have VE against 3 separate outcomes, all shown for the 7 to 179 days since a dose, shown generally by increasing severity, including acute respiratory failure, ICU admission or death, and invasive mechanical ventilation. Here, again, we see indications of higher VE for the most severe outcomes, at 70% for invasive mechanical ventilation or death. This slide shows VE against COVID-19 associated hospitalizations among adults aged 65 years and up with immunocompromising conditions in vision and IV. Though IV did not have enough statistical power to estimate VE by time since dose in this group. In vision, VE appears to be increasing over time, which is something we've seen previously in adults with immunocompromising conditions, and is likely due to faster waning of infection-induced immunity in immunocompromised people, which would make the referent group, those who did not receive a 24-25 vaccine, have less protection over time since the summer surge, thereby appearing to increase VE. VE for the overall time period, 38% in vision and 36% in IV, is close to VE in non-immunocompromising adults, providing assurance that vaccine is working in immunocompromised adults. I'll next share VE by strain from the IV network. In this sub-analysis, IV conducted whole genome sequencing and restricted to patients with sequence-confirmed KP3.1.1 or XCC lineage viruses and calculated VE against hospitalization separately for each lineage. As with the main analysis, controls were those with COVID-like illness and negative tests for SARS-CoV-2, influenza, and RSV. This slide shows the results of the VE by lineage analysis with KP3.1.1 on the top and XCC on the bottom. You can see that VE was similar across lineages with largely overlapping confidence intervals. Note that median time since dose for KP3.1.1 cases who had received a 24-25 dose is 56 days, while the median time since dose for the XCC cases who had received a 24-25 dose was 87 days, likely accounting for the slightly different point estimates, 45% for KP3.1.1 and 34% for XCC. For the respective year, compared to no in-season COVID-19 vaccination, for this respective year compared to no in-season dose, COVID-19 vaccination provided additional protection from COVID-19 associated emergency department and urgent care visits among children. Protection was generally similar across all these age groups. COVID-19 associated emergency department and urgent care visits among adults. COVID-19 associated hospitalizations among adults aged 65 years with and without immunocompromising conditions, and COVID-19 associated critical illness among adults aged 65 years and older. Protection appeared to be higher and more durable against more critical illness compared to less severe outcomes. VE should be interpreted as the added benefit of the 23-24 or the 24-25 COVID vaccination in a population with high levels of infection-induced immunity, vaccine-induced immunity, and both. Prior SARS-CoV-2 infection contributes to protection against future disease, though protection, like with vaccination, wanes over time. An increase in SARS-CoV-2 circulation in the United States occurred in late summer 2024, just before the 24-25 COVID-19 vaccines were approved and authorized. This may have resulted in a higher proportion of population-level immunity against JN1 lineage strains, which could have resulted in lower VE measured than in a population with less recent infection. I'd like to thank the numerous colleagues from CDC and collaborators with Vision, Ivy, and Overcoming Networks who contributed to this presentation. I'll now hand it off to Captain Meyer, who will present on vaccine safety. Thank you.
Thank you, Dr. McNeil. Before we go to the next presenter, we're going to take some questions from committee members. And I'm going to use my privilege as chair to ask the first question. I really appreciate that you emphasize hospitalizations and death, because that's really what matters when it comes to COVID. The gold standard of medical research or the randomized placebo-controlled trials, double-blind. What are the results in terms of vaccine efficacy from such randomized trials?
So I'm also going to look to my SMEs here to comment, but I think it's also important to remember a lot of the randomized controlled trials were done in largely naive populations, and what we're looking at in these couple of recent years is basically the added value in a population that's had multiple exposures to vaccines or infection. So randomized clinical controlled trials are not necessarily comparable to what we're currently seeing with the vaccine. And, you know, we've seen across these different ages, we're seeing ballpark that the added benefit is in the range of 30 to 50%. So it's a, you know, I think it's where we're trying to now monitor is the real world impact of these vaccines as opposed to clinical trial data, which was certainly extensively documented.
And in terms of observational studies, it's important that the control group is sort of representative of the population at large. And that's usually best accomplished with the cohort study. If doing a case control study, the best thing is to recruit the controls from the general population. And that's the weakness for the test negative design, because the control group are people who have a different type of infection that's not COVID. And that's just been a very special, peculiar population which might have very different vaccination patterns. Were most of the results from the test negative design, or were they also some of the results from cohort studies or traditional standard case control studies?
Yeah, no, it's a good question. So I think it's, you know, case control has some limitations in comparison to your classic cohort type study. These platforms all rely on case control design, majority are test negative design. And much of this is the ability for us to have efficiency to be able to collect data in large populations in such a way that is not cost prohibited. And as we get up to substantial numbers in these study designs, it's able to generate a relatively accurate estimate of the VE. So.
Thank you. And we'll go to the next. I think we have Dr. Cody Meyer wanted to ask some questions remotely, and then we'll go to the people in the room here.
Yes. Thank you, Dr. Kilgore. Cody Meissner here. First, I'd like to recognize the enormous amount of work that was provided by the CDC, many people, in generating this data that has been so helpful in understanding the pandemic. I think they oftentimes go unrecognized, and I and many others appreciate it. I also want to thank Dr. McNeil for presenting a huge amount of data in a short period of time, a very difficult task, and you deserve a promotion for presenting that so clearly and effectively.
I'm going to interrupt you and look over to Dimitri with a little nod right there. Thank you. Sorry, back to you, Dr. Meissner. Meissner.
It's a Herculean task, and you did it very, very well. But I've got a series of questions, and I'm going to try and focus on the most important ones, I think, that apply to your presentation. First of all, you referred to the COVID hospitalization rates in numerous slides. And I assume the COVID hospitalization rate refers to a hospitalized person who has a positive RT-PCR assay for COVID. And that doesn't mean a person is hospitalized because of COVID. And it's a patient who's hospitalized with COVID in the pharynx. And those are two very different things. The Commonwealth of Massachusetts did a study that they've discontinued it, but they used to look for how many patients who had a positive PCR assay were actually being treated for COVID, and it turned out that less than half of them were. So I think many of the numbers that have been presented may not really reflect COVID hospitalization. People may have been hospitalized because of appendicitis, for example, and happen to have a positive PCR result, because we know that asymptomatic colonization is quite common with this virus. So first of all, I'll ask you, and I'll stop there. If Dr. Kildorf will permit, I have some other questions, but I'm interested in your response to that. Over.
Yeah, if you give me 1 second, we have, this has certainly been a very commonly discussed question, and we certainly looked at it in detail. I'm going to look at, see, I have a number of SMEs on the line. I wonder if I could have someone jump in real quickly while I'm looking through our data.
I will also just comment while you're looking. I think you said that 50% of the pregnant women who were hospitalized had signs and symptoms of a respiratory infection. So I interpret that to mean the other 50% did not have signs and symptoms and were therefore colonized, if that's the right word, with this coronavirus.
Mina, are we able to jump over to our SME line? We should have an SME online who knows.
We do have an SME who's trying to chime in, so if that line could be turned on, that would be great.
Hi, can you hear me?
Perfect. Yes.
Hi, my name is Dr. Christopher Taylor, and I'm an SME with the COVIDnet system. And that's an excellent question you asked, Dr. Meisner, and thank you for allowing me to address it. There are two sort of components to the COVIDNet data that were presented: the population-based rates of COVID-19 associated hospitalization and the clinical data that's based on a sample of those hospitalizations. The rates that are presented, again, are population-based rates, and as you correctly said, are based on lab-confirmed SARS-CoV-2 positive tests. The clinical data that we present are limited to a sample, and that sample is further filtered, and the results, and you'll note if you go back into the slides on the footnotes, those results are limited to those where COVID-19 was identified as the likely reason for admission for those hospitalizations. Earlier, a few months ago, we published a peer-reviewed paper in influenza and other respiratory viruses looking at the trends in COVID-19 attributable hospitalizations among adults with lab-confirmed SARS-CoV-2. And what we found was that looking, again, just at adults 18 years of age and older, 86% of hospitalizations during the most recent period, which for that manuscript includes 2022 and 22-23, 86% of populations we could define as COVID attributable, which includes cases that were identified as being having a reason for admission, likely attributable to COVID-19, meaning that it was identified that they had COVID-19 related illness on admission. They received a course of medicine during their hospitalization for persons with severe disease among hospitalized persons with COVID-19, or they had a select subset of discharge diagnoses related to outcomes of COVID-19, such as pneumonia or ARDS or something like that. So again, we found 86% of adult hospitalizations during that time period were somehow attributable to COVID-19.
Well, thank you for that very helpful information. I guess my only response is that the severity of disease due to COVID has decreased since, I think you said 22, 23. We know that there are many fewer hospitalizations now than there were then. Whether that reflects mutations in the virus that lead to less severe disease, or whether we all have a baseline immunity from the vaccine and or infection, I guess is hard. Is a hard question to answer. But thank you for that that answer. I would also, I guess it would also apply to the question of deaths due to SARS-CoV-2. How many of the deaths occurred people who had respiratory symptoms or other symptoms referral to a viral infection, and how many simply had a positive throat swab? Because many hospitals have required a throat swab on anybody who's admitted and then is classified as SARS infection.
Yes, thank you. That's an excellent question. And we actually have an ongoing analysis looking at deaths. We're compiling the most recent years of death certificate data. And we'll be, we're actually in the sort of the mid stages of that now, and we hope to present it to ACIP when we have findings in the future. One thing I would also note too about the COVID hospitalizations is one of the things that we knew early on in the pandemic was everyone being presenting to a hospital was being screened for COVID, and we know that that is no longer necessarily the practice in most hospitals. So what we have seen, at least preliminarily, with the 21, 22, and 22, 23 data in our published COVID hospitalization paper, is that the proportion of hospitalizations attributable to COVID has actually increased slightly over time, likely as a result of decreased screening. So the number of asymptomatic people being screened has decreased. So the people that are being tested for COVID-19 are more likely to be those that come in and have some sort of symptom of COVID-19 related illness.
Dr. Meisner, you said you had one more question?
I've got All right, let me ask, okay, a quick point I want to make is that looking at the most recent CDC data on hospitalization rates among children 0 to 4 years of age, it's less than one hospitalization per 100,000 children. And I think that's, even if we look at children under 6 months of age, looking at that same table, it's 1.6 hospitalizations per 100,000. Is that a correct interpretation? So it's my point is, this is a very rare illness in young children, as well as in adults now.
I mean, I would also just make sure we also think and point to overall cumulative numbers that there are, cumulative numbers, this does remain a substantial burden, particularly among the youngest and oldest age groups. To me, I think some of the comparisons to influenza, if you go back through the slides, are, I think, quite telling that there are still areas for concern with COVID-19.
Okay, but do you think those rates are accurate?
Yeah, so the rates from COVIDNet has been, really a very robust platform that it's captured about 10% of the U.S. population, allows very well characterization of illness. And then, from there, our modeled rates to the entire country. Obviously, there's a certain degree of broadness of the confidence intervals, but I think, we're really talking about a pretty comfortable ballpark in terms of the burden estimates.
Okay, and let me just, and make a comment about the reference to influenza. I think early on, many people, including myself, made comparisons with influenza, but I think we've come to find that that's probably not, that the orthomyxoviruses behave quite differently than this coronavirus. And that's why you mentioned shift versus drift. I think many people have suggested not continuing with that comparison with influenza, because it's a very different virus. So I have a bunch more questions, but I don't want to hold up everybody.
Yeah, so I would say, I think when we compared rates, I think your point is well taken. The goal is not to imply that the pathophysiology of influenza is the same as COVID-19. It's more a sense of the population burden, but I certainly appreciate that distinction. I think similarly, it's maybe a fair comment to think about whether differing terminology from drift and shift should be used for COVID-19. I think the point being is that we've seen at occasions kind of these large punctuated changes in the circulating COVID-19 virus that allows it to evade pre-existing immunity. So, I think that's the underlying point, but, it may be worth, I'm also looking at my influenza colleague here, worth thinking about whether different terminology should be used for large, rapid changes in the dominant COVID-19 the dominant COVID-19 variant that circulates.
Okay, thank you for that very interesting discussion, and I think we have a question from Dr. Levi.
Yeah, thank you. I have multiple questions, but I'm going to focus on two. The first one is building on what Dr. Koldorf asked about the method. So I'm just looking at the previous slides. Am I understanding correctly that if I look on the over 65 and I look on the percentage of people hospitalized for COVID, about 65% of them did not were not updated on their COVID dose. But at the same time, when I look on the vaccination rates of that particular same age, it does actually look that the vaccinated, the people with updated vaccination are overrepresented in the hospitalization. And to some extent, if I look on the methods that is being used to analyze the vaccine efficacy, if the vaccinated are overrepresented in the COVID arm, but also slightly less overrepresented in the other arm, we might conclude that the vaccine is effective based on this method because it's just a relative comparison. But would that be really the real conclusion? So I guess my question is, did we kind of scrutinize what are alternative explanations to the analysis that was conducted about the efficacy that might not point to an efficacy of the vaccine, but maybe to a different direction?
If I think I'm following your question, it's probably a question about how much we've been able to control for certain confounding variables.
So let me be more precise. So the method that you're currently using is comparing the relative fraction of people that are updated with their vaccinations between people that came and were tested positive versus people that came and tested negative. And a possible scenario to conclude that the vaccine is effective if they are represented in both scenarios, but just slightly less on the one in which they tested negative. In that case, you will assume that they are that the vaccine is protective, but the only thing, but an alternative explanation would be that the vaccine is actually making you more vulnerable for multiple viruses, including COVID, but maybe more so on other viruses than COVID, and the perception is that it's effective. And there are other scenarios. I think that there are other scenarios that you can take the same results that are presented and potentially think about alternative explanations that do not point out to vaccine efficacy, but maybe to vaccine lack of efficacy or deficiency, even, if I may say.
No, that's one of the weaknesses with the test negative design.
Yeah, so I just wanted to make it more precise because some of the data here suggests that maybe actually that's actually happening because the rate of, it seems that the rate of people that are hospitalized with updated vaccination is actually higher than their relative proportion in the population. And that's kind of should make you at least concerned about these options.
Let me link over to, I think, Dr. Link Gels, who's our SMA on methodology, is online.
Hi, yes, thank you. So the goal of a test negative design is to use the controls to represent the vaccination coverage in the population that gave rise to the cases. So one of the benefits of the test negative design is that these are individuals who had the same symptoms as the cases and sought testing and medical care at the same facilities as the cases. And so in that sense, these are population-based controls, even though it is a test negative case control design. And then I would add that the representation of the controls in this case, these are not the general population in that they are elderly people who are hospitalized with acute respiratory illness. And therefore, we would not expect them to have the same vaccination coverage as in the unhospitalized, likely healthier general US population. They're really meant to be representative as much as possible of people who, if they had COVID, would have sought medical care or been hospitalized at the same location. And so for that reason, we think that the controls here are exactly what we would want to understand the relative impact of the vaccination.
I think we have a question from Dr. Bethel.
Yes. Yes, hi, I'm sorry to ask a question as the FDA ex officio, but I'm very excited to be able to talk with the first author of this study, looking at the test negative design, and I share Dr. Koldorf and Dr. Levy's concerns about the potential for confounding, and I'm wondering, you know, if the goal is to really have comparable groups with comparable symptoms, you know, one that happens to test positive for COVID and one that doesn't, why exclude the patients that test positive for influenza and then those over 60 that test positive for RSV? And, you know, are we not concerned that these may be fundamentally different groups of people that are, you know, seeking medical care but happen to test positive for COVID-19 versus something else? And it's really difficult to say their symptoms are exactly comparable. And so, you know, just to get my point in, I think I share a lot of people on this panel's desire to see randomized controlled trials to minimize these types of bias, so we aren't sitting here saying, you know, wondering, you know, are we being misled by these data? So thanks for your response to that.
Yeah, thank you for that. So I would add to my previous answer that I think if you include controls or cases that test positive for another vaccine-preventable disease, you are actually going to add bias to your study. And there's been quite a lot of published literature by Dahl et al. And others showing that this would happen. And so for that reason, we dropped controls that tested positive for flu or RSV because the vaccine status is actually correlated. And so if you had a positive control for influenza, they would be less likely to be influenza vaccinated, also would mean they'd be less likely to be COVID vaccinated, because we know that COVID and flu vaccine status are highly correlated. We also do quite a lot of work with the study sites to make sure that the cases and controls have similar symptoms. And we have looked at a number of cases and published looking at number of symptoms among cases and controls, severity of symptoms among cases and controls to ensure that our case and control populations are balanced in that respect. As far as the question about clinical trials, I would actually defer that back to you all at FDA.
Yeah, we're working on that. Thanks. Yeah, thanks for the response.
You know, and I would actually maybe weigh in on what other aspect of this with clinical trials, just realizing some of the real world realities of the time and cost it takes to do clinical trials. And I think the test negative design has provided a robust way to, in a very timely manner, get real world data. I mean, to realistically say that, you know, this is June and we're looking at VE data from this last season is the timing, it would not be possible from a temporal or a cost standpoint to be able to, for CDC to be able to do randomized clinical trials with that. So I think this is, it's for us, it's served a robust way to be able to rapidly get real world data very efficiently.
Dr. Levi?
Yeah, I guess my second question is maybe on a completely different topic. So I was looking on the evolution, the genome evolution of the variants. And there are two striking jumps. You see continuous kind of evolution and then two major jumps. And I have two questions related to that. One of them is, did we do any analysis to compare that to other viruses like influenza, for which we have similar data, to see if that's kind of a common pattern, or these jumps, how common these jumps are at once, almost at once? And if they are not common, or what could be some evolutionary pressures that, because usually these jumps come from some pressure, of evolutionary pressure. And so to what extent that was analyzed, and maybe also to see if are there any connections to the vaccination policy that we have and that evolution and the evolution of the variants. That seems at least kind of striking in terms of its shape, its pattern. So
I think we have one more comment from Dr. Meissner, and then maybe I think we should move on.
Do you want me to quickly comment on the,
yes, please,
the evolutionary aspect? Yeah, I mean, this has been, I think it's, has been a it's a field we've been continuing to learn. COVID-19 has thrown us many surprises. Omicron, I think, is a classic example of that, where it was a massive change. It came out of nowhere and caused an incredible infection. I think we've also seen these other punctuated changes. There are likely aspects of selective pressure within the human population due to, say, pre-existing immunity. I think there are also unusual aspects of the virus. So I think it's a complex dynamic. There's obviously been a ton of work in the space of monitoring variants, being able to provide sequencing data real time. So, I think it's crucial that we continue to have the capacity to be able to monitor for if and when these surprises occur.
Thank you, and Dr. Meissner?
Thank you very much. I just want to add to the complexity of what was just being said, because we're now seeing convergent evolution. That is, various strains are developing the same mutations in certain areas. So of the spike protein. So this is a really tough issue to sort out. The one point I wanted to say in regard to the case controlled design, it isn't perfect, and I think that's what we're hearing, but it's the best we can do in a limited time period. For example, that's what we use to assess influenza vaccines, which change every year. So, I mean, a case control, as Dr. Link Ellis pointed out, I mean, that sure, it has biases in favor of a person who's more likely to seek medical attention. So there are problems, but it is a pretty well established design for looking at vaccines over.
Thank you, and I think we have to distinguish between a traditional case control study versus a test negative design, because methodologically I think those are very different in terms of the quality of the information. But we will now have to move on with Dr. Sarah Meyer from CDC, who will talk about COVID-19 vaccine safety issues. Thank you.
Good afternoon. My name is Sarah Meyer. I'm a pediatrician and the director of the Immunization Safety Office. Today, I'll be sharing an update on CDC's COVID-19 vaccine safety monitoring. The goal of this presentation is to share with the committee how CDC monitors COVID-19 vaccine safety and what we have found through 4.5 years of monitoring these vaccines. Before I get into the details, I want to state the bottom line up front. CDC and interagency partners launched an extensive vaccine safety monitoring program for COVID-19 vaccines. Many potential safety outcomes were rigorously assessed through complementary passive and active systems. Myocarditis has been causally associated with mRNA COVID-19 vaccines. In addition, adverse events common to all vaccines, such as local and systemic reactions and allergic reactions, have been observed. CDC continues to monitor the safety of COVID-19 vaccines. I apologize. Let me get the slide to move. Vaccine safety monitoring is a key component of the entire vaccine life cycle. From the preclinical research and development to clinical trials and the reviews by regulatory agencies and advisory groups, safety is evaluated at every step. After a vaccine has been authorized or approved, CDC safety monitoring begins, alongside our interagency partners, FDA, Indian Health Service, Department of Defense, and Department of Veterans Affairs. CDC uses strong complementary systems in a layered approach to rapidly detect and assess potential safety concerns in order for public health officials and policymakers to take appropriate action. Most of these systems have been in place for decades, but we are continuing to improve the existing systems as well as identify new systems that are needed to fill gaps, such as vSafe, which was launched to monitor COVID-19 vaccines. Next, I will briefly describe each of these systems in more detail. I'll start with the Vaccine Adverse Event Reporting System, or VAERS. VAERS serves as our nation's early warning system for vaccine safety. This system is co-managed with FDA and involves nationwide spontaneous reporting to rapidly detect safety signals, including rare events. Healthcare providers and manufacturers are required under the National Childhood Vaccine Injury Act to submit VAERS reports for certain types of adverse events in vaccines. However, reports are encouraged from anyone, such as patients or their family member. An important point to stress is that a report to VAERS does not mean that a vaccine caused an adverse event. VAERS is used for signal detection and hypothesis generation, and in most situations is not able to assess for causality. The Vaccine Safety Data Link, or VSD, is a collaborative model for generating high-quality vaccine safety data. 13 integrated healthcare organizations participate in this network, covering around 15.5 million people per year. VSD involves active surveillance using electronic medical records and chart reviews. This allows for rapid monitoring for pre-specified events of interest, as well as for monitoring for unexpected events. As opposed to VAERS, which is used for signal detection, VSD can both detect as well as assess safety signals. Another hallmark of the VSD is the strong expertise in this network, which has allowed for the development of innovative methods for monitoring safety. The Clinical Immunization Safety Assessment, or CISA project, is a network to guide vaccine safety from the individual to the population level. The CISA project includes 8 medical research centers with vaccine safety experts and subspecialists. CISA consultants provide individual clinical consultations on complex immunization issues to help guide patient care. CISA investigators also conduct clinical research on vaccine safety, geared towards real-world issues not assessed in pre-licensure trials. Finally, CISA consultants help to inform CDC public health guidance on clinical immunization safety issues. Lastly, the vSafe After Vaccination Health Checker is CDC's newest tool and involves direct-to-consumer vaccine safety monitoring. vSafe is a smartphone and computer-based self-reported active monitoring system established during the COVID-19 pandemic. It can serve as the earliest source of information on reactogenicity and other health events for new vaccines and in populations excluded from clinical trials. For example, vSafe provided a conduit to enroll more than 23,000 pregnant women into a voluntary registry to monitor maternal and neonatal outcomes after COVID-19 vaccination. Because it is flexible and able to be rapidly deployed, vSafe is an important tool for emergency preparedness and response. In addition, vSafe is integrated with VAERS to help streamline reporting of serious adverse events. These systems serve as the foundation for CDC's comprehensive approach to studying COVID-19 vaccine safety. This approach includes surveillance to analyze spontaneously reported events, epidemiologic studies to assess specific safety questions, clinical research to help guide clinical practice, a pregnancy registry for a longitudinal assessment of maternal and infant outcomes after COVID-19 vaccination, rapid cycle analyses to quickly detect potential concerns that require further investigation, data mining to assess for over 60,000 potential outcomes in order to detect unexpected events after vaccination, and patient surveys to assess symptoms and health impacts following vaccination. The summary of evidence I'll be presenting in subsequent slides represents a vast body of evidence. Since COVID-19 vaccines were rolled out in December 2025, safety of COVID-19 vaccines is documented in 17 vaccine safety technical workgroup reports, 28 presentations to federal advisory committees, 29 publications in the MMWR, 114 published manuscripts, and nearly 10 million people enrolled in our newest vaccine safety monitoring system, vSafe. This extensive collection of vaccine safety data occurred during the largest vaccination effort in US history, with approximately 1 billion vaccine doses distributed. To quickly recap, there were 3 types of COVID-19 vaccines that were authorized or approved in the United States. mRNA vaccines by Pfizer-BioNTech and Moderna, a protein-based vaccine by Novavax, and a viral vector-based vaccine by Janssen. However, Janssen use was limited in the United States. By April 2021, VAERS detected 6 reports of thrombosis with thrombocytopenia syndrome, or TTS. FDA and CDC issued a 10-day pause in use of the vaccine. By December of that year, ACIP issued a preferential recommendation for mRNA vaccines over the use of Janssen. By June 2023, the EUA for Janssen was revoked, and the vaccine is no longer in use in the United States. The Janssen experience highlights an example of federal safety systems working together to rapidly identify and mitigate a vaccine safety issue. I won't be discussing safety of Janssen COVID-19 vaccine any further in this presentation. For Novavax, there are currently limited post-authorization safety data available in the US. This product was authorized later than the mRNA vaccines in July 2022, and there has been limited uptake in the United States. Therefore, I won't be discussing Novavax during this presentation either. Thus, I will focus the remainder of this talk on the safety of mRNA COVID-19 vaccines, for which a large body of evidence has accrued over the past few years. Here I'll describe what we have learned from monitoring the safety of COVID-19 vaccines at CDC. CDC has evaluated at least 65 specific outcomes to assess COVID-19 vaccine safety using a variety of systems and epidemiologic methods. We have conducted weekly sequential monitoring through rapid cycle analyses, or RCAs, in the VSD since the start of the vaccine rollout in December 2020, of up to 23 pre-specified outcomes among over 12 million people. These outcomes were selected based on clinical trial data, known safety findings with other vaccines, or biological plausibility. Sequential statistical testing using automated ICD-10 codes is used to compare incidence of an outcome in vaccinated people during a post-vaccination risk interval versus vaccinated people in a comparison interval. If a potential statistical signal is detected, additional analyses and/or chart reviews are conducted. The system is designed to be sensitive. Not all detected signals represent a true safety concern. From 2020 to 2025, 8 statistical signals have been detected through VSD's weekly rapid cycle analyses. These include acute myocardial infarction, venous thromboembolism, immune thrombocytopenic purpura, ischemic stroke, seizure, Guillain-Barré syndrome, Bell's palsy, and myocarditis. After a signal is detected, CDC undertakes further investigations to determine whether a true safety concern is present, or whether the statistical signal represents a false positive. These include chart reviews, a trend analysis of the reported rate ratios, cluster analyses, additional studies, such as self-controlled case series, and querying other monitoring systems such as VAERS or databases managed by interagency partners, including the FDA and VA. After completing these investigations, CDC assessed that there is an increased risk for myocarditis following mRNA COVID-19 vaccines. There has been no clear or consistent evidence of a safety concern for the other outcomes I mentioned. Using data from the Vaccine Safety Data Link, this figure shows the incidence of myocarditis per million doses administered within 7 days of vaccination among 12 to 39-year-olds by season and dose. In general, rates of myocarditis peak in 16 to 17-year-olds and are higher in males. Myocarditis is rare in children aged less than 12 years or in adults greater than 50 years of age. As you can see, the risk was highest after the second dose in the primary series, but remained elevated after the first monovalent booster. In subsequent seasons, the incidence has been lower and is more similar to the background rate of less than 2 cases per million population. We have seen similar patterns with VAERS reports as well. There are a few possible reasons for these lower myocarditis rates in recent years. At this stage, adolescents and adults have been eligible for multiple vaccine doses. In addition, the longer interdose interval, where most people are getting a dose only once per year at most, is another potential factor. There may be others, like higher levels of overall population immunity. FDA has also recently shared updated data on myocarditis and pericarditis following mRNA COVID-19 vaccination from the Biologics Effectiveness and Safety System, or BEST, from the 2023-2024 season. FDA issued safety labeling change notification letters to the manufacturers in April to include new safety information on myocarditis and pericarditis. And today, FDA approved safety labeling changes for Comirnaty and Spikevax to include this new safety information. CDC has conducted follow-up studies that show most adolescents and young adults have recovered from myocarditis. These studies are based on surveys of individuals aged 12 to 29 years with myocarditis after mRNA COVID-19 vaccine, for whom a VAERS report was filed during January to November 2021, and their healthcare providers. Based on cardiologist or other healthcare provider assessment, 83% of patients were considered fully or probably recovered by 90 days after onset of myocarditis. And by 1 year, at least 90% were considered fully or probably recovered. Most people experienced improvement in their symptoms and cardiac imaging and testing results. However, there was a subset of patients who underwent a cardiac MRI at least 1 year after onset. The most common abnormality seen was late gadolinium enhancement, which could indicate fibrosis. The clinical significance of this finding is unclear, especially as most of these patients were considered recovered by their provider and had been cleared for all activity. There were no known deaths or cardiac transplants among this group. Next, I'll review COVID-19 vaccine safety in children ages 6 months to 11 years. The risk of myocarditis following COVID-19 vaccines in children aged less than 12 years is low, particularly for those aged 6 months to 5 years. Active sequential analyses in the Vaccine Safety Data Link have demonstrated no statistical signals for myocarditis in children. Furthermore, there have been no confirmed cases of myocarditis in children less than 5 years of age in either VAERS or the VSD. In addition, rapid cycle analyses in the VSD demonstrate no increased risk for 22 other pre-specified outcomes following COVID-19 vaccination. Finally, evaluations to assess multisystem inflammatory syndrome in children, or MISC, following COVID-19 vaccination have demonstrated that most patients had evidence of preceding SARS-CoV-2 infection. One issue I wanted to note is that the majority of COVID-19 vaccine reports submitted to VAERS in children aged less than 12 years of age are related to vaccine administration errors. Approximately 74% of reports in children aged 6 months to 4 years and 70% of reports in children aged 5 to 11 years were related to vaccine administration errors from October 2021, when vaccines were first authorized in this age group, to April 2025. Few of these reports included an actual adverse event. They were simply reporting an error in administration, with most of them related to expired product administered, incorrect dose administered, incorrect product formulation administered, product administered to patient of an inappropriate age, and product preparation error or issue. The high proportion of VAERS reports related to vaccine administration errors in this age group is likely related to the complexity of the pediatric COVID-19 vaccination program, especially earlier in the rollout, with different products requiring different dosing regimens, changing recommendations, and complicated storage and handling requirements. CDC is expanding its work to prevent vaccine administration errors in collaboration with FDA. Some of CDC's available resources for healthcare providers are shown on this slide. Next, I'll discuss CDC's activities to assess the safety of COVID-19 vaccines in pregnant women. CDC launched a voluntary COVID-19 vaccine pregnancy registry, which enrolled over 23,000 pregnant women. We have conducted 7 observational studies based on survey and medical record information. We have also evaluated the safety of COVID-19 vaccines in over 45,000 pregnant women in the VSD, with 11 cohort case control and surveillance evaluations to date. Across these CDC studies, the evidence shows no increased risk between COVID-19 vaccines and maternal outcomes, including 25 medically attended adverse events, serious acute adverse events, pregnancy-related conditions, and maternal ICU admission. In addition, maternal vaccination was not associated with pregnancy outcomes, including miscarriage, stillbirth, preterm birth, and small for gestational age. Maternal COVID-19 vaccination was also not associated with major birth defects, neonatal ICU admission, or infant deaths. CDC has also conducted studies to address vaccine safety concerns from the public. For example, based on reports of abnormal uterine bleeding after receipt of a COVID-19 vaccine, CDC conducted studies in VAERS, VSD, and VSafe. VSD studies demonstrated that the availability of COVID-19 vaccines was not associated with a change in incidence of medically attended abnormal uterine or postmenopausal bleeding. In addition, the receipt of COVID-19 vaccine was not associated with greater bleeding severity. CDC also assessed whether COVID-19 vaccines were associated with the development of tinnitus by conducting data mining through VAERS and VSD. Based on the lack of signals detected in either system for tinnitus, the findings from CDC studies did not support an increased risk of tinnitus after COVID-19 vaccine. Next, I'll describe CDC's activities for safety monitoring of death reports following mRNA COVID-19 vaccination, first starting with our analysis in VAERS. As of May 30th, 2025, there have been 19,417 domestic deaths reported to VAERS after COVID-19 vaccination. Before I delve further into the data, there are a few important considerations related to evaluation of death reports in VAERS. First, the FDA emergency use authorizations and CDC COVID-19 vaccination program provider agreements required healthcare providers to report all deaths following COVID-19 vaccination to VAERS, regardless of cause or circumstances surrounding the death. Of note, this requirement does not apply to other vaccines. In addition, VAERS generally cannot assess causality of adverse event reports, including deaths. We conducted an evaluation of deaths following mRNA COVID-19 vaccination in VAERS through January 31st, 2023, which I will describe in the next set of slides. During this time period, there were 17,631 domestic VAERS reports of death following COVID-19 vaccine. CDC takes every report to VAERS seriously, especially deaths. CDC requests medical records, death certificates, and autopsy reports for every death reported to VAERS. After review by a CDC clinician, 52 of these reports were determined not to be a death and were excluded from the analysis. An additional 1,790 reports were excluded because the vaccine type received was something other than an mRNA vaccine, which was the focus of this analysis. 2,940 reports were excluded because we had no information on the cause of death, despite exhaustive efforts to obtain this information. This leaves us with 12,849 reports with a cause of death available through autopsy, death certificate, medical record, and in a minority of reports through the VAERS report alone. The cause of death was classified based on ICD-10 categories. Among these reports, approximately 78% were aged 65 years and older, 15% were 50 to 64 years of age, 6% were 18 to 49 years of age, and 0.5% were aged less than 18 years of age. Next, we assessed all deaths reported in the general US population during this time period. These data are based on death certificates for US residents, which are maintained in the National Center for Health Statistics Multiple Cause of Death database. These data on cause of death are categorized by ICD-10 diagnostic codes. We then conducted observed to expected ratio analyses for each age group by comparing the number of observed cause-specific deaths among vaccinated persons reported to VAERS to the number of expected deaths in the US population within 42 days of vaccination with an mRNA COVID-19 vaccine. We found that the reported rates of death after mRNA COVID-19 vaccination were below background rates of death in the general US population. The most common cause of death reported to VAERS are generally consistent with leading causes of death in the US population. If you look by age group, you can see that for all ages, the leading causes of death among VAERS reports were diseases of the heart, COVID-19 disease, cerebrovascular diseases, and general signs and symptoms, which primarily included people whose cause of death was listed as shock. For children, congenital malformation was also reported, and for adults 18 years and older, malignant neoplasm was included. Across the board, the observed to expected ratio was below 1, which indicates a lower observed death rate than what would have been expected within the post-vaccination period of 42 days. Even when taking into account the limitations of VAERS, these findings suggest no association between COVID-19 vaccination and mortality. In addition to reviewing reports in VAERS, we conducted two self-controlled case series evaluations in the Vaccine Safety Data Link, one in the general population aged 12 years and older, and one in Medicare beneficiaries aged 65 years and older. We looked at Pfizer and Moderna vaccines separately and found that in both studies, there was no increased risk in the 28 days after vaccination for non-COVID mortality, all-cause mortality, cardiac-related mortality, and non-COVID cardiac-related mortality, as shown by the relative incidence rates that are all significantly below 1. These results are consistent with a separate cohort analysis conducted through the VSD as well. The robust methods used for these VSD analyses provide further confidence of no increased risk of mortality after mRNA COVID-19 vaccines. In fact, there appears to be a protective effect of vaccination. I've gone through a snapshot of data that CDC has collected to assess for adverse events after COVID-19 vaccination. But you may be wondering, how do we know we're not missing something we're not even looking for? And the answer to that is CDC uses data mining in the Vaccine Safety Data Link to assess for unexpected events after COVID-19 vaccination. This allows us to assess for over 60,000 possible adverse events in the 70 days after vaccination using tree-based data mining of ICD-10 codes. We have done these assessments for the primary series, the initial booster, and the bivalent booster. Through these analyses, we have not identified any new safety concerns outside of known events, including myocarditis and pericarditis, allergic reactions, and common local and systemic reactions. So to summarize, we have identified several adverse events following mRNA COVID-19 vaccines. Most of these, including local and systemic reactions, acute allergic reactions, syncope, and shoulder injuries, can occur with any vaccine. Myocarditis and pericarditis have been observed following COVID-19 vaccination. We arrived at these conclusions by evaluating at least 65 specific safety outcomes, conducted data mining of at least 60,000 potential outcomes for unexpected concerns, investigated numerous statistical signals, and conducted many epidemiologic studies. Our findings are consistent with the National Academies of Sciences, Engineering, and Medicine in their consensus report on adverse effects of COVID-19 vaccines. This report was commissioned by HRSA and published in 2024. Over 400 studies on the safety of COVID-19 vaccines were reviewed as part of this evaluation. NASEM concluded that the evidence supported a causal association between mRNA COVID-19 vaccines and myocarditis, and that the evidence favors rejection of a causal relationship between vaccination and 6 additional outcomes, including Guillain-Barré syndrome, Bell's palsy, TTS, myocardial infarction, ischemic stroke, and female infertility. The evidence was inadequate to accept or reject a causal relationship for 13 other outcomes. In summary, COVID-19 vaccines have been evaluated under the most extensive vaccine safety monitoring program in US history. Safety surveillance rapidly identified and characterized the risk of myocarditis after mRNA COVID-19 vaccination. We identified no other confirmed safety concerns except those seen with any other vaccine, such as local and systemic reactions or allergic reactions. CDC continues to prioritize the monitoring of COVID-19 vaccine safety with at least 30 ongoing studies or activities. Next, I'll turn it to Dr. Georgina Peacock to review vaccine coverage and implementation. Thank you.
Thank you so much. Before we go on, we have an CDC SME on the line, Chris Taylor. Dr. Taylor, if you would please ask your or respond to the questions from the previous session. Thank you.
Hi, thank you. Yes, I just wanted to circle back. There was a question about the rates among the young children that were presented for COVIDnet that Dr. McNeil presented previously. I just wanted to point out that on the slides, what we show are cumulative rates, which are the sum of weekly rates over a period of time. And as Dr. McNeil presented, over the July 2024 through May 2025 period, rates among young children, children less than 6 months, their cumulative rate was 268 hospitalizations per 100,000 population. I wanted to clarify because I think if you were to just look at the weekly rates, week by week, those do seem very small, but as we present them cumulatively over a season or a period of months, they are larger. And as Dr. McNeil presented that, the cumulative rates for infants less than 6 months of age are comparable to adults 65 to 74 years of age, around 270 per 100,000. And we see a similar pattern for children 6 to 23 months of age. That cumulative rate over that basically 1 year period is 100 per 100,000, comparable to adults 50 to 64 years of age that are 103 per 100,000. Again, those are cumulative rates, which are the sum of cumulative weekly rates for a period of time.
Thank you. Dr. Levy?
Just a quick question. If I would take those proportions and I just look on overall hospitalizations from all causes on these age groups, would I get different proportions or similar proportions? In other words, do we see here something that is deviating from the pattern of general rates of hospitalizations among different age groups, or this is just consistent with those patterns? So.
I guess I would say that COVIDnet, as one of the ResNet platforms, is limited to examining and collecting data on SARS-CoV-2 positive COVID-19 associated hospitalizations. So we have not done an analysis that compares the general population. However, I will say at previous ACIP meetings, we do have an analysis that examines rates of underlying conditions among adults hospitalized with COVID-19 versus those in the general population. And so we were able to identify certain underlying conditions that increase an adult's risk for COVID hospitalization. But we have not, we're not in a position with COVIDnet data to compare COVID hospitalization rates to general hospitalization rates. That's not data that we have. But thank you.
Dr. Hiblin.
Captain Myers, thank you for your clear presentation of safety. I've always had an interest in risk-benefit calculations, and I'd like to see if this concords in a broad category. It seems to me that you're presenting very few, if none, if no risks of death for receiving a COVID vaccination. And in broad measure, Dr. McNeil's presentations was that there's a substantial risk of not receiving a vaccination, and the benefit of receiving a vaccination would be at least a 40%, 50% reduction in risk, just in broad terms. So the risk of an adverse event, for example, death, from getting a vaccination is 0, and by broad strokes, the benefit of getting a vaccination is a 40 to 50% reduction of risk. Is this a reasonable, broad scope evaluation of risks and benefits?
Thank you for that question. You know, I think you're correct that we have done several studies now to look for increased risk of mortality after COVID-19 vaccines, and we have not seen that in our data. Through the VAERS assessment, where we looked at what we would have expected, you know, is it above expected? And the answer is no. When we looked at in the VSD, is there any increased risk of mortality after COVID-19 vaccines? We didn't see an increased mortality in COVID-19 vaccines. So I think from a safety perspective, we feel confident in our data that there's no increased risk of mortality after COVID-19 vaccines. But in terms of, you know, the risk-benefit assessment, you know, that, I look forward to hearing, you know, from the committee their assessment of that risk and benefits. I don't know if my colleague wants to add anything on the benefit side.
Yeah, I mean, I just, I was playing around with the ballpark calculation here. So let's say we figure there were about 40,000 deaths due to COVID-19 last year. Hypothetically, let's say nobody was vaccinated in that population. Then if you look at the other side, let's say all 40,000 of those hypothetical deaths were vaccinated with the VE, the added benefit of VE. That would mean about half of those, so about 20,000 of the 40,000 deaths would not occur. So that's kind of, I back the envelope, thought about what added benefits on the death side are.
Dr. Malone.
Thanks. I had a number of questions and very much appreciated your ability to rock through data on a short period of time. But we've moved on from that section. Regarding the safety monitoring, just for clarification, there are 2 windows of time post-vaccination. Post-vaccination being defined as having completed at least 2 doses, correct?
Are you referring to a specific analyses, like the rapid cycle analyses, or are you speaking more generally?
I'm speaking of the data that you've shared here. So the windows of time that you're presenting data on are either 28-day or 42-day post-vaccination, defined as fill in the blank.
Okay, for death analyses, yes, that is correct, yes.
Okay, so post-vaccination being 1 dose, 2 dose?
We looked at least 1 dose. And then for our VSD analyses, we did 3 different analyses. So we did after the primary series, so completion of a primary series. Then we did after the original booster, and then we did after the Omicron booster.
And then for the analysis of AE association, that analysis, so you were just referring to deaths. The analysis of AE association was also limited to a time window of 28 days?
We have a number of different ways that we look at. So there's a few different windows that we look at depending on kind of which analytic method we're using. I'd like to invite Eric Weintraub, who's our kind of expert in methodologies, to kind of walk through the different post-vaccination intervals that we use.
Yeah, hi, how you doing? Good afternoon. This is Eric Weintraub with the Vaccine Safety Data Link. Yeah, we set up for the primary series to look at 21-day and 42-day risk intervals following dose 1 and dose 2. And it's similar to what we've done then following each new vaccine that has come as a recommendation up to this past season. And what that allows us to do is then also scan within the 42 days to see if there's any other intervals that might be elevated using Martin Kulldorff's his clustering technique to look for increased risk during certain time periods. So it's very common for us to look at 42 days and then also look at a comparison time. And our comparison time historically for most of these outcomes are going to be days 43 to 84.
Roger. In this analysis, or these analyses, my understanding, because frankly, if you'll forgive the coaching, the slide that lists a series of AEs that have been among the 65 assessed is a little hard to, it would be preferable if that was structured in a way that we really knew what all of those 65 analyses were, and we could, sort of by alphabetical order or something. So I infer, having tried to pick through that hypertension, tachycardia, and POTS were analyzed and were not correlated.
Excuse me. So we have looked at our data a number of different ways, and I'll try to walk through some of that. When we look through VAERS, we have certain lists of pre-specified outcomes that we want to make sure that we can review and flag so that we can review those in more detail. So those are part of that list. For VSD, we do the same. We have a list of outcomes that we want to look at. And then we have other things that come up that we want to do a study on. So that comprehensive list of specific outcomes that we looked at, we can certainly provide you more detail. That was meant in a very short presentation to give you just a flavor of the things that we have been working on. So we have looked at those outcomes, but like I mentioned, we also did data mining where we don't specify what we want to look at. We just say somebody got a vaccine and we want to look to see is there anything that pops up that we weren't expecting. And we did not see any of those outcomes pop up in our data mining as well. There have been a few studies done related to those kids. For example, you mentioned POTS. There's a few studies that have been referenced in the NASM report I showed you, and but there's very limited data. There's very limited data on those outcomes. But what I can say is based on our comprehensive approach to looking forwards and backwards and sideways to try to figure out, are there any adverse events that we're missing after COVID-19 vaccination? What I showed you, myocarditis and then common reactions found with all vaccines is what we have found.
So if I can, again, gentle coaching, I think in the interests of the public interest and transparency, it would probably behoove all of us to make available some listing clarification of those types of analyses and those outcomes that have been queried. Then another follow-up, there are some data suggesting that there may have been significant lot-to-lot variability in terms of adverse event profiles. If there was lot-to-lot variability, it might make it very challenging to identify clusters of AEs that might be associated with particular lots if one is looking in aggregate. Is that a topic that has been considered, discussed, analyzed? How have you approached it? Query possibility of lot-to-lot variability. How's that been addressed? Over.
Yeah, thank you for that question. So I think the kind of answer goes back to one of the first slides I gave, is that we work very closely with our interagency partners. We all work on safety, but we all have somewhat different roles. And lot issues, those are typically assessed by FDA. So I would defer to my FDA colleague if there's anything to add there.
Thank you for your answers.
So just a clarification, POTS stands for postural orthostatic tachycardia syndrome. We have a question from Dr. Meissner and then Dr. Levi after that. So please, Dr. Meissner.
Thank you very much. And first of all, I want to compliment Dr. Meyer on a very clear and thorough presentation. So I now have a comment and then a question for Dr. Meyer. First of all, as a physician, I just want to remind everyone what VAERS is. Every resident is taught to report any adverse event that occurs after vaccination to the VAERS program. And regardless of whether it might be related to the administration of a vaccine or not, we are taught and educated and instructed to report that. So recognizing that there are tens of thousands of vaccines administered every day, there are obviously going to be a lot of adverse events that occur that are utterly unrelated to administration of the vaccine. So VAERS is not designed to determine rates. If there's a signal that's picked up in VAERS, then my understanding is that then people look more specifically, for example, in VSD to see if there is a correlation. But the vast majority of reports that are made to VAERS by either the vaccinee, the parents, the pharmaceutical company, have nothing to do with the vaccine. But we are taught to report that regardless in case there might be something that's unanticipated. So I think people need to realize that the overwhelming number of reports to VAERS are unrelated to administration of a vaccine. Now, the question that I would like to ask Dr. Meyer, and thank you for the very interesting data. That's the first time I've seen it that the rate of myocarditis was 38 per 1 million. And I think if I remember correctly, you said that the current rate is 2 cases per million. So that's probably, I would guess, the background rate of myocarditis in this population, which I think is very reassuring. But the question I have for you is relates to the long-term follow-up of myocarditis. As you pointed out, there have been studies that have reported on gadolinium-enhanced MRIs that have indicated scarring in the myocardium. And even though the vaccinee feels fine and is doing well, the concern is that may predispose to cardiac arrhythmias and death later on in life. So the question I have is, and I think the vaccine industry was asked to look at troponin levels, markers of vaccine injury to the myocardium after the vaccine, thinking about the issue of subclinical myocarditis. And could there be changes that were subclinical, but yet predisposed to arrhythmias later in life? I've never seen that data. I believe the companies were asked to generate that data, but I have not seen it, and I don't know what's happened to it. Over.
Yeah, no, thank you for bringing this up. I think with relation to your question about subclinical infection, there have been some studies, some with biomarkers, troponins assessed. with people who were asymptomatic. I think, what those data show is these people didn't have any adverse clinical outcomes, but, I think the long-term significance is something that will need to be continued to follow. And, this is something that CDC has been monitoring closely. FDA is also continuing to monitor. They have a similar study where they have found similar findings, and I believe that will also be included in the safety labeling change that will be posted soon. And I know with us and with FDA, there are continued plans to monitor this up over the long term.
Thank you for those important points by Dr. Meissner about both VAERS and myocarditis, and the very thoughtful response by Dr. Meyer. Now, Dr. Levi.
Yeah, I just wanted to raise two questions. So one of the two aspects that are very relevant when you do surveillance for safety are what outcomes you are focusing on and what risk intervals and timeframes. And I think it's fair to say that most of our traditional approaches have some implicit assumption that most of the harm is going to happen just immediately after the vaccine is being taken and is going to be reduced over time. But I wonder to what extent we need to inform or maybe change our approach when it comes to the COVID vaccine, given the quite established evidence that we currently have that, at least in some patients, there is residual mRNA and spike for months, if not years, staying in the body and distributed in different organ systems, potentially randomly across different people. It seems to me that that could challenge the sensitivity of most of our traditional approaches, and maybe we need to adapt somewhat broader set of approaches. For example, one approach could be to compare the impact of different vaccines. So in that respect, just want to point out a very, very interesting and very good, I would say, study from the VA system that compared Moderna and Pfizer vaccines in quite a matched way, and actually did show that at least it does look that the Pfizer vaccine has more adverse events following vaccination. Another example could be when you compare death rates, you have to also think about the healthy vaccinee effect. Did we compare death rates after COVID versus death rates after influenza vaccine? So I'm just asking to what extent we are considering broader set of methods given the unique attributes of these vaccines.
Well, I will defer the question related to kind of your question or comment about spike protein and kind of the immunology there. But I think with relation to how are we thinking going forward about our safety and is it well adapted to the situation, I think we feel very confident in our safety systems in the US. We have one of the best safety systems in the world, but we are continuing to think through ways of how to improve them. And I think one thing you're getting at is our ability to monitor long-term outcomes of vaccination. And obviously that's very difficult. The longer you get out from vaccination, the more you can introduce confounding effects or other things that are unrelated to the vaccine. And the ability to tease out vaccine versus other effects becomes much more challenging. But I think we would welcome input from the committee on how to better do that.
Dr. Malone?
Quick follow-up. So these polynucleotide vaccines are significantly different from traditional vaccines. We're aligned on that, particularly in the pharmacokinetics. Having a product that is associated with an antigen that is present in the body for over 700 days, according to the Yale study, is unprecedented in vaccinology. And that type of profile has been associated in animal models with characteristics that are now being observed in humans that are, we might say, is a type of immunologic adverse event, having to do with things like broad-based immunoglobulin class switching, which are really not being captured in any way by our data, and yet are fundamental to some of these concerns that are being raised about whether these products are associated with secondary effects on overall immune function that might impact other infectious diseases. This was one of the bases for one of Dr. Levy's pointed questions about the vaccine effectiveness sampling estimate method. So I infer that really in the safety analyses, what I observe are, as you point out, a kind of a traditional approach, rigorous traditional approach, world-leading rigorous traditional approach, but might be improved by considering the clinical context of a very novel product profile that is reasonable to infer that there may be delayed effects because we have this chronic exposure to antigen and also to the active material. We also have there's some evidence that there are effects broadly based on immune function, not just the narrowly focused positive effects that we think of neutralizing antibodies or et cetera. So I think the public would benefit with expanding your mission. That's a good thing, right? To include some of these immunologic potential risks and benefits, as well as the actively incorporating the possible risk of delayed onset effects, given that the pharmacokinetics of this product are very unusual compared to even live attenuated vaccines. Does that make sense to you?
Well, what I will say before turning it over to my colleague to talk more specific about the immunologic components of your question, I think, we started vaccination back in December 2020. And so we have several years now. We are continuing to monitor in a very robust way to capture any and all adverse events, even if they're cumulative over years from different doses. If we were seeing any effects on organ systems or safety concerns of any kind, we would be well equipped to pick those up in our safety systems. But I do want to give Dr. Thornburg a chance from an immunologist perspective on this question.
If you can keep that short, because we are short on time right now.
Yes, thanks. So there has been some data looked at both in preclinical studies, which are animals, and then some limited studies about protein detection and mRNA detection in human. Most of the preclinical studies in animals are indicate that protein detection is detected up to 9 days the injection site, but not in liver. And beyond that, there's no protein detected. In humans, there have been some studies. Notably, there's one that's been conducted in autopsies in 20 individuals. And in those 20 individuals, none of the patients had vaccine detected in the liver, spleen, or medicinal lymph nodes, just the auxiliary lymph node after 30 days. As far as protein detection goes in those patients, they did not detect any protein in lymph node, left ventricle, right ventricle, liver, only non-specific staining.
Thank you. Scientific discussions are fascinating and wonderful to have. very important in this case. We now have to move on because we're behind time, so I'm going to ask Dr. Georgina Peacock to talk about COVID vaccine and coverage and implementation.
All right, thank you. Good afternoon. I'm Dr. Georgina Peacock. I'm a pediatrician and the director of the Immunization Services Division, and I'll be presenting on COVID-19 vaccination implementation. Before I discuss COVID-19 vaccination coverage, I thought it would be helpful to explain the source of data that I will present. One of the data sources that the Immunization Services Division uses to obtain data on vaccine coverage, like COVID-19 vaccination and other information on immunization implementation, is the National Immunization Survey, or NIS. The NIS is a random digit dial cellular telephone survey of adults 18 years and older in the United States, local jurisdictions, and associated territories. Data for children are reported by their parent or guardian. All responses are self-reported, and the sample size is approximately 15,000 adults weekly, or about 60,000 adults monthly. The data is weighted to represent a non-institutionalized U.S. population. And so now to COVID-19 vaccination coverage. This slide shows the 2024-2025 COVID-19 vaccination coverage for at least one dose among adults 18 years and older in the bottom dark blue line, and among adults 65 years and older in the top light blue line from September 2024 through April 2025. Vaccination coverage among older adults reached 44% for one or more doses and 23% for all adults greater than 18 years. COVID vaccination coverage increased for older adults between the 2023-24 season and the 24-25 season. For those 65 to 74 years of age, vaccination coverage rose almost 5 percentage points in the most recent season, while for adults 75 years and older, coverage improved by about 8 percentage points by the end of the 24-25 season. This slide shows COVID-19 vaccination coverage estimates for the pediatric population. Approximately 5.6% of children less than 4 years of age were up to date with COVID vaccination according to current recommendations for that age group, shown in light blue. In children 5 years and older, up to date is defined as receipt of at least one vaccination since August. For children between 5 and 17 years of age, almost 16% have received at least one dose. Overall, approximately 13% of children between 6 months and 17 years of age were up to date with their COVID vaccinations at the end of April 2025. For immunocompromised adults 18 years and older who received their first COVID vaccine dose in August or September of 2024, 8% were fully vaccinated with 2 doses by the end of the season. When coverage is stratified by age, 16.6% of those in the 50 to 64 year age category were fully vaccinated, compared to 2.4% in the 18 to 49 year category and only 0.8% in the 65 year and older category. In summary, COVID-19 vaccination coverage for older adults improved in the 24-25 season compared with the previous season. Vaccination coverage for all adults greater than 18 years was similar between seasons, and approximately 13% of children between 6 months and 17 years of age were up to date with COVID vaccination at the end of April 2025. Thank you.
Levi?
Yeah, do we have data about the vaccination rates among medical professionals? I guess the motivation to ask this question is that, these are the people that are supposed to advise patients about vaccination, and I think their their acceptance of the rationale of vaccination is probably important to get some signal about how it's being accepted in the public and specifically in this population.
I think you were asking, I didn't quite hear about healthcare professionals, is that right?
Medical, yeah.
Yes,
the
okay.
healthcare professionals.
Not in this specific data set in the National Immunization Survey. We do look at that data through some other data sources, and I could bring that to another ACIP meeting or to the work group, and I can check with our SMEs that are on the line, but I don't think we have that right now.
Dr. Meissner?
Yeah, thank you, Dr. Peacock. And I have a question that's probably difficult to answer, but one that I've thought about recently. So the uptake of the vaccine is pretty low. It's less than 20% among young children, and even among the highest risks, people over 75, it's disappointingly low. But my question for you is, at what point does the reception of a vaccine or the willingness to have a vaccine administered influence the recommendations that are issued by the ACIP? I mean, is that a consideration? If children simply are getting it at a rate of less than 1 out of 5, does that impact the recommendation that you make? Over.
Well, I think that's the discussion for the committee, so I'll turn that back. I do think what we were encouraged to see this season was the increase in vaccination for those over 65 and particularly those over 75, and I do think that may reflect a few things. It reflects that healthcare providers may be providing a recommendation to those that they're seeing that have risk factors for hospitalization or increased risks for hospitalization and death. It also may, well, I'll just stop there. And obviously the recommendation that comes out of ACIP is that of the committee.
Yeah, thank you for that. My only concern is that if the CDC makes a recommendation that people simply are not going to follow, it's troubling because people lose confidence in a recommendation then. So I know there's no easy answer to this, but I think it does need to be considered at some point. Over.
I think as the committee, we have to make recommendations that is evidence-based. We have to use evidence-based medicine. But I think, there has been a recommendation in place vaccinating children, and the fact that it's so low is a reflection of the lack of trust that many parents have with the COVID vaccine recommendations that the ACIP has been giving. So it's a very important question that you're asking, Dr. Meissner. Thank you.
Thank you.
Dr. Peswell, have a question?
Just wanted to make one comment. This is Dimitri Daskalakis from NCIRD. Just to add to something that Dr. Peacock said is that part of our evidence to recommendations framework that is taken into the work group does include an assessment of feasibility and acceptability. And so I think that has historically been a piece of what's been a part of all discussions around vaccinations. Just wanted to clarify that is a piece of what is built in to the discussion that ultimately leads to discussions here and then ultimately recommendations. Thank you.
Thank you for that comment, but can I just ask, is there a threshold at which you decide making a recommendation is probably not beneficial?
I think that is actually the exact reason for the discussion in the committee. So I think that as that is reviewed in the work group, that is brought in front of the committee with the feedback from the work group, so then ultimately the committee makes recommendations that can then be reviewed. Thank you.
Thank you, and I think we have a last question from Dr. Petworth.
Yes. Thank you very much for this very enlightening presentation. I am very concerned because with uptake being as low as it is reported, and also the reports to VAERS are extremely high compared to other vaccines. They are, the last time I looked, it was about 1.6 million reports that came in. I don't know the extent to which underreporting is still an issue for this vaccine, but there are published studies suggesting that underreporting is about 10% of adverse events are actually reported. So that being the case, I think we need to be very careful and also have access to data that we probably wouldn't ordinarily have. And that is, I'm very interested in learning more about what we now know through animal studies, the studies that we would typically have for preclinical trial data, the reproductive toxicity data, the various biodistribution studies. I think this would maybe help to sort out some of the confusing information that we have. Thank you very much.
Do you want to?
Could I make a comment? I just wanted to respond to your concern about VAERS underreporting. And what I just wanted to share is that some of those reports suggesting vast underreporting in VAERS are inclusive of things like sore arm, rash, things that people don't normally report to VAERS. So I'm not sure about anyone here, but I never reported to VAERS when I had a sore arm last time for vaccination. But CDC has conducted a number of studies that we have published in the literature that shows that for serious adverse events, the reporting rate to VAERS is much higher. So it's up to 76% for anaphylaxis, depending on the vaccine, up to 64% for Guillain-Barré syndrome, again, but depending on the vaccine. We've looked at this for intussusception following rotavirus vaccine, vaccine-associated polio following polio vaccination. So I think I just wanted to point out that for serious reports, we are confident that we get a majority of those reported to VAERS.
Dr. Levi?
First, this is very useful information. I still think that if I take the myocarditis example, I still think that we can see if we actually compare the rates based on VAERS versus the rates based on clinical diagnosis versus the rates based on actually testing the troponin levels of people before and after vaccination, we see underreporting depending on the system you're using, and VAERS is probably still underreporting, maybe not at the extent of 10%. And the other thing is that I think that if I understand correctly the data, we do see in VAERS some serious adverse events and some actually new ones that are being reported at rates that are far exceeding other vaccines, even when you normalize to the number of doses, which does suggest something, I think.
Thank you. So we are behind time, so I think we're going to continue. And Dr. McNeil, please, for the last presentation of evidence to recommendations.
Sure. Thank you. I'll now briefly wrap up the COVID-19 session and discuss the evidence to recommendations for the 2025-2026 COVID-19 vaccination. And in my energy, I did not even wait for the slides to pull up. Okay. This slide shows the evidence to recommendations framework, including the domains of public health problem, benefits and harms, values, acceptability, feasibility, resource use, and equity, as well as their associated questions. The first two domains were presented to the work group for review and discussion. The rest of the ETR and final polling was planned for the final work group call. The work group has continuously reviewed data on the public health problem and the benefits and harms domains, and most recently reviewed a summary of the domains during the May 29th and June 5th work group calls. As these domains are primarily informed by the epidemiology, vaccine effectiveness, and safety presentations, data reviewed by the work group in these domains was incorporated into the previous presentations. On June 12th, the work group was planning to discuss the additional evidence to recommendations framework domains and participate in final polling before the ACIP meeting. Because the work group call was not convened, ETR was not able to be finalized, and the work group did not undergo final polling. As a summary of the work group considerations around the public health problem, burden from COVID-19 has been trending down year over year since 2001, but substantial morbidity and mortality continues to occur. Higher rates of COVID-19 hospitalization and deaths, in particular in the oldest and youngest age groups, with the highest rates in adults aged greater than 65 and infants ages 6 months and less. Children less than 2 years of age have the highest morbidity and mortality of all pediatric ages, but deaths due to COVID-19 can occur at any age. Maternal vaccination is the best protection against COVID-19 for pregnant women and infants less than 6 months of age who are too young to be vaccinated. Finally, as a summary of the work group considerations around benefits and harms, the 2024-25 COVID-19 vaccination is effective in preventing hospitalizations and critical outcomes from COVID-19 in adults. Data from prior vaccine formulations show that vaccine effectiveness has been similar across age groups. COVID-19 vaccines have been continuously monitored through robust safety surveillance, which identified and characterized the risk of myocarditis and pericarditis after mRNA COVID-19 vaccination. No other risks have been confirmed in the current US licensed vaccines except those typically seen with other vaccines, such as local and systemic reactions and allergic reactions. Pregnant women are at an increased risk of severe disease and adverse pregnancy outcomes from COVID-19. Maternal vaccination has been shown to protect infants less than 6 months of age from severe outcomes of COVID-19 vaccine. I would again like to extend my thanks to all the CDC and external collaborators who contributed to these presentations. Thank you.
Thank you so much for all these presentations and for a lively discussion, for all the comments and questions. There is no vote scheduled to be held on this topic, and I think as the ACIP, we look forward to receiving the report from the working group before the next meeting. And this has been extremely informative for all of us, so we thank all the CDC presenters and also everybody behind those presentations, because there are a lot of people working on that. So thank you so very much. And we are half an hour behind schedule, so I think we're going to take a lunch break now. I will take it half an hour as planned, and then we will reconvene here at 2 p.m. So thank you so much, everybody.
Thank you. And when we come back, for our records, I'll have to do roll call for our liaisons and our ex officio. So I'll do that at that time. Thank you.
So I hope you all had a great lunch, and we're now going to continue with agency updates. So please.
We'll start with CDC.
Good afternoon and welcome back from lunch. Thank you for the opportunity to give you an update about CDC. My name is Dimitri Daskalakis from the National Center for Immunization and Respiratory Diseases, and I'll be splitting this update with Chris Braden from the National Center for Emerging and Zoonotic Infectious Diseases. So just briefly, I think many of you are familiar, but just to quickly orient you, the National Center for Immunization and Respiratory Diseases, its mission is to prevent disease, disability, and death through immunization and by control of respiratory and related diseases. So we can always go for a much deeper dive at another time where there is more time, but instead I'm going to focus on a couple of the outbreaks that we're currently working on domestically. And so the first is the measles outbreak. As of today, CDC has reported 1,227 measles cases from 37 U.S. jurisdictions in 2025. There have been 23 outbreaks reported in 2025, and 89% of the cases of measles have been associated with those outbreaks. One specific outbreak really makes up the lion's share of infections. This is the outbreak that is occurring in the Southwest, with Texas reporting 750 cases across 35 counties, and New Mexico reporting 81 total cases, primarily in the southwestern part. There's some really good indicators that we have hit a plateau. The cases are definitely decreasing. So as we are seeing fewer cases in the Southwest, we continue to see global introductions that come into the U.S., which thankfully to date have mainly been short terminal chains of transmission as opposed to more sustained transmission like we saw in the Southwest. So our overall risk to the U.S. population is low, but we continue to have vigilance around mobility as well as populations who may not be immune. I also want to briefly highlight H5N1, affectionately called bird flu. So H5N1, as you may recall, is an outbreak that mainly affects animals. So historically, since the 90s, H5N1 has been seen in birds, and there has been spillover into poultry, so domestic, more like commercial birds. Last year, we also had the introduction of this virus into cows with a pretty significant, that's a new mammalian species that had not experienced H5N1 in the past, resulting in over 1,000 herds being diagnosed with H5N1 and spillover to humans with 70 cases reported. The folks who were at the highest risk for that infection were people who were working closely with animal products or had exposures to birds, including backyard flocks. So we have the good news that we are seeing overall a decrease in the number of infections that are being detected in non-human mammals and in birds. Specifically, a huge shout out to our USDA colleagues who are doing bulk milk testing that is detecting cases in herds earlier. The effect of that has been that to date we have had no new human cases in over 15 weeks, which I think is great news despite ongoing monitoring by local health departments. And then lastly, a lot of what we're going to be talking about in the next couple of days focuses on respiratory viruses that are important to seasonal preparedness. So we at NCIRD are responsible for the seasonal outbreak that we see every year that you've already heard in such detail about COVID. You'll hear more about flu and RSV. So we continue to work to make sure that we provide Americans the best tools to be able to prevent these infections. With that, I'll hand it over to Chris Braden, and I think we'll defer to the chair to see if we take questions now or later.
No, right now we're asking to do their presentations from the different agencies.
Chris, do you want to?
Yeah, so I'll be very brief. My name is Chris Braden. I'm the Principal Deputy Director for the National Center for Emerging and Zoonotic Infectious Diseases. There are over 800 pathogens that we're responsible for, some of which you know well and some of which are very exotic. Along the lines of the outbreaks that we are working on right now, there's a number of foodborne outbreaks that we're detecting through a system called PulseNet, which uses whole genome sequencing to match isolates that likely have a common source. We are looking at salmonella infections linked to pistachio cream right now. Again, these are multi-state, and also to eggs. Interestingly, we have a cluster of illnesses due to Botox injections. We're working with Massachusetts to investigate this cluster of illnesses. These are injections that cause a systemic illness beyond the injection site. It looks to be due to a unlicensed provider and an unlicensed facility that is providing Botox injections. We get heavily involved because CDC is the source of the botulinum antitoxin. The antitoxin is stored in port health stations that CDC runs around the country, and we provide that for clinical care. And we do consultations on all of these types of illnesses in addition to the epidemiologic investigation. The one other thing that I'll just say that emphasizes the zoonosis aspect of our work is New World screwworm, which is making its way up from Central America into Mexico right now. It is mainly an animal disease. It is led, the investigation is led by USDA, but there is a human component where New World screwworm can cause a very nasty myiasis that is basically an infestation of the maggots in skin and so forth, and they eat the live tissue. So that always is a little bit impressive. We're working with USDA on that. It is a threat right now to mostly animal agriculture, some human component in the United States as it makes its way up from Central America and Mexico. I'll stop there. Happy to talk about any of these subjects at another time. Bye.
Thank you. And the next?
And CMS.
If you have nothing, that's perfectly fine.
Okay. FDA.
Yeah, hi, Tracy Beth Hogue with the FDA. Just a few updates. I actually think I'm going to start with an update related to a question that was brought up that I'll address briefly, which is related to an announcement today of a safety label change to the mRNA vaccines reflecting the risk of myocarditis. Part of it is based on a question from Dr. Meisner related to Sarah Meyer's talk, where in 2023 and 2024, the best data, the FDA's best data, we did find a 27 per million rate of myocarditis after the mRNA vaccines in 12 to 24-year-old males, and the safety label change is going to reflect this. I wanted to differentiate that from the CDC data that was presented before that, which was not stratified in that age group or by sex, and that also had a lower rate of 2 per million, and so we think that the FDA best data is best to use for the males 12 to 24, shows an ongoing risk in the 2023-2024 season that we saw, as well as concern about ongoing myocardial damage that was seen with late gadolinium enhancement or MRI imaging about a half a year after vaccination. With uncertain clinical significance, but because of that, we did announce that there was a safety label change today to the mRNA vaccines. In other news, you probably are all familiar with, it was discussed, VRBPAC. Our VRBPAC did recommend the JN1 antigen, which was interestingly consistent with the year before, reflecting the slower rate of viral mutation that we have been discussing. And at the FDA, we also announced a new regulatory framework, which many of you are familiar with, and Nuvavaxid and mNEXSpike were approved with the narrowed indication for 12 to 64 years with one risk factor for severe COVID-19, and then 65 years and older. That was for Nuvavaxid, as well as a post-marketing commitment to a randomized control trial, placebo-controlled in adults ages 50 through 64. So we hopefully are going to get some higher quality data about current efficacy of the vaccines, and that a commitment was also given for the mNEXSpike vaccine, which is indicated in those with prior vaccination, and again, ages 12 and older, 12 to 64 with one risk factor for severe COVID-19, and then ages 65 and older. And then we also had, there was an issue that many of you are probably familiar with the IXCHIQ vaccine, that there was the FDA put a pause on that for adults ages 60 and older due to 17 adverse events and 2 deaths. And this is the live chikungunya vaccine. And then related to the myocarditis, there was a question that came up from Dr. Meisner that I just wanted to address right now, and it is FDA related about the subclinical myocarditis. That there was a study that came out by Albertson et al. That did address one of the post-marketing requirements in 5 to 30-year-olds. That was published in Infectious Diseases and Therapy, and we could hold an entire journal club on that article, but I wanted to make Dr. Meisner aware of that study. So, thanks.
Thank you. Health Resources and Services Administration. Anyone on the line?
Hi, good afternoon. This is Commander Britt Rizik with HRSA, and we have no updates at this time. Thank you.
Thank you. Indian Health Services.
Hi, good afternoon. It's Dr. Matthew Clark. The Indian Health Service is working closely with our federal, tribal, and our urban Indian organization partners to mitigate the risk of vaccine-preventable illness in our vulnerable service population. In accordance with our mission, IHS is committed to raising health status and improving health outcomes in American Indian and Alaska Native tribal communities across a wide spectrum, from the promotion of healthy lifestyles to screening and prevention, support of traditional culture and healing, and effective management of both acute and chronic diseases. As a comprehensive healthcare system for 2.1 million American Indian and Alaska Native beneficiaries, vaccination is a key component to this broader strategy. We seek to advance this strategy through proactive education, proper informed consent, and respect for patient, family, and community values and priorities. Tribal communities face many unique challenges that impact access to effective preventive clinical and public health interventions. IHS is actively working with our tribal and tribal health partners to identify vaccine prevention priorities and to establish vaccine best practices that meet the current needs of Indian country. Thank you.
Thank you. National Institute of Health.
Thank you. Mike Kurilla from NIH. No updates to report at this time.
Thank you. And now I'll have to do the roll call for our liaisons. I'll try to do it as quickly as possible. American Academy of Family Physicians.
Good afternoon. It's Dr. Laura Morris from University of Missouri representing AANP.
Thank you. American Academy of Pediatrics. Okay. American Academy of Pediatrics. Okay. American Academy of Physician Associates.
Marie-Michelle Léger, Director of Clinical Education at AAPA.
Thank you. American College of Health Association.
Hi, Ashley Halberter from the American College Health Association.
American College of Nurse Midwives.
Carol Hayes, present.
American College of Obstetrics and Gynecologists.
Hi, this is Dr. Naima Joseph, internal fetal medicine physician presenting the American College of Obstetrics and Gynecologists. And I just want to take this moment to thank you all for the invitation for having us present at this meeting today. And especially want to thank Dr. McNeil and members of the CDC for unequivocally presenting the risk of COVID-19 disease to pregnant women and their infants and the robust data that's been presented regarding their safety of immunization. Over.
Thank you. American College of Physicians. American Geriatrics Society.
Bench Pater here for AGS. Thank you.
America's Health Insurance Plans. American Immunization Registry Association.
Good afternoon, Rebecca Quill representing ERA.
Thank you. American Medical Association.
Dr. Sandra Freihofer representing the American Medical Association.
Thank you. American Nurses Association? American Osteopathic Association? American Pharmacists Association?
Hi, good afternoon. Dr. Kelly Good, representing the American Pharmacists Association.
Thank you. Association of Immunization Managers? Association for Prevention, Teaching, and Research?
Richard Zimmerman, representing APTR, present.
Thank you. Association of State and Territorial Health Officials?
Good afternoon. This is Erica McGowan, Senior Director of Emerging Infectious Disease, representing ASCO, standing in for Dr. Manisha Jutari. Thank you. Over.
Thank you. Biotechnology Innovation Organization?
Good afternoon. Phyllis Arthur and Emily Acker for Bio.
Thank you. Council of State and Territorial Epidemiologists?
Dr. Christine Hahn, representing CSTE.
Thank you. Canadian National Advisory Committee on Immunization?
Hello, Matthew Tunis for NACI.
Infectious Disease Society of America? International Society for Travel Medicine? National Association of County and City Health Officials?
This is Matt Zahn, representing NACHO, present.
Thank you. National Association of Pediatric Nurse Practitioners?
This is Dr. Stacy Buchanan, a doctorally prepared nurse practitioner representing NACNAP, a science-based membership organization of over 8,000 APRNs caring for children.
Thank you. National Foundation for Infectious Diseases?
This is Dr. Bob Hopkins and Marla Dalton for NFID, supporting preventive health for all Americans.
Thank you. National Medical Association? Pediatric Infectious Diseases Society? Pharmaceutical Research and Manufacturers of America?
Yeah, thanks. This is Dr. Michael Ibarra. I'm an emergency physician and chief medical officer representing pharma. Thank you.
Thank you. Society for Adolescent Health and Medicine? Society for Healthcare Epidemiology of America? Thank you. Society for Healthcare Epidemiology of America? Okay, I think that was the last one. Is there anyone else that did not get to introduce themselves?
Some
Dr.
people are
Jason
trying to
Goldman
introduce
is on
themselves.
for American College of Physicians, but his mic is not working.
Okay.
And this is Molly Howell, representing the Association of Immunization Managers. My mic was also not working.
Okay, thank you. I think that's it.
Thank you for that, and I appreciate all your participation in this meeting. We will now move on to discussing the RSV vaccine, maternal and pediatric, and to introduce that, Dr. Adam McNeil, please.
Good afternoon. My name is Adam McNeil, so I'm the Acting Division Director for the Coronaviruses and Other Respiratory Viruses Division within CDC. I'm now going to introduce the maternal and pediatric RSV session. Before I begin, I would like to mention that there are also RSV vaccines for adults. The policy for these vaccines is considered by a separate work group and is not covered in this session. Also, just a reminder, all slides are publicly available on the ACIP website. RSV infection is the leading cause of hospitalization in U.S. infants. RSV can infect the small airways in the lungs. Most infants are infected in the first year of life, and nearly all are infected by age 2. 2 to 3% of young infants are hospitalized for RSV. Roughly 80% of children who are hospitalized for RSV have no underlying medical conditions. In short, all young infants are at severe risk for RSV. Prior to 2023, no long-acting products were available for the prevention of severe RSV disease. In 2023, 2 products for prevention of severe RSV disease in infants were approved by the FDA and subsequently recommended by CDC and ACIP. CDC and ACIP recommend that all infants be protected against severe RSV disease with either maternal RSV vaccine or infant immunization.
Not hearing anything. Is the room muted?
I've lost audio as well.
I've also lost audio.
Same here, no audio.
Lost audio as well.
I'll speak again for the microphone. Can you hear me? Maybe also if the chair could sound check whether it's this microphone or the entire room.
We can hear you now.
Thanks. And can I ask, did you hear the start of the presentation or should I loop back to the beginning?
Go back to the beginning.
Sorry, was that beginning?
Yes.
Okay, thank you. Good afternoon. My name is Adam McNeil. I am the Acting Division Director for the Coronaviruses and Other Respiratory Viruses Division within CDC. Before I begin, I would like to mention that in addition to the maternal and pediatric RSV session, which we will discuss here, there is also a separate RSV vaccine for adults. This is considered by a separate work group and will not be covered in this session. Also, just a reminder, all slides are publicly available on the ACIP website. Next slide. RSV infection is the leading cause of hospitalization in U.S. infants. RSV can infect the small airways in the lungs. Most infants are infected in the first year of life, and nearly all are infected by age 2. 2 to 3% of young infants are hospitalized for RSV. Roughly 80% of children who are hospitalized for RSV have no underlying medical conditions. So in short, all young infants are at severe risk for RSV. Prior to 2023, no long-lasting products were available for prevention of severe RSV disease. In 2023, 2 products for prevention of severe RSV disease in infants were approved by FDA and subsequently recommended by CDC and ACIP. CDC and ACIP recommend that all infants be protected against severe RSV disease, either through maternal RSV vaccination or receipt of monoclonal antibodies to an infant. For infants, there are 2 immunizations, a maternal vaccine and a long-lasting monoclonal antibody. All infants are recommended to be protected against severe RSV disease by either the maternal RSV vaccine or nirsevimab. Only one is needed in most instances. Pregnant women should get a single dose of maternal RSV vaccine during weeks 32 through 36 weeks of pregnancy. Nirsevimab is recommended for infants younger than 8 months who are born during or entering their first RSV season. Nirsevimab is also recommended for some children aged 8 through 19 months who are at increased risk for severe RSV disease entering their second RSV season. Today, we will be reviewing data on a new long-lasting monoclonal antibody, clostridioidomab, that would become a third option to protect infants from severe RSV disease if approved. Clostridioidomab was approved by the FDA on June 9, 2025, for infants born during or entering their first RSV season. The maternal pediatric work group and ACIP review of data on clostridioidomab has been ongoing since September 2023. Since September 2024. In September 2024, the maternal pediatric RSV work group reviewed and discussed data from Merck on safety and efficacy of clostridioidomab. In October 2024, ACIP further reviewed and discussed data from Merck on safety and efficacy of clostridioidomab and the workgroup interpretation of these data. During November 2024 to April 2025, the maternal pediatric RSV workgroup reviewed and discussed the grading of recommendations, assessment, development, and evaluations of the evidence for clostridioidomab. Evidence to recommendation and the evidence to recommendations framework for clostridioidomab. Today, I will represent these data and their interpretation for the committee. Since the April 2025 ACIP meeting, the workgroup has also reviewed data on the uptake, safety, and effectiveness of maternal RSV vaccine and long-lasting antibody from the 2024-2025 season. During today's session, these data will be presented to the committee along with the workgroup interpretation. This session will include 5 presentations. The first 3 presentations will cover updates on products currently in use, including uptake of maternal RSV vaccine and long-lasting monoclonal antibody, effectiveness, impact, and safety of maternal RSV vaccine and long-lasting monoclonal antibody. Then the final 2 presentations will include the evidence to recommendation framework for clostridioidomab and the workgroup interpretations. I will now pass it off to Georgina Peacock, who will present on maternal RSV uptake of maternal RSV vaccine and nirsevimab.
Thanks, Dr. McNeil. And just as a reminder, I'm the Division Director for the Immunization Services Division, and today I'll be talking about the implementation and uptake of nirsevimab and maternal vaccination for infant protection from RSV. Before I do that, just a follow-up to a question you had earlier on our healthcare provider vaccination coverage for COVID. Those data are not available yet for this season, but we can have those at a subsequent meeting. Mm-hmm. All right, just to review the data sources that I'll use in this presentation, as I highlighted during the COVID presentation, the Immunization Services Division obtains data on vaccination coverage and other information on immunization implementation from multiple sources. First, as I already stated, the National Immunization Survey is a random digit dialed cellular telephone survey for adults 18 years and older in the United States, local jurisdictions, and associated territories. Second are the immunization information systems. These are confidential, population-based computerized databases that record all immunization doses administered by participating providers to persons residing within a given geographic area. And since 1993, CDC has funded 64 U.S. jurisdictions to implement IISs. We receive monthly aggregate data for COVID, influenza, and RSV, and quarterly line-level de-identified data for individual immunizations. And third, the Vaccine Safety Data Link, which you heard referred to by Dr. Meyer earlier, provides estimates of vaccination coverage based on electronic health data. For purposes of this presentation, VSD provides us with maternal vaccination coverage. And now for some information on coverage for nirsevimab and maternal vaccination. These data, drawn from the immunization information systems, illustrate the administration of nirsevimab by month of receipt among infants under 8 months of age. During the second season of availability, so the 2024-25 season, more infants received protection against RSV through nirsevimab administration than in the first season, 2023 to 2024. This slide is the first of 2 consecutive slides showing infant age at the time of nirsevimab receipt, stratified by birth month. This slide is for the first season of implementation, so the 2023-24 season, and the pale blue colors indicate receipt of nirsevimab closer to birth. The darker blue color indicates receipt of nirsevimab more than 1 month after birth. Infants born during the RSV season, so from October to March, received their dose of nirsevimab closer to birth than infants born before September, which is what we would expect with nirsevimab, as it's only recommended and available in most states shortly before the RSV season begins. This slide again shows receipt of nirsevimab by birth month, but for the second season of implementation. For infants born during the RSV season, more received nirsevimab within the first month of life than in the 2023-24 season, showing increased healthcare provider understanding of the appropriate administration guidance, as well as improved access to nirsevimab. This slide shows the percent of pregnant women ages 18 to 49 years vaccinated with RSV vaccine overall and by race and ethnicity during the 2024-25 respiratory season using data from the CDC's Vaccine Safety Data Link. We see that from September 2024 through January 2025, 38.5% of pregnant women were vaccinated overall. Vaccination coverage ranged from 25.7% among Black pregnant women to 52.6% among Asian pregnant women. This is fairly consistent with other vaccines during pregnancy, where we typically see the highest coverage among Asian, non-Hispanic, and white non-Hispanic women, and lowest coverage among Black, non-Hispanic, and Hispanic Latino women. This slide shows the percentage of infants less than 8 months during the respiratory virus season born since April 2024 who were protected by either maternal vaccination in the dark blue color or nirsevimab in the light blue color, using data from the National Immunization Survey Fall Respiratory Virus Module. Data were reported by women 18 to 49 years who had a baby born since April 2024, and the x-axis represents month of interview. So when we look at the most recent month, March 2025, we can see that those surveyed who had an infant born since April 2024, 12.3% of mothers received RSV vaccination during pregnancy, and for these, their infant did not receive nirsevimab, and 44.7% of infants received nirsevimab. Therefore, by March of 2025, 57% of infants born between April 2024 and March 2025 were protected by either maternal vaccination or receipt of nirsevimab. And so now I'll move to talking a little bit about some implementation that we've done, particularly around birthing hospital enrollment in the Vaccines for Children program to facilitate nirsevimab administration. So as a pediatrician, I've experienced the impact of RSV in infants. And I remember admissions when I was a pediatric resident where we had too many infants that we were admitting overnight, and in fact, even had to life flight some babies to other states and other hospitals for care. And because there weren't enough beds and there weren't enough staff to care for them. So both the maternal vaccine and the RSV monoclonal antibody are really life-saving and prevent hospitalizations. And the CDC, together with our state immunization programs, has worked really hard to ensure that critical therapeutics are available for newborns as soon as they become eligible. Since nirsevimab is recommended within the first week of life for children born in October through March in most of the continental United States, birthing hospitals play a key role in ensuring newborn children receive nirsevimab to protect them against RSV. Children who lack commercial insurance coverage, approximately 45% of children ages 0 to 17 years in the United States, are less likely to be seen by a primary care physician within 1 week of birth than children who have commercial insurance. Therefore, it's important to have an option in the birthing hospital. Birthing hospitals play a vital role in ensuring that there are no missed opportunities for RSV immunization before hospital discharge and coordination of care with pediatricians. So birthing hospital participation in VFC program promotes access to all ACIP recommended vaccines. It enables newborns to receive the immunizations they need before hospital discharge and reduces hospitals' upfront costs since hospitals do not have to pay for the nirsevimab or the hepatitis B vaccines for VFC eligible children. It also helps provide quality care to all infants who are at risk for RSV infection, regardless of insurance status. So when nirsevimab was added to the routine childhood immunization schedule in 2023, 292 of the 2,827 U.S. birthing hospitals were enrolled in the VFC program, so approximately 10%. Enrolling birthing facilities into the VFC program has required updated policy approaches, new partnerships, and intense communication on the importance of birthing hospitals playing a part in infant RSV prevention. Through the hard work and dedication of our immunization programs and other partners, we've increased the number of birthing hospitals enrolled in VFC from 292 to over 1,000 birthing hospitals, a substantial increase in less than 2 years. And so now a little bit about our plans for the 25-26 season of RSV monoclonal antibody administration in the VFC program. We anticipate that supply will be sufficient to meet demand and will also be available earlier than last season. Earlier supply enables broad availability prior to the start of immunization and promotes confidence in the program implementation. So in particular, we've been working with our state partners and professional organizations, as well as with the Indian Health Service, to improve access and uptake of both maternal vaccine and infant monoclonal antibodies. CDC will facilitate availability of RSV monoclonal antibody across jurisdictions, ensuring that each jurisdiction has access. And pre-season technical assistance is happening right now around ordering so that we can ensure that the whole process works well. We expect increased availability of 50 milligram doses of nirsevimab at the beginning of the season compared to last season, and the newly licensed clesrovimab can be available once it has been added to CDC's VFC contracts. So, in summary, in the 2024-25 season, more infants who were born during the RSV season and received nirsevimab did so in the first month of life compared to those born in the prior season of administration, so 2023-24. Likely due to increased healthcare provider awareness, as well as consumer or family awareness, as well as a greater availability of supply. Maternal immunization and RSV monoclonal antibodies protected 57% of infants born April 2024 to March 2025, showing the benefit of offering both options. Increased birthing hospital enrollment and improved early supply of RSV monoclonal antibodies should provide greater access to protection from RSV in this upcoming season. Thanks very much, and so I'll turn it back to Dr. McNeil.
Yeah, I think in the interest of time, I think we can just continue with the next presentation, and then we can save questions for a little bit later.
Okay.
Good afternoon. We will provide an update on the effectiveness and impact of nirsevimab and maternal RSV vaccination in infants during the 24-25 RSV season. I will briefly summarize how we assess product effectiveness and the systems used at CDC for these analyses. I'll then provide a summary of the observed effectiveness of nirsevimab and the maternal RSV vaccine during the 24-25 respiratory season in the United States, and provide a summary of systems used for monitoring RSV hospitalization rates and the observed impact of these prevention products. So first, overview of how CDC assesses product effectiveness in the United States. There are several study designs that can be used for product effectiveness assessment. All three data sources I'll be discussing today use a variation of the case control design, as we've discussed this morning. Two systems, Vision and NVSN, use a test negative design. In this design, infants who receive care for acute respiratory illness are tested for RSV are included. Our third platform, Overcoming Network, utilizes a matched case control design where prevention product receipt is assessed for children who are RSV positive and compared with matched children who do not have RSV. For the data I'll present today, the product effectiveness is estimated by comparing the odds of immunization in infants who are RSV positive with the odds of immunization in infants who are RSV negative. Here are a few more details for each of the three CDC platforms that we have used to assess RSV prevention product effectiveness in the United States. All three have different strengths and limitations. Vision is a multi-site electronic health record system, including visits from 160 emergency departments and 131 hospitals in 6 states. NVSN is an active surveillance network for acute respiratory illness in children at 7 pediatric academic health systems. And the Overcoming Network conducts active surveillance for infants with RSV in critical care settings in 26 pediatric intensive care units in 23 states. In this table, I briefly summarize the data and definitions used by each of these three platforms. All three platforms have a multi-step review process to verify immunization status, including electronic health records and immunization registries. For Vision and NVSN, the analytic study period for the product effectiveness I'll present today is from October 2024 to March 2025. The Overcoming study period is December 2024 to April 2025. For all studies, cases consist of children testing positive for RSV and a clinical RSV test. NVSN systematically tests all enrolled children for RSV, and thus cases may include children who did not receive clinical testing. Controls are children who test negative for RSV. For NVSN, this may include children who were not tested clinically. Importantly, the Overcoming Network enrolls matched controls based on site, age, and data hospitalization of cases. For the nirsevimab analyses, all studies included infants if they were 8 months old on October 1st, 2024, or born after October 1st during the study period. The maternal vaccine analysis for Vision included infants born on or after September 14th, 2024, which is 14 days after maternal RSV vaccine availability in most of the United States, while the NVSN analysis included infants less than 6 months of age during the study period. All analyses use multivariable logistic regression, adjusting for site, age in months, and timing of enrollment. Vision also adjusted for race, ethnicity, and sex. For nirsevimab effectiveness analyses, NVSN and Overcoming also adjusted for presence of at least one high-risk medical condition for severe RSV disease. Overcoming also adjusted for social vulnerability index. NVSN also adjusted for race and ethnicity and insurance status for maternal RSV vaccine effectiveness in the analysis. Moving on to results, first I'll present the assessment of nirsevimab effectiveness during the 24-25 RSV season in the United States. This slide summarizes the effectiveness of nirsevimab against RSV-associated emergency department or ED visits in infants during the first RSV season from Vision and NVSN. The table includes the number of children by nirsevimab and RSV status, median days since dose among those who are immunized, and adjusted product effectiveness. The data are presented by platform, with Vision data on the top and NVSN data on the bottom. Among over 4,000 ED visits in children included in the Vision analysis, 79% of RSV positive children did not receive nirsevimab, compared to 64% among RSV negative children. Similarly, among nearly 500 ED visits in children included in the NVSN analysis, 86% of RSV positive children did not receive nirsevimab, compared to 56% among RSV negative children. Among children that had received nirsevimab, the median time since dose for both networks was 68 days at the time of their ED visit. The estimated adjusted product effectiveness against RSV-associated ED visits was 63% in Vision and 76% in NVSN, with 95% confidence intervals for both point estimates overlapping between these two networks. Here we see a similar table for nirsevimab effectiveness against RSV-associated hospitalization among infants during their first RSV season. Among over 600 hospitalizations in children included in the Vision analysis, 81% of RSV-positive children did not receive nirsevimab, compared to 55% among RSV-negative children. Similarly, among nearly 700 hospitalizations in children included in the NVSN analysis, 89% of RSV-positive children did not receive nirsevimab, compared to 61% among RSV-negative children. Among children that had received nirsevimab, the median time since dose at the time of their hospitalization was 61 days in Vision and 52 days in NVSN. The estimated adjusted product effectiveness against RSV-associated hospitalization was 79% in Vision and 82% in NVSN, with 95% confidence intervals for both point estimates overlapping between these networks. Here we see a similar table for nirsevimab effectiveness against RSV-associated ICU admission among infants during their first RSV season, with results from Vision, NVSN, and Overcoming. Among the 374 hospitalizations in children included in the Vision analysis, 86% of RSV-positive children did not receive nirsevimab, compared to 55% among RSV-negative children. In NVSN, 92% of RSV-positive children did not receive nirsevimab, compared to 56% among RSV-negative children. Similarly, among 672 children in the Overcoming analysis, 87% of RSV-positive children did not receive nirsevimab, compared to 56% among RSV-negative children. The median time since dose among children that had received nirsevimab was 56, 52, and 50 days for Vision, NVSN, and Overcoming, respectively, with adjusted product effectiveness estimates of 82%, 88%, and 88%, with overlapping confidence intervals between each of the networks. Next, I'll present data regarding maternal RSV vaccine effectiveness during the 24-25 RSV season in the United States. Similar to the previous tables, here we see maternal RSV vaccine effectiveness against RSV-associated ED visits among infants during their first RSV season, with results from Vision. I do want to highlight that on this slide and the next, there is an additional column to account for median days since the infant's birth. Among nearly 1,000 ED visits in children included in the Vision analysis, 79% of RSV-positive children did not have evidence of maternal RSV vaccine receipt, compared to 65% among RSV-negative children. Among children with documentation of maternal RSV vaccine receipt, the median days since birth was 53, and the median days since maternal RSV vaccine administration was 85. Estimated maternal RSV vaccine effectiveness against RSV-associated ED visits was 54%, with a confidence interval of 35 to 67%. Moving on to maternal RSV vaccine effectiveness against RSV-associated hospitalization among infants during their first RSV season, with results from Vision and NVSN. Of 256 hospitalizations among children included in the Vision analysis, 81% of RSV positive children did not have evidence of maternal RSV vaccine receipt, compared to 63% among RSV negative children. Similarly, among the 326 hospitalizations among children included in the NVSN analysis, 82% of RSV positive children did not have evidence of maternal RSV vaccine receipt, compared to 65% among RSV negative children. Among children with documented maternal RSV vaccine receipt, the median days since birth for vision and NVSN was 35 and 32 days respectively. And the median days since maternal vaccination was 73 days in vision and 71 days in NVSN. The estimated adjusted vaccine effectiveness against RSV-associated hospitalization was 79% in vision and 70% in NVSN, with overlapping 95% confidence intervals between networks. Okay. There are some limitations to keep in mind when interpreting findings from these real-world product effectiveness results. First, these systems and methodologies differ in enrollment and population. While we can generalize across studies, findings may not be directly comparable. Second, while the study's design and analysis can help control for potential confounders like health-seeking behavior, residual confounding was possible, although a variety of sensitivity analyses were performed to assess the influence of known confounders. Third, misclassification of RSV immunization status was possible, although a variety of sources were leveraged to determine immunization status. I'll end with conclusions and considerations. Here we summarize the real-world product effectiveness estimates of the data just presented, seen in black, alongside the clinical trial efficacy estimates for each outcome, seen here in blue. ED visits were not direct outcomes measured during clinical trials for either product. However, for RSV-associated hospitalization and ICU admissions, the effectiveness estimates for both nirsevimab and maternal RSV vaccine are consistent with findings from clinical trials. Taken together, these real-world findings during the 24-25 US RSV season suggest that both nirsevimab and maternal RSV vaccination are effective at preventing RSV-associated ED visits, hospitalizations, and critical illnesses. Continued monitoring will be needed to assess additional outcomes. Now we'll discuss the impact of RSV prevention products on pediatric RSV-associated hospitalizations within the United States. To assess the impact, we analyzed data from 2 active population-based US surveillance systems that monitor laboratory-confirmed RSV-associated hospitalizations. The first system is RSVNet, which is a component of the ResVNet system and monitors RSV, influenza, and COVID-19 associated hospitalizations among patients of any age from 13 states. The second system is NVSN, which I spoke about earlier, that monitors hospitalizations among children with acute respiratory illnesses from 7 US medical centers. We performed an ecologic analysis that compared RSV-associated hospitalizations and rates between RSV seasons before and after RSV prevention introduction, including pre-pandemic seasons of 2018-2019 and 2019-2020 for RSVNet, and 2017 through 2020 for NVSN, and the 24-25 season, which was the second year of product availability. We excluded 2020 through 2023 because these seasons were impacted by the COVID-19 pandemic, and also the 24-25 RSV season, which was the first year of RSV prevention product introduction, during which there was low availability and uptake of products. We compared adjusted RSV-associated hospitalization and ICU admission rates for RSV seasons before and after product introduction. We looked at weekly hospitalization. We compared adjusted RSV-associated hospitalization and ICU admission rates from RSV seasons before and after RSV prevention product introduction. We looked at weekly hospitalization rates from RSVNet and monthly rates from MVSN during 24-25, comparing them with the same weeks and months in prior seasons. We also examined cumulative hospitalization rates for 24-25 across both networks and compared them to pooled rates from prior seasons. We also analyzed cumulative ICU admission rates in RSVNet. To quantify these differences, we calculated rate ratios comparing cumulative rates between time periods, and from those, we estimated the relative rate reductions calculated as 1 minus the rate ratio multiplied by 100. To examine changes related to RSV prevention product availability, we assessed changes in rates before and after product introduction for 3 age groups with different prevention product options. First, we assessed rate changes among infants aged 0 to 7 months, a population that was eligible for nirsevimab, but also could have been protected by maternal RSV vaccination. Then we looked at rate changes among children aged 8 to 19 months, among whom a small number of children at risk for severe RSV disease would have been eligible to receive nirsevimab based on risk conditions. And lastly, we assessed rate changes for children aged 20 to 59 months who are ineligible for RSV prevention products. The older 2 groups were included as comparison populations because they were largely ineligible for RSV prevention products. They were included to detect hospitalization rate changes that may have occurred between time periods that were unrelated to RSV prevention product uptake. During 2024-2025, RSV prevention products were available before RSV season onset in most states, with product coverage that increased over time. By March of 2025, nirsevimab coverage among infants aged 0 to 7 months ranged from 21 to 48% among reporting jurisdictions. And as of January 2025, 39% of pregnant women aged 18 to 49 years had received RSV vaccine. I want to briefly explain the kind of analysis we used. We performed an ecological analysis, which means we looked at patterns across whole groups of children over time. In this case, we compared RSV-associated hospitalization rates across 3 different age groups: young infants, toddlers, and preschool-aged children, across several RSV seasons to see how hospital rates changed or didn't change within each age group over time. If no new RSV prevention products had been introduced, we would expect to see the same kinds of patterns we've seen in the past, where infants get hospitalized at the highest rates, followed by toddlers, and then preschool-aged children. And while these rates are different for each age group, they tend to stay relatively consistent from year to year. But in the 24-25 season, that changed. New RSV prevention products were available to help protect some children from severe RSV disease. These products weren't approved for all children. They were recommended only for specific age groups, including infants 0 to 7 months who were eligible for nirsevimab or were potentially protected by maternal RSV vaccine. And children 8 to 19 months, which only a small number would have been eligible for nirsevimab based on risk conditions. Children 20 to 59 months were ineligible for RSV prevention products. Because of these differences, we were able to look at each age group separately and compare hospital hospitalization rates before and after these products were introduced. We used the analysis to help determine whether RSV hospitalization rates dropped more in the 24-25 season for the infants who were eligible for these new prevention products compared to older children who weren't eligible. We looked at how much hospitalization rates changed from the seasons when no products were available to the 24-25 season after products were introduced. If we saw a bigger drop in hospitalizations among infants 0 to 7 months than we saw among children 8 to 19 and 20 to 59 months, that would suggest that these products had an impact in protecting the infant group at the population level. Now we'll move on to results from this analysis. Combined, the two networks identified more than 20,000 children less than 5 who had RSV-associated hospitalizations across these two time periods. Overall, the proportions of children aged less than 5 with an RSV-associated hospitalization who were aged 0 to 7 months decreased in 24-25 compared to seasons before prevention product introduction, as shown in the bottom two blue boxes of each bar, dropping from 51% to 29% in RSV net and from 46 to 38% in MVSN. Additionally, the median age at hospitalization nearly doubled in both systems, from 7.7 to 15.4 months in RSV net and from 6.3 to 12.7 months in MVSN. This means that in 24-25, the typical age of a child hospitalized with RSV is older than it was in prior seasons. Next, we looked at cumulative adjusted RSV hospitalization rates in 24-25 compared to seasons before product introduction by age group. From left to right, we will show rates for each network among infants aged 0 to 7 months, children aged 8 to 19 months, and children aged 20 to 59 months. The light blue bars represent seasons before RSV prevention product introduction. And we see that cumulative RSV-associated hospitalization rates among infants aged 0 to 7 months were 17 and 16, among children aged 8 to 19 months were 5.8 and 5.3, and among children aged 20 to 59 months were 1.7 and 1.1 in RSV net and MVSN net. Here, we added 24-25 rates, represented by the purple bars, and we can see that among children aged 0 to 7 months, rates decreased to 10.5 in RSV net and 11 in MVSN. There was no rate decreases among older children. Which corresponded with a 38% and 31% reduction in hospitalization rates in 24-25 compared to seasons before product introduction in RSV net and MVSN respectively, and no reductions occurred among older children. We then looked more closely at changes in RSV-associated hospitalization rates among those infants aged 0 to 7 months by looking specifically at rates among infants aged 0 to 2 months and aged 3 to 7 months. And we found that RSV-associated hospitalization rates were reduced by nearly half among the youngest infants, those aged 0 to 2 months, with 47% reduction in RSV net and a 46% reduction in MVSN net in 24-25 compared to prior seasons. Finally, I'd like to end with conclusions and considerations related to the impact of RSV prevention products. In summary, 2 population-based surveillance networks demonstrated reductions in RSV-associated hospitalizations during the 24-25 season among infants eligible for RSV prevention products, with 38% and 31% reductions in 24-25 compared to RSV seasons before product introduction among infants aged 0 to 7 months. Reductions in both RSV-associated hospitalization were greatest among those infants 0 to 2 months who were born just before or during the RSV season. This is the group at highest risk for hospitalization and underscores the importance of protecting those infants through maternal vaccination during pregnancy or nirsevimab in the first week of life, as recommended by ACIP. And lastly, ongoing monitoring of RSV disease trends, including severity and age distribution, is crucial to assess the sustained impact of these products over time. I want to acknowledge all of our CDC colleagues as well as all of the contributors that provided data to this presentation. Thank you.
Thank you for that, Dr. McNeil. I want to point out that the vote that we're scheduled to have on the RSV product is for clesrovimab and not of these two. So in the interest of time, we might just try to move forward, but if there are questions from any members of the committee, then please. Yes.
So first, thank you for this detailed analysis. Quite a lot of very useful information. I guess that my question about maybe some complementary analysis that will be good to have is a little bit of more refinement of the outcomes that are being measured in various dimensions. So the first dimension is to understand in a more nuanced way in terms of what babies are benefiting from this the most, specifically preterm babies, babies with comorbidities compared to maybe healthy term babies, to see if there is any difference in the benefit of these products. I also think that it will be useful to consider overall all-cause lower respiratory tract infections, because one thing that we would like to make sure that what we see here is not partially an artifact that these babies tend just to be tested negative, more likely to be tested negative to RSV, but nevertheless still suffer from severe LRTIs. And in fact, I would even suggest to look on overall respiratory infections, because at the end of the day, we would like to make sure that we impacted all the severe cases. And maybe the last dimension I would like to see maybe more information is, hospitalization is definitely a bad outcome for babies, for everybody, but not all hospitalizations are made the same. So some hospitalizations are longer, some of them requires very intense care. So I think that trying to refine the analysis to also consider the number of hospital days, what types of care was provided in different fractions of those days, would be very complementary to understand the overall benefits in a maybe more nuanced way. Thank you.
Yeah, thanks. I'll respond quickly, and I don't know if because of time we want to also go to SMEs who can speak in more depth, but I think, maybe just a couple of quick comments. So one, certainly in terms of preventing respiratory infections, I mean, we all agree completely, right? It's not just RSV, it is as much as we can prevent infant pediatric hospitalizations would be strongly valued. I would note that RSV certainly is the cause of a very large proportion of hospitalizations, particularly among newborns. So even with RSV products, it by itself is having a large public health impact. I think to some of the other ideas you raised about sub-analyses, I absolutely think there would be value in terms of having more granular analyses. I suspect the one limitation if we have time, if we want to go to SMEs on this, would be just the statistical power we have to be able to dig into further analyses.
So. Dr. Hibben?
Excellent presentation, combining small N clinical trials with large-scale ecological trials, which is always a challenge. It would appear to me that these come to similar magnitude of effect sizes in the clinical trials and in the ecological trials. Is that correct?
Similar, yes. I think we also have to remember that the clinical trials were not done within the United States. Obviously, there are differences, but I think the overall magnitude, I think the big picture is yes, I would say we are seeing the real world impact that we would expect based on the clinical trials.
Second is that the big event that happened between the two ecological studies, of course, was COVID. Do you think you have any evidence of an interaction or a protective effect of COVID vaccines on RSV hospitalizations or phenomenon?
There would certainly not be, biologically, there would not be a direct effect of COVID-19 in any way on RSV because they are very different viruses. So,
thank you.
Dr. Malone?
Thanks. Sorry, a little more virology. We have two monoclonals. Monoclonals are notoriously susceptible to viral drift. I could imagine an argument made that it would be useful if particularly those two monoclonals were towards different epitopes. Do we have that information?
Yes, and that is part of the thinking. We'll actually cover in a later presentation is that by having two different monoclonal, they both target the larger pre-fusion protein, but yes, there's a possibility that if resistance were to occur to one of the monoclonals, the other one would remain protective. So that's part of the thinking that went into the work group and their deliberation around having a second monoclonal available.
Yeah, I support that.
Yeah.
This also raises the issue because clearly you've demonstrated there is very significant viral pressure, infectious pressure. Is there a monitoring for drift?
So I think one important thing to remember is that RSV infects all people multiple times throughout their life. So there's ongoing circulation. So we don't think that infecting or providing protection in a small population actually creates a large population-based selective pressure. So we do some genomic monitoring for RSV, but there is not expected to be the ecologic selective pressure because everybody else is still transmitting the virus, right?
So the general population is basically a sink that's maintaining the genetics.
Correct.
Yep. Another point, because it's going to be an issue with the ACIP going forward to ask the question about drug-drug interactions, I infer that some fraction of those receiving these products are fully vaccinated at birth under the standard schedule, and some fraction may not be. If that's the case, then capturing those data, demonstrating that there presumably is no difference in safety signal or effectiveness between those populations that concurrently receive standard vaccination protocol and those that don't, seems to be something that would be useful if you're not doing that yet.
Yeah, and I think I would look to my colleague from safety if she would like to comment further. I think obviously the other aspect of this is these products came through different clinical trials, so there was not, ability to look across impact between clinical trials, obviously.
But with the data you're capturing right now, you have an opportunity to do that as field effectiveness.
Yeah. Looking at Dimitri, are there comments online?
Yeah, we're just flagging that there's a hand in the room.
Thank you. What was the question?
We have somebody remotely, BB.
Oh, yeah, sorry, this is the SME room. Yeah, so there were a couple of questions. One was about the binding sites with the two different monoclonals. These two different monoclonals do indeed bind two different locations in the virus. And you're correct that some viruses do drift away from monoclonal antibodies. These probably aren't quite as prone to drifting just because of the way that evolution happens in this virus. However, we agree and are doing genetic surveillance to ensure that the effectiveness is maintained.
Thank you, Dr. Levi.
Yeah, so just to build on the last point, one of the things that I think is also important to monitor is how the efficacy changes over time, even within a season. At least, if I'm not mistaken, when I interpreted the results from the maternal vaccine, when you look on day 180 to 360, you see something that looks like a negative efficacy, where there are more hospitalization cases among the vaccinated versus the one that were not. Again, I think that what I understand about the RSV, attempts to protect against RSV, it's a tricky virus that more often than not fools interventions in unexpected ways. So I think we need to be extra careful to understand what is our understanding, the explanation or potential explanations to what we see. So.
Yeah, I mean, certainly, we know that effectiveness of these products wanes over time. And so it's going to create its own impacts of, you're protecting the youngest children, and then part of what we want to do, right, is to protect them when they're most vulnerable, so they get to the point that they have fully developed immune systems in which they, like healthy adults, generally are infected with, or I should say healthy teenagers, for example, are infected but do not have severe RSV disease. So really, the biggest impact among the newborns is getting those 0 to 2 months and getting them through that most vulnerable period.
We have another online, I think it's initial BB again, or?
Yes, hi, this is Dr. Meredith McMorrow. I'm also with Corbett at CDC, and just wanted to respond to the question about monitoring up to 150 days or beyond. Right now, the challenge of the way in which we administer these products is that we do them at the beginning of the season, and as we build up coverage, the season progresses, and so that you'll see from the average time between vaccination and immunization and hospitalization for the two analyses that we aren't getting to very many children that have received these immunizations out to 120 to 180 days. And that's part of that is because of the way that we seasonally introduce these products. I think we are hoping that other places where RSV circulation is less seasonal, perhaps more year-round, will help us to answer some of these questions about the duration of protection. But right now, it is a bit of a challenge in terms of looking at the tails of protection in our current surveillance system.
Thank you for excellent discussion and suggestions
Martin,
here.
Martin, can I make a comment?
Yes?
I'm sorry.
Please, go ahead.
This is Cody. Yep. As someone who's been on the RSV work group and as a pediatrician, I mean, people need to understand what a spectacular accomplishment these results are. As was pointed out, RSV is the most common diagnosis among children who are hospitalized in the first 12 months of life. And 2 to 3% of all children, that includes term as well as increased risk children with heart disease or lung disease, they have a higher rate, but are hospitalized. And this is an astonishing accomplishment that's really developed because of an increased understanding of the fusion proteins that exist in at least 2 different configurations, a pre and a post configuration, against which the monoclonal antibody has been made for the pre-fusion. So this is a spectacular accomplishment. It's something that the CDC does very well in providing this sort of data so that recommendations can be made. And I just want to recognize the contribution of Jefferson Jones and Pablo Sanchez on the work group for working so diligently to get this passed and finished. So, and get the recommendations that we now have. But people should understand this is a truly spectacular accomplishment and will have an enormous impact on public health.
Thank you for those positive words, Dr. Meissner. Before we go to the next presentation, we have a little bit more of a roll call, I believe, because there were some people who were not able to be heard.
Sure, we had some of our liaisons who were unable to unmute. So if you would like to go ahead and unmute and introduce yourselves, that would be great.
Go first. Jason Goldman, clinical affiliate professor of general internal medicine at Florida Atlantic University, president of the American College of Physicians, representing 160,000 internal medicine specialists over 145 countries, as well as being a primary care physician in general practice, expertise in taking care of patients in the office and in the clinic. Thank you.
Thank you for that.
Hello, Masood. Sorry, Masood
Barbara
Mahmoudi,
Resnick from American Nurses Association is present.
Sorry, Masood Mahmoudi, American Osteopathic Association. I don't know if you could hear me.
Thank you. Anybody else? Thank you.
Thank you so much for that, and it's a pleasure to have you with us on this meeting. So we will now move on to the next presentation on the safety of these products by Drs. De Silva and Daly.
Good afternoon. Can you hear me?
Yes, we can hear you.
Okay. I am an internal medicine and pediatrics physician and a senior research investigator at Health Partners Institute in Minnesota, which is one of the vaccine safety data link sites. Today, I'll be presenting results for prenatal RSV Pre-F vaccine safety during the 2023-2024 respiratory season from the Vaccine Safety Data Link. Next slide, please. Established in 1990, the Vaccine Safety Data Link, or VSD, is a collaborative project between the CDC's Immunization Safety Office and integrated healthcare organizations in the United States. The VSD monitors the safety of vaccines used in the U.S. primarily through observational, multi-site studies using real-world data. The project includes data on approximately 15.5 million individuals across all sites annually, which represents approximately 4.5% of the U.S. population. The VSD has an annual birth cohort of approximately 115,000 live births. Data is organized using a common data model with standardized coding systems. The map on the right shows currently participating VSD healthcare organizations. There are 13 VSD sites that provide clinical, methodological, and data expertise. 11 of the 13 sites provide data for the project. Sites that do not provide data are denoted with an asterisk. Next slide, please. The prenatal RSV vaccine was recommended for use by ACIP in September of 2023 for use between 32 through 36 weeks gestation with seasonal administration from September through January. The phase 3 RSV Pre-F clinical trial identified non-significant imbalances among vaccinated women compared to placebo recipients in preterm births and gestational hypertension and preeclampsia. Next slide, please. Prenatal RSV Pre-F vaccine safety outcomes we evaluated in this study are acute outcomes occurring within 42 days of vaccination, preterm birth, small for gestational age at birth, stillbirth, and hypertensive disorders of pregnancy, which we evaluated as a combined outcome, as well as the individual outcomes of gestational hypertension, preeclampsia, eclampsia, and HELLP syndrome. Next slide, please. We used a target trial emulation design to compare vaccinated and unvaccinated persons at each gestational week. This study design attempts to recreate a randomized experiment from observational data. For the eligibility criteria, we included pregnant women 16 through 49 years of age with gestational age 32 through less than 37 weeks during September 22nd, 2023 through either January 31st, 2024 or February 29th, 2024 for 2 sites that continued vaccinating through February. The treatments we compared were RSV pre-F vaccination during pregnancy to no RSV pre-F vaccination during pregnancy. Pregnant persons exposed to RSV pre-F vaccine were matched 1-to-1 on VSD site and propensity to be vaccinated to unvaccinated pregnant persons during the same gestational week. All participants were followed for outcomes from the index date through 2 weeks after the pregnancy end date. Unvaccinated matches were assigned an index date equal to the gestational day of vaccine for their vaccinated match. The matched pair was censored if the unvaccinated person was later vaccinated. Next slide, please. Back one. Next slide. We estimated risk ratios with 95% confidence intervals using a log binomial model with robust variance with adjustment for nulliparity for the pregnancy and infant outcomes. For small for gestational age at birth, matched sets were excluded if the infant weight was not available for either infant in the matched pair. For hypertensive disorders of pregnancy, the matched set was excluded if disease onset was before or on the index day for either included pregnant woman. Next slide, please. This slide shows a balanced plot of covariates included in the propensity score before and after matching. In the figure, the x-axis shows the standardized mean difference, or SMD, and the y-axis shows the covariate included in the propensity score. Blue circles are the standardized mean differences for the entire population before matching. Red circles show the standardized mean difference after matching. This includes only the matched pairs. Unmatched persons are excluded. The balance plot shows that characteristics of the included pregnant women are similar after matching. Next slide. This table shows the age group, race, ethnicity, receipt of one or more other vaccines during pregnancy, and nulliparity of the matched cohort. There are 13,966 matched pairs included in this analysis. Of note, the matched cohort is not unique individuals, as some initial unvaccinated persons were ultimately vaccinated and subsequently rematched as vaccinated. While the characteristics are similar, RSV vaccinated women tended to be older than their unvaccinated matches. The vaccinated group had a higher percentage of Asian patients and lower percentage of Black and Hispanic patients compared to their unvaccinated matches. 98.5% of the vaccinated group had received at least one other vaccine during pregnancy, compared with 81% of the RSV unvaccinated group. There was a higher percentage of nulliparous women in the RSV vaccinated group compared with the unvaccinated group. Next slide, please. This slide and the next show results for the risk of acute outcomes among pregnant women receiving RSV pre-F vaccine and their unvaccinated matches. The table lists the outcome, the risk intervals evaluated, either 1 through 6 days or 1 through 21 days on this slide, the number of events and events per 10,000 persons, and the risk ratio with 95% confidence intervals. If an outcome we evaluated is not included in this figure, it is because there were no events in either group for these outcomes. There were no significant differences between the RSV vaccinated group and their unvaccinated matches. Next slide. This slide shows results for the 1 through 42-day risk interval for acute safety outcomes among pregnant women receiving RSV pre-F vaccine and their unvaccinated matches. Again, the table lists the outcome, the number of events and events per 10,000 persons, and the risk ratio with 95% confidence intervals. Again, if an outcome we evaluate is not included in this figure, it is because there were no events in either group. There were no significant differences between groups for these outcomes. Next slide, please. The next few slides show similar tables. Each slide focuses on a specific outcome. Each table shows the number of matched pairs included, the number of events for both the RSV vaccinated and unvaccinated women, and the adjusted risk ratio. This slide shows preterm birth risk among pregnant women receiving RSV pre-F vaccine and unvaccinated matches. The adjusted risk ratio for preterm birth is 0.90, with confidence interval including 1. There is no association between RSV pre-F vaccination and preterm birth risk. Next slide, please. This slide shows small for gestational age at birth risk among infants born to RSV pre-F vaccinated women or their unvaccinated matches. There is no association between RSV pre-F vaccination and small for gestational age at birth risk. Next slide, please. This slide shows the stillbirth risk in RSV vaccinated pregnant women or their unvaccinated pregnant matches. Again, there is no association between RSV pre-F vaccine and stillbirth risk. Next slide, please. This slide shows the risk for hypertensive disorders of pregnancy among pregnant women receiving RSV pre-F vaccine and their unvaccinated matches. The adjusted risk ratio for any hypertensive disorder of pregnancy is 1.09 with confidence interval 1.03 to 1.15. The adjusted risk ratios for the individual hypertensive disorders of pregnancy were statistically significant for preeclampsia and gestational hypertension. There is an association between the RSV pre-F vaccine and any hypertensive disorder of pregnancy, preeclampsia, and gestational hypertension. Next slide, please. Only individuals with a diagnosed hypertensive disorder of pregnancy are included on this slide. This slide evaluates the rates of cesarean delivery, hypertensive disorder of pregnancy admissions following the birth hospitalization, and lengths of stay longer than 3 days for the birth hospitalization for both the infant and mother, stratified by the type of delivery and shown by RSV vaccination status. There were 2,344 RSV pre-F vaccinated women and 2,056 unvaccinated women included. The columns show the severity indicator and the number and percent of each group who had that severity indicator. There are similar rates of cesarean delivery and hypertensive disorder of pregnancy admissions following the birth hospitalization in both groups. The percent with a length of stay over 3 days was slightly higher in the RSV pre-F vaccine group compared with the unvaccinated group, except for infants following cesarean delivery. These results suggest similar severity for hypertensive disorders of pregnancy in both the vaccinated and unvaccinated groups. Next slide, please. This slide shows results for serious adverse events in the phase 3 clinical trial of the RSV pre-F vaccine administered to pregnant persons. There were more cases of gestational hypertension and preeclampsia among RSV pre-F vaccine recipients than among placebo recipients, although these associations were not statistically significant. Next slide. Similarly, the results of a retrospective observational cohort study of patients who delivered at 32 and 07 weeks gestation or later at 2 New York City hospitals from September 22, 2023 to January 31, 2024, found a significant association between the RSV pre-F vaccine and hypertensive disorders of pregnancy in a time-dependent Cox covariate regression model. This association was not significant in an unadjusted or adjusted multivariable logistic regression model. In stratified analyses by site and insurance status, the association between hypertensive disorders of pregnancy and RSV remained among those with private insurance and at one of the 2 included sites. Next slide, please. In conclusion, RSV pre-F vaccine is not associated with increased risk for acute safety outcomes, preterm birth, small for gestational age at birth, or stillbirth. RSV pre-F vaccine is associated with a small but statistically increased risk for hypertensive disorders of pregnancy. These findings are consistent with those of the phase 3 trial in a large observational study. This finding is limited by potential residual confounding or outcome misclassification. Importantly, the severity of hypertensive disorders of pregnancy was similar between those that received the RSV pre-F vaccine and their unvaccinated matches, based on rates of cesarean delivery, admissions following birth hospitalization, and lengths of stay. Results of the 2024-25 season analysis are pending and will be important for further understanding of prenatal RSV vaccine safety. Next slide. Thank you for your time. I look forward to answering any questions you may have.
Thank you for that. And I think before questions, I think we should continue with the presentation by Dr. Matt Daly, which is also about safety.
Thank you. Can you hear me?
Yes.
Great. So I'm Matt Daly. I'm going to be presenting on monitoring the safety of nirsevimab in infants birth through less than 8 months of age. These are preliminary results from the Vaccine Safety Data Link for the 2024-2025 season. Next slide. I have no conflicts of interest. I'm presenting on behalf of the Vaccine Safety Data Link. Next slide. Next slide. To provide a little bit of nirsevimab overview, as we've heard, it's a long-acting monoclonal antibody for the prevention of RSV disease. It's recommended for infants birth through less than 8 months of age if no RSV vaccine was given during pregnancy. It's also recommended for select high-risk infants aged 8 through 19 months of age. It has demonstrated high efficacy in phase 3 clinical trial and high effectiveness post-licensure, which we heard today. There was a severe shortage of nirsevimab during the 2023-2024 season. Despite that, uptake has been quite high. Within the VSD during the 2023-2024 season, 72% received either nirsevimab or vaccine during pregnancy. Next slide. In terms of the safety database for nirsevimab, it's primarily derived from 3 randomized clinical trials. These clinical trials included healthy infants as well as more high-risk infants. And there were 3,184 who received nirsevimab. Again, this is combining results across 3 trials. 1,284 who received placebo, the reason being that there was a 2-to-1 randomization of nirsevimab to placebo, and then 304 who received palivizumab, which is another monoclonal antibody targeted at RSV. Adverse events were generally balanced among infants who received nirsevimab versus the comparator. There were some adverse events of special interest. 7 nirsevimab-exposed infants had rashes that were primarily papular or maculopapular. Importantly, there were no cases of anaphylaxis, no serious hypersensitivity type reactions reported, and no immune complex diseases reported. Next slide, please. In the context of the safety data from the clinical trials, it is still important to perform additional post-licensure safety data, including an assessment of rare adverse events, and then also when nirsevimab is given during routine care in a general patient population. So the objective of our study was to investigate the safety of nirsevimab by examining pre-specified adverse events among nirsevimab recipients in the Vaccine Safety Data Link. I would note that nirsevimab is a passive immunization, yet the CDC and ACIP requested that the VSD evaluate its safety. Next slide, please. The Vaccine Safety Data Link we've heard about a couple times today. I'll just highlight a couple points here. It's observational. It uses EHR data. The cohort size, as Dr. De Silva said, has an annual birth cohort of 115,000. It has the following data characteristics. We use electronic health record data, but we also have access to claims and immunization information system data, and then diagnosis codes, vaccines, and medications. These data come from inpatient, emergency department, and outpatient settings. One additional characteristic of the VSD that distinguishes us from some of the other vaccine safety systems is the ability to rapidly perform manual medical record review. While diagnosis codes have a high degree of accuracy, they're not 100% accurate. There can, for example, be a diagnosis code for seizure, and then on manual medical record review, that was found to be a ruled out seizure. It was something else. Or in the case of an adult who has a diagnosis code for Guillain-Barré syndrome, on review of the medical record, at times that could have been Guillain-Barré syndrome 2 years ago, which is not relevant to the vaccine given today, at least in the context of safety. And then I would also say that VSD applies a range of analytic methods to address confounding, including self-controlled designs. Next slide, please. This figure shows VSD sites in 2025. Next slide. We also evaluated the safety of nirsevimab in the VSD during the 2023-2024 season. These results have been shared previously with the ACIP RSV work group. In that study, 36,719 received nirsevimab. We had pre-specified adverse events that were monitored through a self-controlled risk interval analysis, and then all analyses were stratified by age group. In this first season of nirsevimab use, there was no elevated risk of seizures, ITP, drug reactions, fever, or sepsis. And then there were also no cases of anaphylaxis. There were cases of non-anaphylactic allergic reactions that were primarily urticaria or hives, often on the same day as nirsevimab. This is not an unexpected finding given the finding of rashes from the nirsevimab clinical trial. Next slide, please. Next slide, please. So to provide a methods overview, and again, now I'm going to be summarizing the safety results for nirsevimab for the 24-25 season. We used all VSD data contributing sites. The population was all infants, 0 days through less than 8 months of life who received nirsevimab between October 1st of 2024 and February 1st of 2025. With respect to same-day vaccines, this study included all nirsevimab exposed infants, regardless of whether they received vaccines on the same day as nirsevimab. We also required health insurance enrollment through the control window. What I mean by this is that the infants needed to have health insurance with their VSD site through the end of their control window so that we could assess both the receipt of nirsevimab and then whether they had adverse events through the control window. We primarily used a self-controlled risk interval design, and then we excluded infants born to someone who received RSV vaccine during pregnancy. Next slide, please. I did want to provide a little bit more information about the use of self-controlled designs in safety studies. The self-controlled risk interval is a form of self-controlled case series. Self-controlled case series designs are commonly used in vaccine safety studies. The rationale for using self-controlled designs is as follows. The exposed to a vaccine, or in this case to nirsevimab, often differ in important characteristics from the unexposed, and these characteristics may not be measured in electronic health record data and can confound safety assessments. To provide an example, if there is a new vaccine and early adopters of that new vaccine are quite healthy, then if we compared them to the unvaccinated, it would bias towards not seeing a safety finding if there was a safety finding there because of the difference between the vaccinated and the unvaccinated. So self-controlled designs are within individual designs. They control for measured and unmeasured confounders that do not vary over time, for example, a prevalent chronic condition. So in self-controlled designs, there is an exposure, in this case, nirsevimab, and then we look in a risk window immediately following nirsevimab or vaccine exposure compared to a later time in that same individual. So with respect to a prevalent condition, if there's an adult who has type 1 diabetes and then receives a vaccine and then has a risk and a control window, they have type 1 diabetes in their risk window and in their control window. That is controlled for implicitly with a self-controlled design. Next slide, please. I also want to discuss age effects because this is an important consideration in how we design this study. Diagnoses in the first month of life are often related to pregnancy, delivery, newborn-specific conditions. Healthcare utilization is different in the first month of life, and then there can be lags in health insurance enrollment. And then one other consideration, with the exception of the birth dose of hepatitis B vaccine, the earliest that all other vaccines recommended can be given is 38 days of age. So for all of these reasons, we performed separate safety analyses for the newborns, which here we're defining as 0 days through 37 days of age, and then infants out of the newborn period, which here we're defining as 38 days through 8 months of age. Next slide, please. In terms of the adverse events that we monitored, the adverse events were pre-specified, and they were chosen based on biologic plausibility, clinical trial data, as well as expert opinion, including feedback that we received from the ACIP RSV work group. The adverse events were primarily identified based on ICD-10 diagnosis codes. We also used platelet counts for one of the outcomes. Next slide, please. Here are the outcomes for the nirsevimab safety surveillance study. The first column shows the adverse event. The next column shows the study design. We examined seizures, immune thrombocytopenia or ITP, drug reaction, fever, and sepsis. These were self-controlled risk interval designs. And then anaphylaxis and non-anaphylactic serious allergic reactions in which the counts were monitored, and then also have plans to study autoimmune and immune complex disease. However, those type of outcomes in newborns and infants are rare and may have a long latency, and so the plan is to examine these as a case control study at the end of surveillance. Next slide, please. So let me walk you through this slide. Here are the risk and control windows for each of the adverse events in the self-controlled risk interval. The first column is the adverse event. I would highlight that each row is a separate analysis, as I explained, and then age at nirsevimab administration, and then risk window in days, and this refers to days after receipt of nirsevimab, and then a control window, and then the setting in which we identified these cases. Next slide. There are also conditions that we call exposure-dependent events, including anaphylaxis and non-anaphylactic allergic reaction. One way to think about this is that there's not essentially a baseline rate of anaphylaxis. You need an exposure to something, such as a medication or a bee sting or a peanut product. So for these, we monitor cases in a risk window and then manually review those cases. So in the case of anaphylaxis, the risk window was 0 to 2 days after nirsevimab administration. And then in the case of non-anaphylactic allergic reactions, we looked 0 through 7 days. Next slide, please. This provides some additional information about the outcomes that we used for the nirsevimab safety surveillance study. The first column is the adverse event. The next column is the ICD-10 codes that we used. And then the last column provides some additional information. So I'd just highlight that for immune thrombocytopenia, or ITP, we required both ICD-10 codes and platelets less than 50,000. Next slide, please. This slide has some additional information about our analytic methods. This is the last method slide. Again, this is for the self-controlled risk interval analysis, or SCRI. For each pre-specified outcome, we identified cases that occurred within either the risk or the control window. There were 2 observations per individual, 1 per control window and 1 per risk window. And then informative cases have an outcome in one window but not the other. And then the cohort must have at least 1 outcome in each window to estimate an effect. And then our models, as I explained before, were stratified by age group. Next slide. Next, we'll review results. And again, as I would highlight, these are from the 24-25 season. So we identified 117,427 children. This is neonates and infants, 0 days old through less than 8 months of age. We then applied our enrollment criteria. 43,532 received nirsevimab. We excluded 1,663 who also received RSV vaccine during pregnancy. This does not necessarily represent an administration error because there are some specific circumstances when an infant who was exposed to RSV vaccine during pregnancy would still be eligible for nirsevimab. And then we stratified by age. There were some kids who, when we established this cohort, had received nirsevimab at the very end of last season, the 23-24 season, and so were included in that safety analysis, so those also were excluded. So from this study flow, we had 9,855 neonates 0 to 37 days of age exposed to nirsevimab who contributed to the safety analysis, and then 28,054 infants in the 38 days to less than 8 months of age at the time of nirsevimab administration who contributed to the safety analysis. Next slide, please. I'm going to provide a couple figures that provide context for the safety results that follow. In this graph, we're looking at number of doses on the y-axis and then age in weeks on nirsevimab administration date on the x-axis. And as you can see, the administration patterns were quite heterogeneous. And by that, I mean any given week of age up till 8 months, infants could have been exposed to nirsevimab, but there is clustering of nirsevimab in that first week of life, and then at 2 weeks, which corresponds to a 2-week well-child check, and then at 2 months, 4 months, and 6 months of age. Next slide. This slide is focused just on the neonate cohort, days 0 through 37 days of age, and then we also show here whether or not hepatitis B vaccine was given on the same day as nirsevimab. So as you can see, for those babies who received nirsevimab on day 0, their birthday, they most often received it on the same day as Hep B vaccine. For those babies who received nirsevimab on day 1, most received nirsevimab alone, although there were some who also received Hep B on the same day. And then after that, for the most part, nirsevimab was given not on the same day as hepatitis B vaccine. Next slide. A little more information about simultaneous or same-day receipt of vaccines. To summarize, among the neonates, the 0 to 37-day-olds who received nirsevimab, 20% received nirsevimab on the same day as hepatitis B vaccine. And then among the infants, 38 days through less than 8 months of age who received nirsevimab, 84% received on the same day as vaccines. The most common combination was nirsevimab plus hepatitis B, rotavirus, DTaP, Hib, pneumococcal, and polio vaccines. Next slide. This is the first of the safety results slides, so I'm going to walk you through it one by one, and then the format for some subsequent slides is similar. First column is the adverse event, the next column is the age group. I'll highlight again that each row represents a separate safety analysis, and then the N, the risk window, the control window, the number of cases in the risk window, the number of cases in the control window, and then the relative risk. There was no significant increase of seizures in the 24-25 season. There also was no significant increase in seizures in the 23-24 season. However, because there was a numeric imbalance here, we performed a rapid medical record review. And what I can summarize from that is several of these cases were not seizures, but were diagnosed with something else, and seizures were ruled out. There were also several cases of a known genetic cause for seizure, and seizure in a child who had a pre-existing epilepsy. So just to summarize, no significant increased risk of seizures in 23-24 or 24-25. And upon medical record review, some of these were not cases, others were a known genetic seizure disorder. Next slide, please. With respect to ITP, there was a single case in the risk window in that older age group. Otherwise, no cases. Next slide, please. With respect to drug reactions, there were 0 cases in the risk window, 0 cases in the control window, both for the younger age group and for the older age group. Next slide, please. With respect to sepsis and fever, walking through by column, this is just in the 0 to 37 days, risk window, control window. There were 4 cases in the risk window, 9 in the control window for a relative risk of 0.44. This was only examined for the newborn cohort. It wasn't examined for the other children because, as any parent would tell you, a 1-week-old is very different from a 6-month-old, and that also includes fever in a well-appearing 6-month-old, which does not necessitate a workup for serious bacterial illness, which is quite rare at that age, versus fever in a newborn. In addition, we did perform additional exploratory analysis to assess whether nirsevimab, again, just in this age group, could cause fever, which then led to a sepsis workup, such as blood culture, spinal fluid culture, or both. There was a numerical imbalance detected in cultures in risk versus control windows, so we did a manual medical record review of a sample of these charts, and those charts showed no consistent pattern of concern. Those neonates typically had reasons other than fever for cultures being done. So just to summarize, no increased risk of sepsis and fever, which was our primary analysis. Next slide, please. In terms of these exposure-dependent events, as I've mentioned, something like anaphylaxis, you need an exposure, so we just look in the risk window. For anaphylaxis, 0 to 37 days, 0 cases. In that older age group, no cases. Other non-anaphylactic serious allergic reactions, there were 14 cases in the youngest age group and then 4 in that older age group. These were primarily diagnosis codes for urticaria or hives that occurred on the same day as nirsevimab. Next slide, please. Next slide, please. So to provide a summary, among a population of 74,000 infants and neonates, and this is combining results across 2 seasons of neonates and infants exposed to nirsevimab, there was no increased risk of seizures, ITP, drug reaction, fever, and sepsis. There were no cases of anaphylaxis. There were a small number of cases of non-anaphylactic allergic reactions in both years, and those were primarily coded as urticaria or hives, but without a more serious hypersensitivity reaction in those same children. And so this really should provide some reassuring data regarding the safety profile of nirsevimab when used in routine clinical practice. Additional data extraction is needed for late season nirsevimab use, and so we should view these results as preliminary. Next slide. And then our Nursivimab safety surveillance continues. We had three planned assessments after the 23-24 season, which again, results were shared with the ACIP RSV work group. The preliminary assessment of the 24-25 season, which is what I'm presenting here today, and then an end of surveillance assessment, which will be cumulative with data extraction through July of 2025. We will manually review any records of anaphylaxis cases and then any other outcomes of concern. And then we had planned a case control study of autoimmune and immune complex disease. However, it appears that there are too few cases to study in this group of outcomes at present. And just to provide a little bit more information about that, these are conditions such as myocarditis, pericarditis, arteritis, lupus, diabetes mellitus, glomerulonephritis, hemolytic anemia. There were only 2 cases in 24-25. Those appeared to be isoimmunization, which is basically what happens when maternal blood type is different from infant blood type, and that is what's causing hemolysis. So of course that couldn't be Nursivimab associated because that happened prior to the time of Nursivimab receipt. So essentially no cases of autoimmune or immune complex disease for the 24-25 season. So we can't perform a case control without any cases, but that should provide reassuring results regarding the risk of autoimmune and immune complex disease. Next slide. I'd be happy to take any questions. Thank you very much.
Thank you, Dr. Daly. These 2 presentations, these very thorough presentations, illustrates how important CDC's vaccine safety data link is to monitor the safety of these products. We will have questions, but there is one agenda item that we cannot move, and that is the public comment. So we will do the public comments at 4:15, and that is in 10 minutes. So we will give you a 10-minute break and then reconvene here at 4:15, and then we will resume the questions for these 2 presentations at 5 o'clock after the public comments. Thank you.
I'll check and see when I'm done, but I literally, because this session ran over, I got 3 patients in a room. I would ask Jason, so call him, but his answers are going to be more general, but I don't think there's much there, but I would suggest calling Jason, and then I'll text you when I'm done seeing those 3. Okay. Sorry. Okay. All right, thanks. Bye.
So it's 4:15, so I ask you to please take your seats. We're going to continue now, so please have a seat. So there's a little bit of a change in plan here. Before we do the public comment, there's a rule that we have to present the draft votes. And before we present the draft votes, there's a rule we have to hear the updates and summary of the evidence to recommendation. We will postpone the vote until tomorrow, so that will not happen today. But what we will do now is we will hear from Dr. McNeil and Dr. Peacock, and then we'll present the draft vote, and we will have then the public comments after that. And I've asked Dr. McNeil to do that as quickly as possible, and if there are any questions on his presentation, we will also do those tomorrow.
Thank you, and I'll do my best to run as quickly as possible, and I do want to make sure that all this information is available to be weighed for the vote. So noting you all have the material and there'll be opportunities to review further leading up to the vote. So I will try to go quickly. The policy question under consideration for today: should a clostridobamab be recommended for all infants less than 8 months of age during or entering the first RSV season? ACIP utilizes evidence to recommendation framework to structure evidence into a set of domains, both for the work group and the committee to consider when making an immunization recommendation. Today, I will present evidence for each domain listed on the slide. The equity domain was presented in April, and in the interest of time, I will not cover it today. However, slides and a recording are available on the CDC website. The first domain is public health problem. The evidence presented in this domain is intended to inform the question: is RSV associated disease among infants less than 8 months of age of public health importance? The burden of RSV in children is high. In the absence of RSV preventer products, CDC estimates in the United States RSV leads to 2 million medical encounters, 58 to 80,000 hospitalizations, and 100 to 300 deaths in children under 5 years of age. In the absence of RSV preventer products, most infants are infected in their first year of life, and among young infants, 2 to 3% will be hospitalized due to RSV. Highest hospitalization rates occur in the first year of life, and the risk declines as children get older. Approximately 80% of infants hospitalized for RSV have no underlying medical conditions. Therefore, all young children are considered at risk for severe RSV disease. When asked, is RSV disease among infants under 8 months of age a public health concern, the work group unanimously voted yes. The second domain is benefits and harms. Data in this domain should inform 3 questions. How substantial are the desirable anticipated benefits? How substantial are the anticipated undesirable effects? And do the desirable effects outweigh the undesirable effects? To assess the benefits and harms of immunization with to assess the benefits and harms of receipt of clostridobamab, we conducted a grade analysis, an approach to evaluate the certainty of the effects for both beneficial and harmful outcomes. To define the scope of the grade assessment, the policy question was reframed as a PICO question. The population of interest is all infants under 8 months of age who are born during or entering their first RSV season. The intervention is clostridobamab. The comparison is no immunization. The potential beneficial outcomes included in the grade assessment were RSV-associated medical attendant, lower respiratory tract infection, RSV-associated LTRI and hospitalization, RSV-associated LTR and ICU admission, all-cause medically attended LTRI, all-cause LTR-associated hospitalization. The potential harmful outcome evaluated was serious adverse events. As a short refresher, a certainty assessment reflects our confidence that the true effect lies close to the estimated effect. Here are the outcomes, their importance, and the data sources used for grade. There was one study that met the inclusion type criteria for the PICO question and was used to evaluate all the outcomes. This was Merck's phase 2b/3 double-blinded randomized placebo-controlled trial. The full grade benefits can be found in the slides posted online from the ACI meeting, but I'll review high-level results. For beneficial outcomes, we assessed efficacy estimates from the trial through 150 days, along with certainty estimates. I'll follow up on the critical outcomes, which are boxed in red. For RSV-associated medical attended LTRI, the efficacy was 60%. In the certainty assessment, there was concern for indirectness because the trial excluded infants who were palliative eligible and took place during a season with disrupted RSV circulation due to COVID-19. These concerns were deemed not serious, but they were noted for all the outcomes. The concern noted for all outcomes was judged to not be serious. For RSV-associated LTRI with hospitalization, the efficacy was 91%. For RSV-associated LTR with ICU admission, the efficacy was estimated to be 100%. For harms, we evaluated the relative risk of serious adverse events in the trial through 360 days. The estimated relative risk had a 95 confidence interval that ranged from 0.77 to 1.2, so included 1. This suggests that serious adverse events occurred at a similar rate in clostridioidomab in the placebo groups. However, there was a serious concern for imprecision in this estimate. This slide summarizes grade findings and the final evidence certainty ratings. Clostridioidomab was found to be effective in preventing RSV-associated medically attended LRTR and RSV-associated hospitalization with high certainty. It was effective in preventing ICU admissions due to RSV-associated LRI with moderate certainty, ineffective in preventing all-cause medically attended LRTI with moderate certainty, moderately effective in preventing all-cause hospitalization with LTRI with high certainty. Finally, there was no observed increase in serious adverse events in the clostridioidomab group compared to the placebo. I'll now discuss additional information relevant to the benefits of clostridioidomab that were not included in grade. Participants were followed through 180 days for 2 outcomes, RSV-associated medically attended LRTR and RSV-associated LRTI with hospitalization. While the efficacy appeared to be sustained through 180 days, based both on the point estimates and the 95% confidence intervals, very few cases were added either to the clostridioidomab or placebo arms during 151 to 180 days. This was likely due to low RSV circulation during that time period. In addition to clostridioidomab trial outcomes, including a grade, there are other potential benefits of clostridioidomab that are important to highlight. If recommended by CDC, clostridioidomab would be the second approved recommended long-lasting monoclonal antibody for prevention of severe RSV disease in infants. Having multiple products available with different binding sites will be beneficial in the event that resistant mutations emerge to either product. If one product experiences a supply disruption, this was experienced, as was experienced during the 23-24 season, the availability of the other product can help prevent shortages. Market competition may also help in creating favorable pricing. In addition to serious adverse events, the clinical trials also evaluated solicited adverse events. These are expected short-term reactions like injection site or systemic symptoms reported within the first 5 days after immunization. The overall rate of injection site and systemic reactions was very similar between groups. 29.9% in clostridobamab arm and 30.9% in the placebo arm. These events were mostly mild grade 1 or moderate grade 2. No grade 4 events were reported. Rates of fever within the first 5 days after immunization were also evaluated and are shown in this rate. The rates were comparable between the groups, 3.7% in the clostridobamab arm, 4% in the placebo arm. These data suggest that fever is not increased with clostridobamab use compared to the placebo. Based on the data I presented in this domain, the work group felt that clostridobamab was an efficacious, long-lasting monoclonal antibody that can prevent severe RSV disease in young infants for the duration of their first RSV season. Clostridobamab is to be the second long-lasting monoclonal antibody prevention product, and having two products will mitigate the risk of manufacturing shortages and loss of efficacy due to mutations in the binding site. Clostridobamab has a favorable safety profile with no observed increase in serious adverse events or local or systemic solicited adverse events, including fever, but it was noted that rare serious adverse events were unlikely to be detected in this trial due to size. The vast majority of the work group felt that the desirable anticipated effects of clostridobamab were large, and the undesirable anticipated effects were minimal to small. When polled on the question, do the desirable effects outweigh the undesirable effects, the work group unanimously polled that the data favored clostridobamab. The next domain is values. Data presented in this domain should help the committee answer two questions. First, do parents and caregivers feel that desirable effects of clostridobamab are large relative to undesirable? And second, is there important uncertainty about or variability in how much parents and caregivers value the prevention of severe RSV disease? To help inform the ETR values, we looked at a survey data on risk perceptions among pregnant women. This nationwide online survey was conducted in December 2022 to January 2023 among women who were either pregnant or within 12 months postpartum. 31% of respondents reported knowing a baby who had been hospitalized for RSV. 40% believed that their own baby would become moderately or severely ill if infected, and 69% worried their baby would need to be hospitalized if infected with RSV. In April to May Cascadia study conducted of parent preferences for RSV products among respondents aged 18 to 49 with children, parents were asked which product they would prefer if both were available, safe, and effective. 37% preferred the maternal RSV vaccine, 12% preferred the infant monoclonal antibody, 3% preferred neither. The largest share, 48%, had no preference. These findings indicate no clear parental preference between maternal vaccination and long-lasting monoclonal antibodies, suggesting that either option may be acceptable to parents. This slide shows preliminary data from the National Immunization Survey as of February of this year. Women aged 18 to 49 years with an infant under 8 months of age were asked about RSV immunization for their infants. Respondents reported that 50% of infants were protected by long-lasting monoclonal antibody, represented in teal. An additional 7% reported that they definitely intended to receive a long-lasting monoclonal antibody for their infant, represented in gray. The work group felt that parents and caregivers probably felt the desirable effects of clostridobamab were large relative to the undesirable effects. When asked whether there was important uncertainty about or variability in how much parents and caregivers value the prevention of severe RSV disease, the majority of the work group felt that there was probably not important uncertainty or variability. I will now present data on acceptability. This domain asks whether clostridobamab is acceptable to key stakeholders, which generally refers to providers or provider and professional organizations. In a survey of 200 U.S. pediatricians conducted in October 2024, about 3/4 of pediatricians reported their practice had offered a long-lasting monoclonal antibody. Over 90% of pediatricians agreed or strongly agreed that long-lasting monoclonal antibody is safe for infants is effective against severe RSV disease. They felt confident discussing and recommending the immunization, and they felt comfortable co-administering this immunization with one or more vaccines in a single visit. RSV prevention through long-lasting monoclonal antibodies has been endorsed or recommended by national provider and professional organizations, including but not limited to the American Academy of Pediatrics, the American Academy of Family Physicians, and the National Foundation for Infectious Diseases. The work group felt that immunization with clostridioides is acceptable to key stakeholders. The next domain is feasibility. Data presented here will inform whether clostridioides is a feasible intervention to implement among all infants less than 8 months of age, born during or entering the first RSV season. The VFC program is a federally funded program that provides immunizations at no cost to children who might not otherwise be anticipated to be vaccinated due to inability to pay. If ACIP votes to include clostridioides in VFC, it would consider the second monoclonal it would become the second monoclonal antibody to be added to the program. There are several implementation pros and cons to consider. Clostridioides is a single-dose product administered regardless of the infant's weight, which can simplify delivery. Stocking clostridioides may be challenging for providers who also need to stock nirsevimab for high-risk children aged 8 through 19 months entering their second season. Some providers may prefer to stock only one RSV monoclonal. In a 2024 survey of pediatricians regarding challenges they experienced or anticipated experiencing when offering long-lasting monoclonal antibody, the 3 most commonly reported challenges after parent caregiving concerns around safety were: first, challenges knowing maternal RSV vaccination status to determine infant eligibility, which was reported by 34% of all pediatricians. Second, financial burden in purchasing the product. And third, challenges with reimbursement from private healthcare insurance. The majority of the group felt that clostridioides is, or probably is, feasible to implement. The next domain is resource use. Here I will present data intended to help the committee address whether clostridioides is a reasonable and efficient allocation of resources. A cost-effectiveness model was conducted by the University of Michigan and CDC. The model is built off of methods and inputs that were selected to model the cost-effectiveness of nirsevimab. The model cost-effectiveness of clostridioides, to model the cost-effectiveness of clostridioides, investigators updated key inputs, including effectiveness, its waning trajectory, and anticipated cost per dose. On this slide, you can see the results of the modeled base case scenario for an annual birth cohort in which 50% of infants are immunized with clostridioides, compared to an annual birth cohort in which only palivizumab is used among eligible high-risk infants. In this scenario, it's approximated that the following events will be averted: 120,000 outpatient visits, 43,500 emergency department visits, 20,000 hospitalizations, 4,500 ICU admissions, 20 deaths, and almost 3,500 quality-adjusted life years that would be gained. Examining the incremental cost-effectiveness ratios, or how much it costs to prevent a single outcome, in this model is estimated to cost roughly $3,000 to prevent one outpatient visit, $8,200 to prevent one emergency department visit, $17,500 to prevent one hospitalization, and $80,000 to prevent one ICU admission. And finally, $104,500 per quality adjusted life year gained. I also want to highlight that we did extensive sensitivity analyses looking at a broad range of inputs, which is described on this slide. Overall, clostridioides is cost-effective under standard U.S. thresholds in the range of $100,000 to $150,000 per quality. However, ICRs depend heavily on model inputs for inpatient costs, quality of life losses, and clostridioides costs.
The majority of the work group felt that clostridobamab use among all infants under 8 months of age born during or entering the first RSV season is or probably is a reasonable and efficient allocation of resources at an average cost of $458 per dose. I will now summarize the work group discussions, considerations, and interpretation of the data. The work group felt the phase 2b/3 trial of clostridobamab demonstrated high efficacy for prevention of severe RSV through 150 days. The work group noted that serious adverse events appeared balanced between clostridobamab and placebo arms. At the same time, they acknowledged that rare events are unlikely to be detected in a trial of this size. The work group discussion also highlighted the following. Although clostridobamab has demonstrated a shorter half-life than nirsevimab, the efficacy of clostridobamab against severe RSV appeared sustained through 150 days. Differences in trial endpoints made direct comparisons between the two products challenging. A head-to-head trial would be needed to directly assess comparative efficacy. The work group highlighted the benefits of multiple long-lasting monoclonal antibody products and multiple manufacturers. This diversification offers key advantages. If RSV develops resistance to one product, or if there's a supply chain issue, another option remains available. It may also encourage price competition, potentially lowering costs over time. Finally, RSV is the leading cause of hospitalization in infants, and this burden can be reduced through immunization. However, to have meaningful public health impact, timely administration is essential. For infants born outside of the RSV season, high uptake prior to season onset is critical. For infants born during the RSV season, administration should be within the first week of life, ideally during birth hospitalization. When asked, what is the balance between desirable and undesirable effects? The work group concluded that the desirable consequences clearly outweigh the undesirable consequences. And in the final poll, when asked, should clostridobamab be recommended for all infants less than 8 months of age born during or entering their first RSV season, the work group unanimously supported recommending the intervention. I would like to, again, thank the many collaborators who contributed to this presentation, including both experts at CDC and external experts. Kayasa, Chair, would you like to move on to the clinical considerations? Okay. You queue up the next presentation, please. Next, I will discuss the proposed clinical considerations for clostridobamab. As a reminder, clostridobamab was approved by the FDA earlier this month. The following slides refer to proposed clinical considerations for clostridobamab if recommended by ACIP. I will discuss the workgroup considerations and interpretations of uptake, safety, effectiveness, and impact studies, and then review clinical considerations, including clostridobamab, recommendations compared with nirsevimab, and clostridobamab storage, handling, and administration. To summarize the effectiveness, uptake, and impact data, nirsevimab was effective against RSV-associated ED encounters, hospitalization, and critical illness among infants in their first RSV season. Maternal vaccination was effective against RSV-associated ED encounters and hospitalizations. An estimated 50% of infants were either born or vaccinated, were either born to vaccinated mother or received nirsevimab. Compared with prior RSV immunization introduction, RSV-associated hospitalization rates were reduced by 30 to 40% among eligible infants and by half among infants aged 0 to 2 months. The work group noted The impact of RSV immunizations to decrease severe RSV disease in infants during the 24-25 RSV season in the RSVNet and NVSN networks is clear. Increasing uptake is important in order to further reduce burden of RSV disease. Higher impact has been seen in other countries that have attained higher uptake of these immunizations. It is important to maximize availability of RSV immunizations, including providing infant RSV antibody during the birth hospitalization. The increase in birthing hospital enrollment in the VFC program is important, and challenges remain, and we want to continue to increase that. Continuing increase enrollment. To summarize the FAERS database, post-marketing adverse event reporting and error reporting with nirsevimab, during the reporting period since approval in March 31st, 2025, the most frequently reported adverse events involve patients who developed RSV infections despite prior receipt of nirsevimab and included signs, symptoms, or complications of these infections. No product safety labeling updates have been made since serious hypersensitivity reactions with nirsevimab were added on February 23rd, 2024. No additional safety signals have been identified at this time. Errors involving incorrect nirsevimab dose or incorrect product continue to be reported. FDA will continue routine pharmacovigilance of nirsevimab. Earlier, VSD nirsevimab safety study is presented. It included almost 40,000 infants that received nirsevimab during the 24-25 season and used a self-controlled risk interval study methodology. No increased risk observed for seizures, immune thritis, thrombopedia, drug reactions, sepsis, or fever were observed. No cases of anaphylaxis and 18 cases of allergic reaction were reported, primarily hives. The work group found that FAERS and VSD safety data are reassuring and emphasize that continued monitoring of safety is important. To summarize the VSD maternal vaccine study, the study matched a cohort of 14,000 pairs of vaccinated, unvaccinated pregnant women. No increased risk was observed for most outcomes. An association of maternal RSV vaccine and hypertensive disorders of pregnancy overall and preeclampsia was found. The severity of HDP was similar among vaccinated and unvaccinated. VSD noted that there was potential residual confounding, for example, including parity of the propensity matching and outcome misclassification due to the difficulty in determining the timing of when HDP first occurs and the lack of chart review. The work group felt that overall study findings were reassuring, including the lack of association of preterm birth and vaccination. The work group continues to feel that benefits of maternal RSV vaccination clearly outweigh the potential risks. The work group was split on the importance of the association of vaccination and hypertensive disorders of pregnancy. Some were not concerned about this association since the effect was small, and there was no increased severity in vaccinated versus unvaccinated women with hypertensive disorders of pregnancy, and no overall association of vaccination with preterm birth. The American College of Obstetricians and Gynecologists was in agreement with this opinion. Clostridobamab is a long-lasting monoclonal antibody manufactured by Merck. It is a type of passive immunization. It is administered as a single dose of 105 milligrams in a 0.7 milliliter syringe, with the same dose recommended for all infants born during or entering their first RSV season, regardless of weight. Transitioning now to clinical considerations, the recommendations for clostridobamab and nirsevimab are to be the same for use in infants younger than 8 months born during or entering their first RSV season. There is no preferential recommendation for use of clostridobamab versus nirsevimab. However, only clostridobamab is recommended for children ages 8 through 19 months who are at increased risk of severe RSV disease and entering their second RSV season. This is because clostridobamab has not yet been approved for this age group or indication. Infants eligible to receive nirsevimab when entering their second RSV season could have received nirsevimab or clostridobamab for their first RSV season. There is no effectiveness or safety concerns for using clostridobamab for an infant's first RSV season and nirsevimab for their second RSV season. For the proposed use of RSV antibody immunizations in infants, meaning either nirsevimab or clostridobamab, these recommendations are largely unchanged from current nirsevimab recommendations. One dose is recommended for infants younger than 8 months of age during or entering their first RSV season. Meaning the administration window is during October through March in most of the continental United States. If the mother did not receive RSV vaccine during pregnancy, the mother's RSV vaccination status is unknown, or the infant was born less than 14 days after maternal RSV vaccination. RSV antibody may be considered for infants born to vaccinated mothers when infants are in their first RSV season and born to mothers who may not mount an adequate immune response to vaccination, born to mothers who have conditions associated with reduced transplacental antibody transfer, for infants who have procedures leading to loss of maternal antibodies, or for infants with substantially increased risk for severe RSV disease. Today's focus has been on infant RSV antibodies. However, there are 2 immunization options to prevent severe RSV in infants. Most infants will not need both maternal vaccination and RSV antibody. Pregnant women with their healthcare provider should choose one of the options. Maternal RSV vaccine is recommended during September through January, and infant RSV antibodies are recommended during October through March. Optimal timing for infant RSV antibody administration is shortly before season for those babies who are already born before October. In jurisdictions with differing RSV seasonality, providers should follow state, local, or territorial guidance on the timing of administration. Errors have been reported of giving RSV immunization products to the wrong population. The only RSV immunization to be administered to infants is an RSV antibody. The RSV vaccines, including Abrysvo, Arexvy, and Mresv, should not be given to children. Only Abrysvo should be given to a pregnant woman. Arexvy and Mresv should not be given to pregnant women. Older adults can receive any of the 3 approved RSV vaccines. RSV antibodies should not be given to pregnant women or older adults. Regarding clostridobamab or nirsevimab and palivizumab, if clostridobamab or nirsevimab is given to an infant or a child, then palivizumab would not be recommended for the same RSV season. Clostridobamab administration will be the same as for nirsevimab. It will be given as an intramuscular injection to the vastus lateralis muscle of the anterior lateral thigh. The gluteal muscle should not be used. Simultaneous administration of infant RSV antibodies with vaccines is acceptable. Clostridobamab storage and handling recommendations are to store the product at refrigerated temperatures, used within 48 hours of removing from the refrigerator. Clostridobamab should not be frozen, should not be shaken, and should be protected from light. The proposed recommendation to report suspected adverse events after clostridobamab mirror those for nirsevimab. If RSV antibody is administered alone, please report suspected adverse events to MedWatch. If RSV antibody is administered simultaneously with any vaccine, please report suspected adverse events to the Vaccine Adverse Event Reporting System. Additional reporting to MedWatch is not necessary. Thank you.
Thank you. And the next thing is to propose recommendations.
Yes, please.
So yeah, we're saving questions for probably tomorrow.
Okay. The first proposed, sorry, Dr. Zadeh, reject me? Okay. The first proposed recommendation, ACIP recommends infants aged less than 8 months born during or entering their first RSV season who are not protected by maternal vaccination receive 1 dose of clesrovimab.
The proposed recommendation for the VFC resolution is to approve the updated Vaccines for Children VFC resolution for the prevention of RSV.
And do you have the text of that proposed resolution?
I do. There's a slide set that I need to go through that shows updates to the VFC resolution update. Is that after this? Okay. So I'm going to now go through the updated VFC resolution update. And so what you'll see first is that the changes to the currently approved VFC resolution language are going to be shown in orange font, and the existing language is shown in black font. So the purpose of the resolution is to update the resolution to include an additional RSV long-acting monoclonal antibody. The first component of the resolution addresses RSV maternal vaccine, and there are no changes to eligible groups. There are no changes to the recommended schedule and intervals. However, the individual product name was replaced with a product group name because now there are 2 products available. There are no changes to the dosage, contraindications, or precautions. The second component of the resolution has been retitled to refer to a product group name rather than an individual product name. The eligible groups are unchanged. The list of children at increased risk for severe RSV disease is unchanged. For the recommended schedule and intervals, information about nirsevimab is unchanged. However, a new row has been added to the table to reflect the clesrovimab, the newly licensed RSV long-acting monoclonal antibody. As previously discussed and noted in this table, the product is not indicated for the second RSV season. Table notes have been added to the table of reference alternative products, providing the definition of long-acting monoclonal antibody and to provide a link to the published information with additional details about the timing of administration. The language below the table has been updated to replace the individual product name with the product group name. There's no changes to the dosage, contraindications, or precautions. And the final slide notes that ACIP recommendations published within 6 months following the resolution are incorporated by reference into the resolution other than for the eligible groups. Thank you.
Thank you very much. And again, we will leave questions for later, and I think we can now go on to the public comments. And I would like to apologize for the delay. Thank you for patiently waiting. We have 10 persons who will comment, and you have 3 minutes each. And the first person to comment is Kim McRosenberg. Please go ahead. Do we have Kim McRosenberg on the line?
If you're speaking, you're on mute.
Yes, I apologize. I was on mute. Thank you very much. I appreciate the opportunity to address you this afternoon. I am General Counsel at Children's Health Defense, a nonprofit dedicated to safeguarding children's health, and I'm here to address a critical issue, the misuse of ACIP's best practices guidelines by many states, including large states like California and New York, to recklessly restrict medical exemptions for school vaccine requirements where a treating physician has identified a risk. ACIP guidelines define contraindications and precautions broadly as conditions that increase risk of serious adverse reactions or compromise vaccine efficacy. ACIP has acknowledged these guidelines are not exhaustive and cannot define all reasons a child may need a medical exemption. Yet many states and schools are overriding treating physicians' clinical judgment, limiting exemptions to only those based on reasons explicitly listed in the non-exclusive tables, or going even further, accepting only anaphylaxis as a valid exemption, ignoring other serious risks or reasons that a vaccine might need to be deferred. With many new members in place, the ACIP must now act to prevent continued harm. I urge you to amend the best practices guidelines or issue clear public statement on your website affirming that CDC is not authorized to give medical advice about what an individual child may need to stay safe, that the guidelines are not exhaustive and cannot define every reason for a medical exemption, and only treating physicians using CDC guidance, other evidence, patient and family history, their clinical judgment, and any other information relevant to an individual child's health should determine if an exemption is warranted. Without your action, misapplication of the ACIP guidelines will continue to have devastating consequences. One of the many examples is the case of Sarah Doe, a 16-year-old from New York with acquired von Willebrand's disease, autoimmune hypersensitivity, unexplained periodic paralysis, and uncontrollable anaphylactic rash, a history of severe vaccine reactions. 6 licensed physicians certified that a third hepatitis B dose could endanger her life, yet her school district rejected these exemptions, demanding anaphylaxis within 15 minutes of her last dose as the sole criteria. She desperately wanted to attend school and even tried to get vaccinated at a walk-in clinic after she was denied medical accommodation and kicked out of school. But even that clinic physician found her ineligible because of her condition. Still, the school and state maintain that she cannot be accommodated from taking that third dose of hepatitis B vaccine because her conditions are not listed by ACIP as clear contraindications. She's not alone. CHD and the attorneys with whom we work get calls like this every week. Children not only are being deprived of federally protected disability rights, but some have been badly injured after they were forced to take vaccines against medical advice so they could attend school. And physicians are harmed by this narrow reading, as some of these states are using the ACIP guidance as a cudgel to threaten doctors' licenses if states do not think a recommended exemption meets criteria. Clarification of the guidelines will protect children and ensure physician autonomy. Your timely action is needed this summer to safeguard vulnerable students. Thank you for your time and consideration.
Thank you very much. And the next comment is from Chrissy Giuliano.
Good afternoon. Thank you for the opportunity to provide public comment today. My name is Chrissy Giuliano, Executive Director of the Big Cities Health Coalition, which is made up of leaders from 35 of the country's largest metropolitan health departments. We are disappointed in Secretary Kennedy's recent decision to dismiss without cause all 17 prior ACIP members. Among them was my colleague and BCHC board member, Dr. Mashika Roberts, Health Commissioner for the City of Columbus, who is scheduled to join the committee in July. Local health departments play an important role in vaccination. So many people in communities across the country go to their health departments, not just for vaccines, but to get their questions answered and concerns addressed by people they know and trust. Our members and their colleagues across the country take this responsibility seriously, and they do it every day. In the same way that residents look to public health leaders for vaccine advice and guidance, they look to ACIP for vaccine recommendations. But with all due respect to the new committee members, there is genuine worry about whether that will remain the case. For more than 60 years, ACIP has provided independent, science-based, nonpartisan, and objective vaccine recommendations. Clinicians, health departments, and families across the country rely on these recommendations. At a time when trust in public health is already low, the sudden dismissal of an entire committee will only cause additional confusion and distrust. Vaccines are one of public health's greatest accomplishments. They prevent disease and save lives. Before widespread vaccination, nearly 1 in 5 American children died before their 5th birthday. The most common cause was infectious diseases that are now preventable. For a time, because of advances in vaccine science and immunization rates, diseases like measles and polio were eliminated in this country. But as we've seen with measles over the past few months, vaccine preventable diseases are making a comeback, and some children have already died as a result. ACIP recommendations are critically important. They ensure that vaccinations are covered by most insurance plans and that children without insurance coverage can still receive them. The Big Cities Health Coalition is deeply concerned that many routine vaccines may soon become inaccessible or unaffordable for millions of Americans if ACIP makes changes based on ideology rather than science. The stakes are simply too high to let that happen. We urge and expect the new members of this committee to do what ACIP has always done and what health department officials do every day. Follow the science, support the evidence, and make decisions that are in the best interest of the public's health. Thank you again for the opportunity to provide comment.
Yes, thank you. The next presenter is Mary Koslap-Petrako. Please go ahead and welcome.
Thank you. Good afternoon. I'm Dr. Mary Koslap-Petrako, pediatric nurse practitioner. I've been a PNP for over 30 years, and I'm grateful for this opportunity. The scientific and medical community and public health communities are losing faith in the ACIP because of the bogus reasons that were used to dismiss the 17 members. These members have the expertise to design vaccine studies. It is clear that the current members do not have this expertise. VAERS data has clearly been misinterpreted by this committee. It only offers signals and does not prove causality. The vaccine safety data link is where the actual studies are conducted. And to say that children do not need COVID vaccines is a mistake. I have children in my own practice who have long COVID and were not vaccinated. The vaccine needs to be available for those who want it. Parents have been totally misled by the mis and disinformation that they are seeing on the internet, among other places. They lose faith in their primary care providers and do not seek their advice. I pride myself on answering the questions my patients' parents have. The real enemy here are the viruses and bacteria that are no longer familiar to parents because of the success of vaccines. If the vaccines become less available or used less because of confusion and fear caused by these unscientific changes and the rhetoric coming from DHHS, people will become very aware of the presence of these diseases because they will specifically see children suffer and die. I live on Long Island in New York, and I've walked through old churchyards, and I saw all row after row of tiny headstones of children who died before their 5th birthday. I saw older children's headstones as well. The causes of their deaths were noted on the stones: measles, polio, tetanus, diphtheria, whooping cough. Do we really want to witness this again? I will leave it to all of you to explain to the parents why their children did not have access to life-saving vaccines. My own mother had polio in 1923 and developed post-polio syndrome later in life. My sister's immune system was permanently damaged from measles, which she had in 1959. I do not want other families to suffer as my family has. My own children and grandchildren all had these vaccines, and they have grown up safe and healthy. I want all children to have the same opportunity to grow up safe and healthy and free from vaccine-preventable diseases. I'm a VFC provider. Please continue to offer these vaccines so that all children have access to life-saving vaccines. Thank you for this opportunity.
Thank you for commenting, Dr. Koslap-Petrako. The next person is Marcia Cohen-Sakai.
Hello. First, a question. Was it necessary to purge this panel of all 17 duly vetted experts? Was it because, according to Dr. Macquarie, ACIP is a kangaroo court that rubber stamps? Or was this purge unjustified and unthinkable? If Senator Cassidy is concerned about a lack of expertise and anti-vaccine bias among the newly appointed members, how can I, a layperson, consider it reasonable for all 17 members whose expertise is indisputable to have been terminated? This week, the California Medical Association, the American Medical Association, and more than 100 national and state medical organizations submitted a letter to the HHS Secretary demanding the immediate reinstatement of all 17 ACIP members. Their removal threatens public confidence in vaccines and risks the destruction of the success vaccines have made in controlling preventable diseases and saving lives. Over the years, ACIP experts have provided evidence-based vaccine recommendations for FDA-approved vaccines through a transparent public process. They have been vetted and appointed through a transparent public process. Without them, we are left with a vacuum filled with doubt and confusion that will likely lead to untold preventable illness, disability, and death among healthcare providers and patients of every age and vulnerability, along with all the people they live with, work with, study with, and care for. ACIP recommendations determine insurance coverage decisions, so we need vaccine experts who will ensure widespread, unhindered access to FDA-approved vaccines like flu, measles, HPV, RSV, and COVID. Even as we speak, the US is beginning a summer wave of COVID, and measles outbreaks are increasing globally. No child should die of measles or have their immune system shattered. No one should have their life devastated by acute or long COVID. The safe and effective vaccines we have help prevent such tragedies. The scientific evidence has been clear for a very long time. Our trusted vaccines have proven themselves to save lives and prevent severe disease, disability, and death. We need the expert recommendations of the ousted ACIP members to ensure the continuity and accessibility of vaccine protection in the United States. Thank you.
Thank you for taking the time to speak to us. The next presenter or commenter comes from Caroline Brown. Please.
Sorry, I was muted. My name is Dr. Caroline Brown. I'm a general pediatrician practicing in North Carolina. I've cared for children in this community for nearly 2 decades, and I've seen what vaccine preventable diseases do to otherwise healthy kids. I've treated infants with blue faces, gasping for breath from RSV and pertussis, children in the ICU paralyzed, brain damaged, or missing limbs from illnesses we now have vaccines to prevent. When I trained in the early 2000s, we routinely performed spinal taps on infants with fever to rule out meningitis. But thanks to vaccines like Hib and pneumococcal, most of those children were spared devastating outcomes. My older colleagues have countless stories from the 80s and 90s of children who weren't so lucky, whose bodies were ravaged by these diseases and whose suffering still haunts those doctors decades later. Now, 18 years into my own practice, I watch with heartbreak as the public's trust in vaccines erodes. Ironically, just yesterday, the first confirmed case of measles was announced in my own state, here in my own county. So I've spent the past 24 hours responding to panicked parents worrying about their young children. We must acknowledge that measles spread throughout our country is our reality today only because of the fear-mongering and pseudoscience that has overtaken our country. Remember, measles was completely eradicated from the United States 25 years ago and is back now because of declining vaccine rates fueled by misinformation that is not only allowed, but amplified by voices of some of you sitting on this very committee. The parents of the children I care for are frightened watching health policy shift from evidence to ideology and from science to self-interest. I understand skepticism. Medicine must earn public trust, but let me be clear. Vaccines are the most rigorously studied, safest, and most effective medical intervention of the 20th century. There is no legitimate scientific debate about the risk versus benefit of vaccines. nor is there any link between vaccines and autism. Furthermore, the fact that thimerosal is on the agenda for tomorrow's meeting is particularly concerning, given that it was removed from virtually all routine pediatric vaccines in this country over 20 years ago. As American citizens, pediatricians understand and respect the deep value our country places on individual freedom. We understand for politicians, it's easiest to say, let the people choose for themselves. But the choice stops being personal when one family's decision to not vaccinate means another child they pass in the grocery store becomes infected with a potentially deadly disease. As Dr. Paul Offit says, there is no risk-free choice. The danger isn't the vaccines, it is the disease. Pediatricians are passionate about vaccines because we have witnessed the horrific suffering that can occur in their absence. But like a gardener who thinks no weeding is needed when there see no weeds, without proper tending, if herd immunity declines, these diseases will crop back up and the damage will be devastating. Thank you.
Thank you for your comments. The next comments are from Alexandra Jones Packham, please.
Hello. My name is Lexi Jones Packham. I just graduated medical school and I'm starting my residency in internal medicine and pediatrics right now, actually. In undergrad, I majored in microbiology with a particular interest in immunology and vaccines. I'm also pregnant and will be due in the middle of respiratory season. It's a very exciting time for any new mom, but as a new pediatrician as well, I have some extra perspective on how dangerous respiratory season can be for newborns. In medical school, I rotated for several weeks in the pediatric ICU during the winter, and I saw so many bronchiolitis cases, specifically from RSV and influenza. Unfortunately, we don't have many effective treatments against these respiratory viruses, so we just have to offer all the supportive care that we can while their body fights off the infection. As a doctor and as a future mother, it is so hard to watch these babies struggle to survive these infections when we have vaccines and the RSV antibodies that are so effective at preventing these infections. I believe you heard the evidence today on the effectiveness of some of these vaccines and antibodies. And anecdotally, every patient that I saw during my time in the pediatric ICU with a respiratory infection had not been vaccinated against the pathogen that they were infected with, whether because of parental choice or because they were too young to qualify for that vaccine yet. Children who do receive these vaccines are much less likely to get severe disease from these infections. As a soon-to-be mother and as a pediatrician, I will be electing to get the RSV, flu, and COVID vaccines during my pregnancy and will ensure that my child gets the flu and COVID vaccines as soon as they're eligible, as well as the antibodies if it's indicated for them. I want to make sure that all of my patients' parents have the opportunity to discuss these vaccines with me as their pediatrician, and especially to have these covered by insurance if they do choose to get them. Thank you for your time.
Thank you for those comments. And the next presenter is Rosalie Bright. Please go ahead. We cannot hear. Are you on mute? So we're going to go on to the next comments from Diana Figueroa.
Hello, good afternoon. I want to say thank you for allowing me the time to speak today. My name is Diana Figueroa, and I have been a nurse for 16 years as an LVN. I've specifically been a pediatric LVN for 14 of those years. I believe I can speak for many of my fellow LVNs and LPNs that the termination of the 17 ACIP members is a poor decision, as these members have gone through a thorough vetting process and have now and shown how knowledgeable and intelligent they are in making vaccine decisions for our country using evidence-based science. Our country and healthcare organizations have valued all the hard work and time that goes into the thoughtful decisions that the 17 ACIP members have made in the past until April of this year. The recent decisions made without the consultation of ACIP shows the danger that our country will be facing when the non-medically trained individuals and those who have not been vetted appropriately attempt to make decisions and recommendations that are not at the best interest of our country as a whole, using evidence-based science, but only making decisions based on their own opinions and for the 0.1% of people who do not agree with the ACIP's previous decisions. The current lack of transparency is very troubling. I also believe that that decisions like shared clinical decision-making is a major barrier preventing LVNs and LPNs like myself from providing requested vaccines to patients, which then end up leading to delays in care. Our healthcare system is very overwhelmed with needs from our patients, and as we believe that preventative care is essential to prevent costly hospital stays from chronic and non-chronic illnesses. In providing immunizations as a preventative care measure, there should never be barriers to providing a life-saving vaccine for any communicable disease that can be prevented with an available vaccine in our country. I ask that the FDA and the CDC not create more barriers in providing valuable and important vaccines to our patients, from our pregnant women to our newborn babies, to our immunocompromised and our elderly who are all at high risk, but also to our healthy individuals like myself who desire to be vaccinated to protect my friends and family around me, as well as any patients I may encounter. We share the sentiments across many medical organizations to ask to reinstate the terminated ACIP members to full capacity within the ACIP so that they can continue the great work they have done in the past, and remove the recently unvetted appointed members, but also to leave the current pediatric and adult vaccination recommendations as they are, returning the COVID vaccine recommendations for our pediatric patients and our pregnant individuals to the previous recommendations, as it has proven to be successful in disease prevention. Thank you for your time.
Thank you for those comments, and we'll go now to Amy Hardin. Please go ahead.
Hi, I'm Dr. Amy Hardin. I'm a pediatrician in private practice just outside of Atlanta in Woodstock, Georgia. I trained at Emory from 1990 to 1993, spending 2/3 of my time at Grady Hospital and the rest right across the street at Eggleston from the CDC. Back then, before we had Haemophilus influenza type B and pneumococcal vaccines, we admitted 5 to 10 children every night under the age of 3 with fevers above 101 and no clear sores. These children underwent full septic workups, including blood cultures, catheterized urine samples, and then a spinal tap to check for life-threatening infections like meningitis and sepsis. I remember examining gram stains in the microlab at Grady myself, searching for the telltale bacteria, which we were dreading to see, Hib and strep pneumo. Before the Hib vaccine, 1 in 200 kids under the age of 5 developed invasive Hib disease. These infections included sepsis, epiglottitis, cellulitis, and meningitis, and they didn't discriminate by income. Healthy, cherished children from all walks of life suddenly became critically ill. Many died, others survived, but were left with lifelong disabilities, deafness, cerebral palsy, severe learning challenges, and many of the kids I cared for with cerebral palsy in the first few decades of my career developed CP due to meningitis. Why do I sleep better on call now? Because these vaccines work. I have not seen a single case of Hib or pneumococcal meningitis or sepsis since 1999, thanks to vaccines against Hib and pneumococcus. Check out the graphs in the CDC Pink Book of post-vaccine diseases. The slopes with the precipitous drops of disease post-vaccine entry are amazing. And how do I remember this date of 1999? It's because this is the last patient's funeral who I went to in 1999 who died of a vaccine-preventable disease. He was a lovely 2-year-old little boy whose mom missed his 2-year-old checkup because he was sick, and then she got busy and forgot to reschedule. He died 3 months later from pneumococcal sepsis. There's nothing more tragic than the loss of a child from a vaccine-preventable disease or a child-sized coffin with a large fire truck on it. I'll remember that funeral forever. And to show just how well vaccines have worked since then, in my group of 9 pediatricians, only 2 of us have seen children die of vaccine-preventable diseases. Because we're the 2 oldest docs, vaccines work. But sadly now, due to vaccine hesitancy and misinformation on the internet, we are seeing these infections again and again, and with other germs such as measles and whooping cough. Children are dying. My colleagues in Atlanta are again treating children with Hib meningitis. What do these heartbreaking cases have in common? These children were unvaccinated due to usually scary misinformation on the internet. You are now the decision makers in your new role in the ACIP who safeguard America's children. They are your responsibility. And mine too. Please don't let us go backwards. Don't make my job a more difficult one. Having to give parents in my practice horrible news when their children develop or expose these horrible or preventable diseases. We are too smart of a country to relive the tragedies we pediatricians have worked so hard to prevent. Vaccines are safe, effective, and save lives. Let us not forget this. Thank you.
Thank you for those comments, Dr. Hardin. And the next person is Adriana Williams.
Hello, everyone. I'm U.S. citizen Adriana Williams. Thank you all for being here and allowing me to speak today. I will start off by reminding us of the Hippocratic Oath, which stated firmly that doctors will avoid harmful treatments for their patients. Yet it's been noticed that doctors, CDC personnel, and their colleagues have provided ever-increasing access to harm for patients nationwide and even worldwide. The vaccines in discussion today and tomorrow are of no good enough health benefit and are in no way safe enough for members of the public. There are much more safer and effective natural treatments and preventatives. Therefore, vaccines must be abolished immediately. Vaccines are known to be a bioweapon mechanism. Some don't even know it. Evidence shows that many are systemically, medically harmed by all vaccines, and the damage has been shown to be done cumulatively over time and in negative interaction with ingredients and adjuvants with bodily functions. You need to do due diligence to address this issue with more integrity than what we have seen. Therefore, all vaccines should be abolished in its entirety till the broken system can be fixed. This is serious. VAERS data reports that over 8,000 reports were filed, and with over 70 deaths following RSV vaccination. Please do not ignore the evidence, the data. It shows RSV vaccines are dangerous. RSV vaccines are harmful. For example, look into VAERS report ID 28011021. A person passed away following an RSV vaccination. Sadly, that is just one out of many. You look at most of any US currency, such as a dollar or coin, a part of our legacy, you'll see an emblem which transcribes E pluribus unum, which translates to one out of many. If you listen to the Stop the Shots community on X, the ones out of many, such as the vaccine injured, they speak. They share what is happening in reality, that people are dying and people are hurting, and they want help and restitution from individuals such as yourselves having heroic potential. God bless us all, and may you all stand for your duty of the Hippocratic Oath to do no harm by not ignoring the data that shows you must stop all vaccines from being administered starting today and tomorrow with the RS vaccination votes. Start with today and tomorrow and make your legacy one of a hero for present and future generations by beginning to save the one out of many from being harmed by vaccines. Please stop the shots. Recommend them to be stopped, all of them. Now, help the vaccine injured. And thank you.
Thank you for sharing that with us. We're going to go back and see if Rosalie Bright is available now. I don't think that is the case unless you're on mute.
Hi.
Hello?
Can you hear me now?
Can you speak a little bit louder? It's very weak, very low sound.
So can you hear me now?
That's better, thank you.
Thank you. Sorry about these problems. Hi, I'm Dr. Rosalie Bright. I was a doctoral level epidemiologist at the Food and Drug Administration for most of my career. While there, I witnessed many instances when staff and managers wanted to advocate for decisions that, quote, felt right, although the data supported another decision. The importance of scientific data was sustained by the requirement that all of the internal and advisory experts with input needed to document their reasoning for the archived record. I learned from and became able to trust the input of experts in different disciplines who worked on the same regulatory decisions as I did. I believe most of the decisions produced by the system were valid and well supported. Now that I'm retired, my trust in decisions based on confidential data has been shaken in the past several months because of mass federal firings, intimidation, overruling of scientists by the political appointees, and now radical changes to the tried and tested advisory committee system. I can still read and analyze the public research literature to see if I agree with federal decisions. Being elderly, I may lose that ability due to my own illness or censorship of publications and decisions. I won't be able to act in my best interest if the federal government restricts my access to treatment and preventive measures. Federal guidance is crucial because most people, including healthcare professionals, can't or won't read the scientific literature for themselves and rely on the guidance from FDA and CDC. My requests are: 1, continue to consider long COVID incidence and severity when recommending COVID-19 vaccine schedules. 2, recommend universal access to FDA-approved COVID-19 vaccines 3 times per year. 3, call for development of more effective COVID-19 vaccines. 4, provide ACIP meeting materials to the public at the same time as to the ACIP members and allow at least a week to file responsive written comments. 5, provide summaries and discussion of public comments at the meetings. 6, allow more and longer oral public comments at the meetings. 7, reinstate the 17 ACIP members that had been let go. 8, require ACIP members to show evidence of the ability to perform science-based assessments of reports and studies. 9, bar ACIP membership to those who refuse to follow established principles of clinical and human research ethics. People who conduct human research have generally been required to learn the applicable publicly available ethics guidelines before being allowed to begin their study. Anyone who says they support comparing a vaccine that has already been approved or similar to one that has been approved to an inert placebo is advocating for the violation of the basic ethic against withholding vaccines that are known to work. Such people have no business being on ACIP or in or leading any HHS organization. More details are in my written submission. Thank you.
Thank you, and thanks you to all 10 members of the public for taking the time to speak to us and to give us your comments. So this concludes the public comment period. So again, thank you very much, all 10 of you. We did not finish the agenda items for the RSV vaccines, but it is now 5:30, so it's time to adjourn for today. And we will reconvene here tomorrow at 8 o'clock in the morning. So I'm looking forward very much to see all of you then, and for new important scientific discussions. And as the last word today, I was to remind everybody that the purpose of this committee is to follow evidence-based medicine, and that is what we will do. And that is the only way to restore integrity and trust in public health. So thank you very much, everybody.